अब थोड़ी सी ज़्यादा होनी चाहिए। तो एक बार दोबारा सभी बोलेंगे, गुड मॉर्निंग एवरीवन। थैंक यू। अब लगा है कि हाँ कुछ चल रहा है, हलचल हो रही है यहाँ पे। सो रिस्पेक्टेड डिग्निटरीज, स्टीम्ड फैकल्टीज, panelists and my dear colleagues, it is truly my honor to welcome you all to the International Hepatopancreatobiliary Association India Midterm Conference 2025 on the theme Mastering Techniques and Perioperative Management in Hepatic, Pancreatic and Biliary Surgery. This conference is more than a collection of lectures and sessions. तो जैसे आपने देखा होगा जब आप नीचे आए हो तो लेक्चर्स और सेशंस वो तो एक इसका अलग पार्ट है। पहला पार्ट आपने देखा होगा कि बहुत सारे स्टॉल्स नीचे लगे हैं। सो यू ऑल मस्ट हैव विजिटेड ऑल द स्टॉल्स। इट इज अ ग्रेट अपॉर्चुनिटी फॉर ऑल ऑफ अस टू लर्न दोज थिंग्स which I think we have missed during our clinical duties. Like there is a one Johnson and Johnson bus. If you go there, अभी किसी ने Johnson and Johnson वाली बस में कोई गया अभी? बाहर जो खड़ी है जेल ऑडिटोरियम के बाहर लगभग 15-20 लोगों ने साइन किया, मैंने देखा उसमें। ऐसे तो नहीं है कि गया नहीं है, गए तो हैं। तो एक हमेशा एक मिसिंग पार्ट रहता है हमारे कि हमारे पास कब वो अपॉर्चुनिटी आएगी जब हम सूचरिंग की टेक्निक सीखेंगे, कब हमारे पास सिमुलेशन के लिए अवसर होगा। तो आई थिंक आज वो दिन है। तो एक बार जोरदार तालियां सभी के लिए जिन्होंने इस सुंदर कॉन्फ्रेंस को ऑर्गेनाइज किया है। और हमारे बीच में हमारे बहुत ही सीनियर हमारी नर्सिंग सुपरिटेंडेंट मैम, डीएनएस मैम, एएनएस मैम हमारे साथ इस कॉन्फ्रेंस में मौजूद है और उनके सम्मान के साथ आई थिंक ये कॉन्फ्रेंस शुरू होनी चाहिए, क्योंकि उनके आशीर्वाद के बिना ये ऐसी बड़ी चीज़ें होना संभव नहीं है। और ये अपने आप में यूनिक कॉन्फ्रेंस इसलिए भी है, जैसा कि आपने नीचे देखा कि डायरेक्टर साहब ने क्लियरली बोला कि यहाँ पे डॉक्टर्स और नर्सेज एक साथ हैं। आई थिंक हमने कभी किसी कॉन्फ्रेंस में ऐसा एक्सपीरियंस नहीं लिया होगा। तो इसी ऐतिहासिक कॉन्फ्रेंस को शुरू करते हैं। मैं सबसे पहले स्वागत सम्मान की कड़ी में मैं बुलाना चाहूंगा हमारे नर्सिंग सुपरिटेंडेंट मैम कमला रत्न मैम को। आप मेन हॉस्पिटल में नर्सिंग सुपरिटेंडेंट है। इनके स्वागत के लिए मैं रिक्वेस्ट करूंगा प्रियंका जी से और सुनैना जी से कि वो कृपया करके मैम का स्वागत करें एक टोकन ऑफ एप्रिसिएशन के साथ। धन्यवाद। अब मैं मैम से रिक्वेस्ट करूंगा कि वो अपने जो ब्लेसिंग्स हैं अपने शब्दों के माध्यम से हमारे जितने भी आए पार्टिसिपेंट्स हैं उनके तक आप शेयर करें। मैम प्लीज।
Good morning to all dignitaries, and it is my privilege and honor to address this distinguished gathering at the Ihpba event organized in association with the Nursing Council. Today we come together not just as professional of medicine and nursing, but as one team with a shared mission to bring the highest standards of care of patients with hepatobiliary and pancreatic disease. Nurses are the bridge between science and service, between doctors and patients, between advanced technologies and human touch. In complex procedures such as liver transplantation, pancreatic surgery or biliary intervention. The role of the nursing team is indispensable from pre-operative counseling to post-operative care, from infection control to emotional support. Nursing professionals carry the responsibility of safeguard life with patience, vigilance and dedication. As a superior authority, I urge all us to recognize the need for continuous nursing education, structured training modules and opportunities for leadership in HPB care. Let us work hand in hand with Ihpba to strengthen capacity building, encourage research among nurses and empower them with the latest knowledge and skills. Thank you to all.
थैंक यू सो मच मैम, आपने बहुत ही अपने सुंदर विचार व्यक्त किए कि ये समय की ज़रूरत भी है कि जब नर्सेज आगे आएँ और उनमें एक लीडरशिप का जो एक कंटेंट है वो उनके अंदर इंस्टिल हो और वो अपनी जो भी पोटेंशियल है वो इस कॉन्फ्रेंसेस के माध्यम से पूरे देश और पूरे विश्व को बता भी पाएँ कि वी आर वर्किंग इन द प्रीमियर इंस्टीट्यूट ऑफ दिस नेशन। अब मैं इसी कड़ी में आगे बुलाना चाहूँगा हमारे डीएनएस मैम शोभा संपत मैम को। आप डिप्टी नर्सिंग सुपरिटेंडेंट है एनआई डिपार्टमेंट में। उनके सम्मान के लिए मैं रिक्वेस्ट करूंगा दयानंद जी और रश्मि जी से कि वो कृपया कर आगे आएं और टोकन ऑफ एप्रिशिएशन के साथ आप मैम को सम्मानित करें। और मैम से भी मैं रिक्वेस्ट करूंगा कि वो अपने विजन को, अपने थॉट को हमारे सबके साथ शेयर करें। मैम।
Good morning, everyone. It is a privilege to be here at the Ihpba Conference 2025. I want to congratulate the entire organizing team for their hard work in bringing together this important event on mastering techniques in HPV surgery. Such conferences are not only about sharing knowledge, but also about inspiring teamwork, new ideas, and better care for patients. The special inclusion of a CME for nursing staff shows true commitment to learning at all levels. May this conference be successful, meaningful, and leave a lasting impact on all participants. Thank you.
थैंक यू सो मच मैम। अब मैं रिक्वेस्ट करूंगा इसी कड़ी में आगे डिप्टी नर्सिंग सुपरिटेंडेंट मेन ओटी से मैडम राजेश को और उनके सम्मान के लिए मैं रिक्वेस्ट करूंगा मोहिनी जी और दीपक जी से कि वो कृपया कर आगे आए।
Good morning, all of you, and my senior and participant colleagues. Thank you so much इतना सम्मान और को ऑर्गेनाइज करने के लिए बहुत अच्छा लगा आज मुझे। इसके लिए बहुत बहुत थैंक्स सबको।
और आपके आशीर्वाद से सभी को अच्छा लग रहा है आज इसके लिए भी आपका बहुत बहुत धन्यवाद मैम कि जो आपने मौका दिया सभी ओटी नर्सेस को अपने पोटेंशियल को दिखाने का। इसी कड़ी में मैं आगे रिक्वेस्ट करूंगा मैडम परमजीत कौर जी से। आप मेन ओटी में एएनएस हैं, आप भी कृपया इनके सम्मान के लिए मैं त्रिलोक जी और मदन जी से रिक्वेस्ट करूंगा कि वो कृपया कर आगे आएं और मैडम को आप सम्मानित करें। एक बार जोरदार तालियों के साथ स्वागत होना चाहिए। इसी कड़ी में आगे बढ़ते हुए अब जो सबसे इम्पोर्टेंट कड़ी है इस पूरी कॉन्फ्रेंस की, जो धुरी है, नरगिस मैम, मैं उनसे रिक्वेस्ट करूंगा कि वो आप आए और उनके सम्मान में मैं समीप ज्योति बिस्ली मैडम और नीतू कालिया जी से रिक्वेस्ट करूंगा कि वो उनके सम्मान के लिए आगे आए. समीप. ओके, ही इज नॉट हियर. आप फॉर्मर एएनएस रहे हैं जीआई सर्जरी में और इस पूरी कॉन्फ्रेंस की आप दूरी हैं. मैम आपसे रिक्वेस्ट है, नरगिस मैम आपसे रिक्वेस्ट है कि सबके स्वागत सम्मान में आप थोड़े से कुछ अपने एक्सपीरियंस, क्योंकि ये आसान नहीं होता है ये सब चीज़ें ऑर्गेनाइज करना और करवाना जो अभी तक नहीं हुई है, तो आपका क्या अनुभव रहा, आप कृपया करें.
गुड मॉर्निंग एवरीवन. बहुत साल काम किया, ऑपरेशन थिएटर में किया, ऑलमोस्ट 38 इयर्स, और उसका एक्सपीरियंस मुझे खुद को ऐसे लगता है, या मुझे लगता है आपको भी कभी महसूस हुआ होगा कि एक चलती फिरती लाइब्रेरी की तरह हम काम करते हैं, क्योंकि आपका एक्सपीरियंस है जो आपको आगे लेके जाता है. और ये मेरा बहुत बड़ा सपना था कि हम ऐसा कोई काम करें जिसमें हमें भी आगे आने का मौका मिले. और मैं डॉक्टर डैश का धन्यवाद करूंगी कि उन्होंने हमें अपने साथ जोड़ा, जो कि आज तक नहीं हुआ था, और ये सेकंड टाइम है कि मैं इसको ऑर्गेनाइज कर पाई डॉक्टर डैश के थ्रू. और डीएनएस ऑफिस और सीएनओ ऑफिस के सपोर्ट के बिना तो कुछ नहीं हो सकता, तो उनका भी थैंक यू करूंगी. और हमारे डीएनएस मैडम राजेश मैम पिछली बार तो हमारे साथ नहीं थे, इस बार हैं, तो अच्छा लगा है कि हर किसी को कुछ ना कुछ सीखने को मिला है. और ये इंटरनेशनल लेवल पे चलती है, नेशनल लेवल पे चलती है, और बहुत सारे लोग बाहर से आए हैं और उनका मैं स्पेशल वेलकम करूंगी जो भी दूसरे हॉस्पिटल से आए हैं. कौन कौन बाहर से आए मैं पूछना चाहूंगी, कौन से हॉस्पिटल से? तालियां हो जाएं जरा उनके लिए. एक दिन मैंने कहा था कि बहुत सारे लोग अगर रजिस्टर कर देंगे तो हमें दिक्कत होगी, तो किसी ने बोला, किसी ने नहीं, कनिष्क ने बोला कि एम्स में तो लोग वाइब्स लेने के लिए ही आ जाते हैं. तो मुझे लगता है एम्स की वाइब जो बहुत बड़ी है, यहाँ बैठना, यहाँ खड़े होके बात करना, यहाँ खड़े होके कुछ सीखना, वो ज़्यादा ज़रूरी है. और हर एक नर्स को ये सीखना बहुत ज़्यादा ज़रूरी है कि मैं कहाँ खड़ी हूँ, उसकी मुझे नॉलेज है कि नहीं. अगर है तो उसको अपडेट करना और ज़्यादा ज़रूरी बनता है, ताकि हम सर्जन के साथ हाथ से हाथ मिला के चल सके, हम अपने आप को उनसे कम ना समझें, क्योंकि वी आर अ बोन बैक ऑफ द हॉस्पिटल. नो सर्जरी कैन बी परफॉर्म्ड विदाउट द नर्सिंग स्टाफ. और अगर नर्सिंग स्टाफ इतना ट्रेंड है तो जो सर्जरी वो 2 घंटे में करेंगे, वी कैन कम डाउन टेक डाउन टाइम टू 145 मिनट्स, 15-20 मिनट्स हम जरूर उस सर्जरी में कम कर सकते हैं, अगर हमें सर्जरी के टाइम हर स्टेप के बारे में पता है कि अब क्या चाहिए, रादर देन आस्किंग कि अब आपको क्या चाहिए. मैं हूं तो मुझे लगता है मैं 2 कदम उनसे 10 कदम आगे चलूं ताकि वो टाइम कम हो जाए. और दूसरी बात यह है कि बहुत कुछ मैं एक जनरल नर्सिंग करा हुआ है, लेकिन मैंने जो सीखा है वो पढ़ पढ़ के सीखा है. जब भी पेशेंट की फाइल मेरे हाथ में आती है, कोई भी सर्जरी हो, सबसे पहले मैं देखती हूँ कि पेशेंट ओपीडी में किन साइन सिम्टम से आया. अगर वो साइन सिम्टम हमने पढ़ लिए तो हमें बीमारी के बारे में जरूर पता चल जाएगा कि ये बीमारी किससे होती है. तो थ्योरेटिकल नॉलेज मुझे इससे बहुत ज़्यादा मिली है, और मैं आप सबको भी इनकरेज करूंगी जब भी टाइम मिले प्लीज़ गो थ्रू द फाइल, क्योंकि आपको कभी कभी पेशेंट को किसी चीज़ से एलर्जी है, अगर आपने फाइल ही नहीं पढ़ी तो आपको नहीं पता होगा. एक इंसिडेंट में ज़रूर बोलना चाहूँगी, हमारे इधर सिस्टर हेमा सीनियर नर्सिंग ऑफिसर नहीं है, पेशेंट की फाइल पे लिखा हुआ था कि पैरासीटामोल, एलर्जी टू पैरासीटामोल, और सडनली शी वॉज न्यू अबाउट इट कि पेशेंट इज एलर्जिक टू पैरासीटामोल. बाय द टाइम शी वेंट आउट एंड की केम बैक, पेशेंट को पैरासीटामोल चढ़ने के लिए कनेक्ट करा जा रहा था, ऑलमोस्ट 2-4 बूंदे चली गई होंगी, बट शी नोटिस्ड इट एंड इमीडिएटली डिसकनेक्टेड इट, और दैट इज गुड फॉर आवर नॉलेज. सो मैं कहूँगी आप सबके लिए तालियां अगर आप ऐसी नॉलेज रखते हैं. थैंक यू वेरी मच. आज कनिष्क होस्ट कर रहे हैं और सारे ऑर्गेनाइजिंग टीम, कोई भी अकेला कोई भी प्रोग्राम ऑर्गेनाइज नहीं कर सकता, उसके लिए एक टीम चाहिए और डेजिग्नेटेड टीम है। जिसने भी इसमें हिस्सा लिया है, काम किया है, सबके लिए बहुत बहुत शुक्रिया। थैंक यू।
थैंक यू सो मच मैम, आपने अपना एक्सपीरियंस शेयर किया बहुत ही कम शब्दों में और बहुत ही ऊर्जावान, बहुत इंस्पिरेशनल। कि कोई भी काम करते हैं बड़ा, जब बड़ा काम तो पूरी टीम एक पीछे होती है सपोर्ट में। और हमने ग्रुप में भी डाला था कि जो CNE के क्रेडिट आर हैं कि 6 मिलेंगे, 7 मिलेंगे, बट एक्चुअली में 8 क्रेडिट आर्स मिलेंगे और उसका सारा क्रेडिट जाता है मदन को, नरगिस मैम को और पूरी ऑर्गेनाइजिंग टीम को। तो एक बार जोरदार तालियां इन सभी के लिए। मैं देख रहा हूं कि इस कॉन्फ्रेंस में अलग अलग डिपार्टमेंट के बहुत सारे सीनियर मेरे मौजूद हैं। सबका नाम लेना मुश्किल होगा, अगर मैं कुछ नाम लेने जाऊंगा तो आई थिंक हो सकता है कुछ नाम मैं मिस कर पाऊँ। सुनीत जी हैं, राहुल बिडिया सर जी हैं, सज्जन जी भी हैं, इसके अलावा त्रिलोक जी भी मेन OT से हैं और सुरेश जी जैसे बताया कि दूसरे हॉस्पिटल से भी हमारे साथ जुड़े, उनके साथ उनके कोलीग भी हैं, मेदांता से भी हमारे साथ हैं। तो सभी, मुझे नहीं लगता यहाँ क्रेडिट आर के लिए कोई आया होगा, यहाँ सीखने आया होगा, ये मुझे पूरा विश्वास है। इसी के साथ आगे बढ़ते हुए जब क्रेडिट आर की बात कर रहे हैं तो इसमें एक थोड़ा सा टेक्निकल एक पॉइंट रहेगा कि नीचे जितनी भी स्टॉल्स हैं वहाँ पे आपको सभी को जाना है। जब तक कॉन्फ्रेंस चल रही है वहाँ पे एक रजिस्टर होगा, उसमें आपको साइन देना होगा। आपका अपना जो नंबर है, जो मैंने PDF शेयर की है मेल के थ्रू, उसमें आपका नंबर है, वहाँ आप नंबर मेंशन कीजिए, हमारे लिए इजी रहेगा। और जो भी आपका सर्टिफिकेट है वो आपके मेल के ऊपर भेज दिया जाएगा। अब हम आगे बढ़ते हैं। आई थिंक मैम आप ज्वाइन करना चाहेंगे आगे कंटिन्यू? ठीक है, तो सेशन शुरू करते हैं एकेडमिक। ठीक है, तो मैम के लिए ठीक है। तो एक बार जोरदार तालियां आप सभी के आशीर्वाद जो हमें आप मिला। तो अब हम एकेडमिक सेशन की तरफ शुरू करते हैं और हमारा पहला जो विषय है गॉल ब्लैडर, और मैं इनवाइट करूंगा हमारे नर्सिंग ऑफिसर रेखा और मानसी जी को कि वो हमारी जो आज की एकेडमिक जर्नी है वो शुरू करें। रेखा, आप जो है ओपन और लेप्रोस्कोपिक जो अप्रोच है गाल स्टोन डिजीज से रिलेटेड है, कोलेसिस्टेक्टमी से जुड़ी हुई, उसको आप कवर करेंगे और मानसी हैं वो रोबोटिक अप्रोच को अप्रोच करेंगे।
गुड मॉर्निंग।
डॉक्टर कार्तिक, नरगिस मैम है इसमें एज ए पैनलिस्ट, जिसपे हम बाद में डिस्कशन भी करेंगे, और रश्मि जी हैं मेन OT से। रश्मि मैम, सुनैना जी की जगह अभी रश्मि जी हैं पैनल में, आप रहेंगे। डॉक्टर कार्तिक आई थिंक अभी वो नीचे बिजी है तो वो हमें बाद में ज्वाइन करेंगे। ओके, डॉक्टर कार्तिक प्लीज। अच्छा, डॉक्टर कार्तिक के परिचय में आपने बता दूं, अभी ये राजीव गांधी हॉस्पिटल में फैकल्टी है और ये यहीं के पास आउट है। अभी शायद 1 महीना ही हुआ होगा इन्होंने राजीव गांधी ज्वाइन किया है। मैं इसलिए बता रहा हूं कि ये वो रेयर सर्जन्स हैं, सीनियर रेजिडेंट है। जब यहाँ से गए तो मैं देख रहा था कि पूरे GI सर्जरी के जितने भी नर्सिंग ऑफिसर्स हैं उन्होंने सब में स्टेटस लगाया हुआ इनके साथ सेल्फी का। तो आई थिंक ये आपने यहाँ से कुछ ना कुछ अलग से प्यार जो है हासिल किया है और ये आपका व्यवहार भी है और उसी के चलते हुए आज हमारे साथ भी हैं। बहुत बहुत धन्यवाद आपका डॉक्टर कार्तिक जी।
गुड मॉर्निंग ऑल ऑफ यू। आई एम मिस रेखा, nursing officer in main Aims. So today's my topic is intraoperative nursing management of gallbladder. As you all know, the anatomy and some signs and symptoms and everything are discussed in auditorium. So now I am just only describe about what are the done in OT. So this is normal anatomy of gallbladder. in this cholecystectomy, open and laparoscopic both are done, and also robotic. Mm. In intraoperative preparations, first is OT preparation. In OT preparation, mainly include lighting or environment of OT, equipment working or not working, these are including, like cabinet, you can see in this way the cabinet that is used in laparoscopic, and these laparoscopic instruments are available or not. Gas is, anybody can tell me about what gas is used in peritoneum? Yeah, CO2. The pressure of gas is 14 to 15 mmHg. That ups to on the depend on the patient also, obese and thin and moderate, all up to on patient. Next is WHO I'm concerned. This is WHO safety checklist. In this, circulating nurse and scrub nurse both are responsible for the identification of patient and the WHO checklist. Next is open cholecystectomy. Now come to open cholecystectomy. What is the open cholecystectomy? Administering general anesthesia and making 4 to 5 inches of incision in the upper right abdomen and exposing, separating gallbladder from the right liver and the other structures. Then clipping and ligations are done for the cystic duct and the arteries. Removing the gallbladder and controlling bleeding. Then finally done suturing by the help of staples and sutures also. Next, you can see in this picture open cholecystectomy how it's look like by the retractions, and you can see the gallbladder. In open cholecystectomy, the position to give the patient is supine, and incision in the right subcostal or the costal incision, you can say. Next is draping. Draping in the supine position. This is how it looks like while we drape the patient. These are more normal things that we arrange before the surgery, like monopolar and bipolar cautery and some retractors. No specific retractors are used, only the general retractor we can use for the cholecystectomy. In this, the blue lead and the probe, you can see the harmonic probe, and the cautery with the white and long tip, you can call it extendable cautery. And third one is cautery and the suction tubings and energy sources which we use for this is cautery machine. Here we can connect 3 leads, monopolar, bipolar and extendable also, by the help of earth padding. This is harmonic machine, and this is the trolley for the open cholecystectomy. As you can see the instruments, there is some general instruments and slings to identify the ducts and arteries. Now it's as we can say this is the main and important instrument for this surgery, that called as stone welding forcer, and with the bowl of water for cleaning of this stone welding. And by the help of stone welding, we remove the stones from the gallbladder. These are retractors, Harrington, Morris, Zernis, and also the LT applicators. 100, that is blue in color, 200 is white in color, 300 is gray in color, and 400 is yellow in color. These are the clips. And this is the ligation that used in cholecystectomy. This is cystic duct and cystic artery. Ligation are cystic duct and cystic arteries by the help of suture or the clips, whatever the surgeons are prefers or the condition while doing the procedure. Drain are used after the procedure, and specimen are mainly removed by the direct because it is opened. Now coming to the advantage. Advantage is a good for the complex of anatomy, and disadvantage is as you know, the open is having the large scar and more painful, and long recovery also, and stay hospital is also increases. This is the suturing of operating site. Now come to the laparoscopic cholecystectomy. It is a minimally invasive surgical procedure to remove the gallbladder through the small incision in the abdomen, and by the help of using laparoscope. Come to the benefit. Smaller incision, reduce pain, faster recovery, lower risk of complications, and the stay of hospital is also reduced. Come to the position and the port. Position are usually supine and reverse Trendelenburg with the left tilt also, and port 3 to 4 ports are used in this. Mainly 4 ports are used. In this 2 ports are 10 or 12 mm, and 2 is 5 mm. First trolley for the laparoscopic. This is the laparoscopic instruments. Scope and ligashores, hooks, and also the gallbladder extractor. This is also a kidney tray with the scalpel for the trocar incision. This is second trolley which used in laparoscopic open for opening the incision area. Main things are used in this are port vicrine for suturing the port site, and second one is trocars. These are disposable trocars, and in this white tubing you can see this is gas tubing, and gray is a bipolar that used in cautery for the cauterizations, and this is the arrangement after the draping. In this picture you see this is the white transparent poly. It is a camera cover used for draping the camera source and camera light tubing, sorry. Next is Hemolock and Lalti applicator. Mainly these are non-absorbable polymer ligating clips used in surgery to resurely the blood vessels and for the tubal structures. Sizes of Hemolock is small that is green color, medium is purple, and larger one is golden color. Size of LT applicator is 200 white. These are LT applicator for the laparoscopics. As you know, these are long in their shape. This is Hemolock applicator, laparoscopic harmonic. This is the draping, and second pictures is pneumoperitoneum. By the Verries needle, we putting the CO2. This is the port placement. Port placement site is first one is above the umbilical. You can see for the camera source and axis. Second one is epigastric region below the breast bone, and the 5 mm port right lumbar region or right hypochondrial region. Next is ligation. By the Hemolock or the LT applicators, we ligate the cystic duct cystic artery. Special arrangement are Lennon bag for a trocar incision and a dome. This is an endo bag, and you can also call as endo cache bag, used for removing the gallbladder to to prevent spillage of bile. This is the staple and dressings. Thank you. Now join Mansi for the robotic.
Good morning all. So my colleague has very well explained everything about the open and laparoscopic cholecystectomy. I am taking it more advanced to robotic level. So anyone knows anything about robotic cholecystectomy or robot we are using nowadays? Anyone knows the name of the robot we are using in Aiims Delhi? Yes, very nice. We are using Da-Vinci XI for latest technology for in Aiims Delhi, but in limited OTs only. XI, Da-Vinci XI. What we mean by robot? ऐसा कोई रोबोट आ गया है जो अपने आप सर्जरीज कर दे? रोबोट ऐसा लेमन लोगों को लगता है कि रोबोट ऐसा है वो अपने आप सर्जरी करेगा, डन. लेकिन ऐसा बिल्कुल भी नहीं है. इट्स अ बिग नो. रोबोट ऐसा दिखता है रियलिटी में. ये पूरा का पूरा सर्जन ऑपरेटिव होता है, नर्सिंग ऑफिसर असिस्ट करते हैं. रोबोट अपने आप उसका कोई ब्रेन नहीं है, वो अपने आप सर्जरीज नहीं करता. इट्स अ मिथ. तो रोबोट होता कैसे है, कैसे ऑपरेट करता है? लेट्स सी दिस वीडियो. साउंड प्लीज. This is a robot we have. Every robot, the robot we have, Da-Vinci XI system, has 3 parts. First one is the patient side card, which I have already seen in my first slide. Second is the vision card, and third one is the surgeon's console. Patient side card is have the 4 robotic arms, जिसमें हम instruments को place करते हैं after creating the pneumoperitoneum. जो laparoscopically हम लोग surgeons handfully movements देते थे इंस्ट्रूमेंट्स को, वो अब ये रोबोटिक आर्म्स देते हैं. सेकंड हमारे पास में विजन कार्ड है, जिसमें ऊपर मेन स्क्रीन है, जैसे कि आप पिक्चर में देख सकते हैं, विच शोज कौन कौन से इंस्ट्रूमेंट वी आर यूजिंग, इन विच आर्म वी आर यूजिंग, न्यूमोपेरिटोनियम का कनेक्शन, कैमरा कनेक्शन, मोनोपोलर बाइपोलर कनेक्शन, ये सब इस विजन कार्ड में होता है. थर्ड वन इज द सर्जन कंसोल, विच इज़ वेरी इंपॉर्टेंट. सर्जन कंसोल इस टाइप से बना है कि आप इसमें एक बेटर पिक्चर में देख सकते हैं. नीचे फुट एंड पे सर्जन के पास में कैमरा कंट्रोल, मोनोपोलर कंट्रोल, बाइपोलर कंट्रोल, एवरीथिंग होता है. सर्जन आराम से एक चेयर पे बैठ करके एक लेंस में, जो ऊपर आप लेंस देख सकते हैं, उस लेंस के थ्रू पेशेंट के अंदर डायरेक्टली देख सकते हैं. उस लेंस में एक 3D व्यू होता है, जो हमारी लेप्रोस्कोपिक सर्जरी से मच बेटर है, फार बेटर है. वो बहुत ही अच्छे से वास्ट व्यू देख सकते हैं. दिस इज हाउ लेप्रोस्कोपिक all three functions together. Let's see this video. Surgeon is sitting on the surgeon's console and he is operating, he is suturing, and he is seeing, and the robotic arms are operating on the patient, and we nursing officers can see what is happening inside patient's body through vision card. This all 3 works together, and only then a robotic surgery can be performed. अब हमारे पास क्वेश्चन ये आता है, when surgeon is doing the surgery, when a nursing officer is assisting, why we need robotic surgery? हमें उसकी ज़रूरत ही क्यों है? क्योंकि सर्जन्स का काम कम नहीं हुआ, नर्सिंग ऑफिसर्स भी अभी भी वैसे ही असिस्ट करें, तो हमें रोबोटिक की ज़रूरत क्या है? बिकॉज वी हैव वास्ट वेरी मच बेनिफिट्स ऑफ रोबोटिक सर्जरी. लाइक इट इज़ मिनिमली इन्वेजिव. लेप्रोस्कोपिक सर्जरीज की तरह मिनिमम स्कार्स होते हैं, बहुत ही मिनिमली इन्वेजिव रहता है इसकी अप्रोच. और पेशेंट को पोस्ट ऑपरेटिवली देखा गया है कि पेन बहुत ज़्यादा कम होता है, क्योंकि स्किन मूवमेंट्स, स्किन से इंटरेक्शन बहुत कम हो जाता है. जो हमारे ट्रेमर्स होते हैं, जो मैनुअली जो हम इंटरप्रिटेशन कर पाते हैं, टिश्यूज़ का इंटरप्रिटेशन हो जाता है हमसे मैनुअली एज एन ह्यूमन एरर, वो मिनिमाइज हो जाता है. फास्ट रिकवरी है पेशेंट की, हाई डेफिनेशन 3D व्यू मिलता है सर्जन को, तो वो बेसिकली अपने आसपास के स्ट्रक्चर्स को भी इजीली देख सकते हैं और उनको अकॉर्डिंगली सर्जरी कर सकते हैं। जो इंस्ट्रूमेंट्स होते हैं रोबोटिक इंस्ट्रूमेंट्स, वो 7 डिग्री फ्रीडम होती है उनके पास में, जिसकी वजह से फाइन डाइसेक्शन भी पॉसिबल है। जो ह्यूमन रिस्ट है वो इतनी मूवमेंट नहीं दे सकते, और ऐसे जो इजीली एक्सेसिबल एरियाज नहीं है वहाँ पर नहीं पहुँच पाते, लेकिन ये रोबोटिक इंस्ट्रूमेंट्स पहुँच पाते हैं। जो नेचुरल ट्रेमर्स होते हैं सर्जन्स के हाथ में, जो यूजुअली किसी के भी ह्यूमंस के हाथ में जो नेचुरल ट्रेमर्स होते हैं उनको फिल्टर आउट कर देता है, तो स्किन मैनिपुलेशन, टिश्यू मैनिपुलेशन बहुत ज़्यादा कम हो जाता है। सर्जन्स की फटीग ड्यूरिंग द लॉन्ग आवर्स वो काफ़ी कम होती है, और डिफ़िकल्ट एरियाज, एज आई टोल्ड कि डिफ़िकल्ट एरियाज में रीच उसकी पॉसिबिलिटी बहुत अच्छी है, जैसे पेल्विक एरिया है, ऑन्कोलॉजी की सर्जरीज है, उसमें बहुत अच्छा बेनिफिट देखा गया है रोबोटिक सर्जरीज का। और मैन पावर भी रिड्यूस हुआ है काफ़ी, सिर्फ एक सर्जन, नर्सिंग ऑफिसर, एक रोबोटिक टेक्नीशियन आर इनफ टू डू द रोबोटिक सर्जरीज। प्री रिक्विसाइट्स क्या क्या रहेंगे, एज रेखा मैम हैज़ ऑलरेडी डिस्कस कि पेशेंट के लिए प्री रिक्विसाइट्स in every surgery is the same: identification, WHO checklist, informed consent, and AST. We have requisites, nothing other than this. रोबोटिक सर्जरीज के लिए अपने आप कुछ प्री रिक्विसाइट्स है, जैसे हम ओपन और लेप्रोस्कोपिक में अपनी ट्रॉलीज रेडी करते हैं, अपनी चीज़ें अरेंज करते हैं, ऐसी रोबोटिक के लिए हमें स्पेशल रोबोटिक ड्रेप्स आते हैं, जिसे हमें रोबोटिक ड्रेप्स को हमें स्पेशल रोबोटिक ड्रेप्स को हमें अरेंज करके रखना होता है। रोबोटिक इंस्ट्रूमेंट्स डिफरेंट होते हैं, जैसे लेप्रोस्कोपिक इंस्ट्रूमेंट्स ओपन के इंस्ट्रूमेंट्स, इस तरह से रोबोटिक इंस्ट्रूमेंट्स होते हैं। वेरीज नीडल सेम टू क्रिएट द न्यूमोपेरिटोनियम, एनर्जी सोर्सेज मोनोपोलर बाइपोलर इज डिफरेंट टू रोबोटिक सर्जरीज। रोबोटिक लिप एप्लीकेटर्स एंड ऑन बैक हैंड पे हमें ओपन सेट्स रखने होते हैं टू मैनेज एनी कॉम्प्लिकेशंस। नेक्स्ट कम्स द रोबोटिक इंस्ट्रूमेंट्स। रोबोटिक इंस्ट्रूमेंट्स में हमें सबसे इंपॉर्टेंट, आप साइड में एक इमेज देख सकते हैं, उसमें आपको एक रोबोटिक आर्म दिख रही है जिसमें रोबोटिक एक इंस्ट्रूमेंट अटैच्ड है। दिस रोबोटिक इंस्ट्रूमेंट हमें इसका लाइफ को चेक करना होता है। एवरी रोबोटिक इंस्ट्रूमेंट ओनली हैज़ 50 to 100 लाइफ्स, जो कि कंपनी वाले हमें बताते हैं। विजन कार्ड पे मॉनिटर में अटैच करते ही हमारे पास में आता है कि उसकी कितनी लाइफ बची हुई है। एज अ नर्सिंग ऑफिसर इट्स आवर रिस्पॉन्सिबिलिटी टू चेक इन एडवांस हाउ मेनी लाइफ्स आर देयर, ताकि सर्जन को ड्यूरिंग द इंटर ऑपरेटिव कुछ प्रॉब्लम ना हो। जैसे कि मैंने बताया 7 डिग्री फ्रीडम, बेटर प्रिसीजन, मैग्नीफाइड व्यू, ये सब चीज़ें हमें रोबोटिक्स इंस्ट्रूमेंट्स हमें प्रोवाइड करते हैं। नाउ लेट्स कम टू द रोबोटिक कोलेसिस्टेक्टमी। कोलेसिस्टेक्टमी में हमें पोजीशन, एज मैम ऑलरेडी एक्सप्लेन्ड, सुपाइन पोजीशन विद रिवर्स टेनलेनबर्ग रहेगा एंड विद राइट साइड अप। इन यूजुअली इन कॉमन लैंग्वेज वी से राइट अप हेड अप। तो इसमें हम ऐसी पोजीशन रखते हैं पेशेंट की, क्योंकि जब हम हेड अप करते हैं तो इंटेस्टाइन्स फॉल डाउन हो जाती है ड्यू टू ग्रेविटी, जिसकी वजह से हमें बेटर स्पेस मिलता है काम करने के लिए। सेकेंडली हम हेड अप करते हैं, राइट अप करते हैं, तो उससे क्या होता है, लीवर और गॉल ब्लैडर मीडियली प्लेस हो जाता है, तो हमें ईजी एक्सेस हो जाता है हमारे लिए। हमारे एज अ नर्सिंग ऑफिसर इट्स आवर रिस्पॉन्सिबिलिटी टू इंश्योर प्रॉपर पैडिंग एट प्रेशर एरियाज। Under pressure points. Next is the draping of the robot. Let's see how we drape the robot. This transparent sheet we use is the robotic drape. My colleague is doing the robotic drape. Robotic drape is tucked at all the points. Every clutch button is covered to make it sterile. You are seeing the 4 written on the arm. Every arm has its own number. जहाँ पे 4 लिखा है वहाँ पर एक आप स्पेशल देख रहे हैं, उसमें इंस्ट्रूमेंट हमारा अटैच होता है, जिसकी वजह से हम सर्जन कंसोल से उसे ऑपरेट कर सकते हैं। और जहाँ पे जो नीचे आप देख रहे हैं 4 के नीचे, जहाँ पे ये अभी करने वाले हैं डॉग, उसको वहाँ से पोर्ट अटैच होता है, उसके पास एक मैग्नेटिक व्यू होता है जिससे पोर्ट अटैच होता है, और सर्जन कंसोल से पूरा ऑपरेट कर सकते हैं। दिस वॉज द ड्रेपिंग ऑफ द रोबोट। नाउ कम्स द पोर्ट प्लेसमेंट। रोबोटिक पोर्ट्स और लेप्रोस्कोपिक पोर्ट्स डिफरेंट होते हैं। जो हमारे पास रोबोटिक पोर्ट्स होते हैं वो मेटल में होते हैं, क्योंकि मैग्नेटिक होता है, रोबोटिक में मैग्नेट से अटैच होते हैं। ये 8 mm to 12 mm हम यूज़ करते हैं। लेप्रोस्कोपिक पोर्ट्स, इसमें मोस्ट इंपॉर्टेंट नर्सिंग रोल ये है कि वी हैव टू कीप द स्किन मार्कर एंड स्केल रेडी, बिकॉज एवरी पोर्ट शुड बी एट 8 to 10 centimeter of distance. And these lines, the broader lines you are seeing on the ports, are for not for the decorative purpose, it's for the depth markings. We have to ensure that all the ports are at the equal levels for proper docking of the robot, and not in the much deeper area of the peritoneum. This is how we place the ports. Every port at 8 to 10 centimeter of distance, and every port is docked with the respective arms. Next comes the docking of robotic arms. Once we have draped the robots, ports are placed, robotic cart हम उस पेशेंट के पास पोजीशन करेंगे. देन आपने फर्स्ट वीडियो में, अगर आप इफ यू कैन रिकॉल, फर्स्ट वीडियो में आपने देखा होगा एक ऊपर ब्लू कलर की लेजर लाइंस थी which was intersecting. That laser line was not a decorative purpose. वो हमें assess करते हैं कि हम किस तरह से पोजीशन कर पा रहे हैं पेशेंट की. That intersection comes at the umbilicus area, where the camera is inserted into the port. First we have to dock the camera arm, then camera is placed, and under the vision we have to place the rest of the ports. उसके फिर then we have to target the anatomy, which is already pre-filled in the robotic cart. उसके बाद में वो adjust करेगा अपने आप robotic arms accordingly. Then other arms can be docked, and every arm should be at adequate distance of 8 to 10 centimeter approx, because if they will collide, no instrument can work. This is how robotic surgery is being performed. Robotic arms are moving. Surgeon is operating from the surgeon's console. See, the surgeon is sitting on the surgeon's console. He is operating from far away. Vision card we can see, and we can see the instrument written on the right side of the vision card, and the instruments moving inside, and we can see which instrument are being used, which arm has which instrument. This is how robotic surgeries are done. Next comes the drain placement part. Drain is not a routine for laparoscopic. Drain is not routinely placed in robotic surgeries, but if the spillage is there, bleeding during intraoperative phase is detected, we can place the drain for sure. We usually use Romovac drains of 16 to 18 Frenches depending on the surgeon's choice. Drain placement की site हमारे पास होती है right subhepatic space, which is below liver near the gallbladder bed, and we should, as a nursing officer, we should see that drain is ensuredly properly secured with the skin. Everything has some pros and cons. We also have some shortcomings for robotic surgeries, as it is expensive. Of course, locally areas में बहुत सारे hospitals है जहाँ पे ये available नहीं है, so we can. This is a shortcoming for robotic surgery. It's very expensive. It's very costly. Longer setup and docking time. इसके setup में, draping में, सारे instruments arrangements में बहुत ज़्यादा time लगता है. OT का काफ़ी ज़्यादा स्पेस लेता है, तो हमें बहुत अच्छा स्पेस चाहिए. जो हमारा सबसे बड़ा OT होता है उसी में हम लोग इसको प्लेस कर सकते हैं. 3 अलग अलग डिफरेंट कार्ड्स है, फिर पेशेंट OT टेबल, ये सब चीज़ें जो नॉर्मली हमारे पास होती है वो होनी है, तो इसके लिए हमें लार्जर स्पेस की ज़रूरत होती है. इसके अलावा हमारे पास में रिक्वायर्ड ट्रेन स्टाफ और ट्रेंड नर्सिंग ऑफिसर्स, ट्रेन स्टाफ चाहिए हमें, तो लेकिन हमारे पास एक और ये लिमिटेड है फ्यू हॉस्पिटल्स के लिए. दीज वर द शॉर्टकमिंग्स. These were all the shortcomings. This is all from my side about robotic surgeries. If you have any doubt, I am here to explain. I would love to. Thank you.
So, as a panelist, we have a few experts as well. Dr. Karthik, Nargis ma'am, और रश्मि मैम, आप कुछ इसमें ऐड ऑन करना चाहेंगे? देन उसके बाद हम हमारे सभी डेलीगेट से कुछ उनके जो क्वेश्चंस होंगे वो लेंगे हम.
पहले तो मैं सभी डेलीगेट से पूछना चाहूँगी, जो लोग ऑपरेशन थिएटर में काम करते हैं, अगर उन्होंने कुछ छोड़ा है, मिस्ड आउट है, तो आप उसको ऐड ऑन कर सकते हैं.
सेकंड माइक प्लीज. आप अपना हैंड रेज कर सकते हैं, किसी की क्वेरी है, देन हम फिर आगे प्रोसीड करेंगे। देखो प्रश्न दो ही चीजों में नहीं आते, या तो कुछ समझ नहीं आया या सब कुछ समझ आ गया। अब कौन सी सिचुएशन है ये समझ नहीं आ रहा अभी हमें।
वैसे मैं कहना चाहूंगी कि ओपन सर्जरी में एक तो सर्जन के लिए बहुत ज़्यादा टायरिंग हो जाता है, कोई भी ओपन सर्जरी हो। गॉल ब्लैडर अगर तो नॉर्मल है, निकल गया तो ठीक है, अगर कॉम्प्लिकेटेड हो गया तो इट कैन गो फॉर 2 hours 3 hours। सो रिट्रैक्शन बिकम्स वेरी डिफिकल्ट बिकॉज today's generation is more interested in laparoscopy surgery, so that stamina they want कि वो सर्जरी हो जाए, 4-5 घंटे पकड़ के रखें। दूसरी बात है, कई बार गॉल ब्लैडर ग्रॉसली एनलार्ज्ड होता है, तो उस एनलार्जमेंट कम करने के लिए एंड सिल्क होती है कि वो काम करने के लिए जगह कम होती है। जब जगह कम होती है तो करते हैं, वो सोचते हैं कि इसको एस्पिरेट कर लेते हैं, तो बाइल को एस्पिरेट कर लेते हैं, उनको जगह मिल जाती है। तो उसके लिए जैसे ही नर्सिंग ऑफिसर, द पर्सन हु इज असिस्टिंग, देखता है कि ये बहुत बड़ा है, तो एकदम उनके दिमाग में आना चाहिए कि नाउ आई नीड अ सिरिंज एंड नीडल टू एस्पिरेट द ब्लैडर, गॉल ब्लैडर। सो ये चीज़ें छोटी 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 जो है नर्सिंग ऑफिसर्स को सर्जन से पहले पता चल जानी चाहिए, तो उसी से आपका टाइम जो है कम हो जाएगा। दूसरी बात है, इंजरी हो सकती है गॉल ब्लैडर को, अगर ग्लॉसली इंजरी आ जाए तो उसमें बहुत सारा आपका बाइल जो है लीक हो जाएगा, एब्डोमिनल कैविटी में हो जाएगा और इन्फेक्शन हो जाएगा, स्टोन स्कैटर्ड हो जाएंगे। जो स्टोन होल्डिंग फॉर्सेप्स है दैट इज नॉट एसेंशियल फॉर एनी सर्जरी, जब तक कि आपका स्टोन सीबीडी में नहीं है या आपका गॉल ब्लैडर फट गया और स्टोन स्कैटर्ड हो गए हैं, आप उनको उठाने के लिए चाहिए। और जो स्टोन होल्डिंग्स है डिफरेंट साइज के होते हैं, उनके कर्व अलग अलग होते हैं, हेपेटिक उसमें डालना, डक्ट में डालना, राइट में डालना, तो उनका कर्व जो है वो बढ़ता जाता है। जो सीबीडी में होते हैं उसके लिए तो सिंपल आपको स्ट्रेट वाला ही चाहिए होगा। तीसरी बात है, इसमें कई बार ऑल ऑफ सडन सर्जन बात कर रहे होते हैं कि इसका ज़्यादा है, ऐसे मेलिग्नेंसी ना हो तो चलो फ्रोजन भेज देते हैं, तो स्टाफ का काम है इमीडिएटली फ्रोजन सेंस कर लिया कि इनको क्या चाहिए, मैं उसके लिए रेडी करना शुरू कर दूं अपना काम। तो ये चीज़ें मुझे लगता है एक्सपीरियंस के साथ आती हैं। तीसरी बात है, बाकी हॉस्पिटल्स में दे हैव स्टार्टेड डूइंग फ्रोजन फॉर दिस थिंग ऑल्सो, cholecystectomy ऑल्सो। तीसरी बात है, जब हम सोचते हैं कि अभी सिस्टिक डक्ट को बांधने लगते हैं तो सर्जन क्या करते हैं, मिल्क करते हैं कि कोई स्टोन जो है सिस्टिक डक्ट में तो नहीं है। तो अगर उनको लगता है कि बहुत ही माइन्यूट स्टोन्स हैं और सिस्टिक डक्ट से सीबीडी में जा सकता है, तो इंट्रा ऑपरेटिव कोलेंजियोग्राम इज वेरी वेरी इंपॉर्टेंट। उसके लिए फिर आपको फटाफट कॉन्ट्रास्ट चाहिए, या कौन से सर्जन की चॉइस होती है। कभी कभी वो लोग फीडिंग ट्यूब से करते हैं और कभी कभी वो जो एक्सेस कैथेटर जैसा होता है उससे करते हैं, तो इट डिपेंड्स ऑन सर्जन्स चॉइस। तो हम जब एक ही सर्जन के साथ सालों से काम करते हैं तो हमें उनसे 10 कदम आगे चलने की आदत पड़ जाती है, तो वही है कि वो सर्जरी का टाइम कम कर देती है। तीसरी बात है, आपने ओपन देख लिया, रोबोटिक देख लिया, लैब देख लिया, लेकिन एक चीज आपने नहीं सुनी होगी जो मैंने करवाई है, उसको कहते हैं नेचुरल ऑरिफिस ट्रांसल्यूमन लैप्रोस्कोपी cholecystectomy। ये स्कारलेस सर्जरी होती है, ये वजाइना से करते हैं, और इसके इंस्ट्रूमेंट इतने लंबे होते हैं क्योंकि उनको यहाँ तक जाना होता है। लेकिन उस वक्त मैंने ये 3 सर्जरी इंटरनेशनल फैकल्टी के साथ कराई थी एम्स में, तो अच्छे से उन्होंने किया था, बट ये दोबारा कभी प्रैक्टिस में आया नहीं। सो आई वॉज द ओनली विटनेस टू दैट सर्जरी, क्योंकि उस दिन मेरी वर्कशॉप में पोस्टिंग थी। उसमें हमें बहुत परेशानी हुई थी क्योंकि इंस्ट्रूमेंट इतने लंबे थे कि हमारे पास ना तो उतना लंबा ऑटोक्लेव था और ना ही हमारे पास उतनी लंबी साइड एक्सट्रेज थी। तो इंडियंस आर ऑलवेज जुगाड़ू। तो हमने क्या किया, हमने कैमरा कवर को एक तरफ से रबर बैंड डाला, उसमें साइड एक्स भरा, सारे इंस्ट्रूमेंट उसमें डाले और फिर इधर से रबर बैंड डाल दिया, एंड देन टुक आउट इंस्ट्रूमेंट आफ्टर 20 मिनट्स फॉर द सर्जरी। सो ये आपको चौथी सर्जरी के बारे में आपको मैंने आज बताया जी, जो आपको नहीं पता थी।
आई थिंक जितनी मेरी एज है उतना आप ओटी में स्पेंड कर चुके हैं, और उसी का ही परिणाम है कि आप जब एक्सप्लेन कर रहे हैं तो ऐसे चल रहा है कि जैसे किसी ने मूवी चला दी हो और हम थिएटर में और बस देखे जा रहे हैं। बट कुछ एक जनरल क्वेश्चन होते हैं, मैं डॉक्टर कार्तिक आपसे लेना चाहूँगा कि चूँकि हम बहुत सारे नर्सिंग ऑफिसर्स जो हैं वो ओटी में कभी जाने का मौका नहीं मिला, हालांकि मैं तो 2-3 महीने लगा के आया हूँ, बट मेजॉरिटी हमारी ऐसी यहाँ पे है जो ओटी में नहीं जाते। तो एक प्रश्न सभी के माइंड में आता है, एक तो मैं मिथ से रिलेटेड शुरू करता हूँ कि कई बार बोलते हैं कि स्लज है, जैसे हम यूएसजी किसी के देख लेते हैं, तो स्लज और स्टोन, क्या उसमें स्लज वाले पार्ट में क्या सर्जरी के साथ जाना चाहिए? देन स्टोन के लिए एक मिथ है, छोटी है कोई बात नहीं छोड़ दो, बड़ी है तो देखेंगे। तो इन दोनों के बारे में आपके क्या व्यूज हैं, मतलब एक्सपर्ट ओपिनियन आपके क्या बोलते हैं?
So, इसी बारे में I was about to say that in the first slide Rekha has mentioned that asymptomatic gallstone disease we should observe. So ideally, if you are in North India, there is a high risk of gallbladder cancer incidence here. So if any patient is diagnosed with the gallstone disease, according to me, it is my preference that I will opt for a laparoscopic cholecystectomy for that patient to prevent gallbladder cancer per se, because gallbladder cancer has got dismal prognosis, only 6 months. However, if you're in South India, you may avoid it. You can totally avoid laparoscopic cholecystectomy. And second thing that you were telling about the size of the gallstones. So smaller stones are always dangerous, as they can pass into the CBD and cause acute pancreatitis, which if severe can be lethal. So that is why my preference, if you ask me, even if asymptomatic gallstone disease is there, I will definitely ask the patient to undergo a laparoscopic cholecystectomy. And the same goes for sludge also. Sludge P, it can pass into the CBD and can cause pancreatitis.
ओके, थैंक यू सो मच डॉक्टर साहब। मेरा नेक्स्ट जो प्रश्न है वो रश्मि मैम से है कि बहुत सारे नए बच्चे आते हैं ओटी में, फॉर एग्जांपल मेरा ही डे 1 है, और अभी जैसे मैम ने कॉम्प्लिकेशंस के बारे में बताया, आपके मन में भी एक आता होगा कि मैं ओटी में जाऊंगा तो कैसे करूंगा, एक हफ्ते में मैं इतनी सारी चीज़ें बताई जो बड़ी कॉम्प्लिकेटेड है, कॉम्प्लेक्स है, तो उस समय आप कैसे माइंड जो है वो डेवलप करते हो सामने वाले का जो असिस्ट कर रहा होता है एज ए ओटी नर्स?
मेरा बोलना यही है कि जब भी नए बच्चे आते हैं तो सबसे पहले तो हम स्टेरिलिटी के बारे में ही बताते हैं। कोई भी काम करना है स्टेप वाइज करना है, आपको पहले सर्जरी देखनी है, ऐसा नहीं कि तुरंत हम उन्हें केस में खड़ा कर दिया, ऐसा कुछ नहीं है। पहले उनको ऑब्जर्व करने के लिए दिया जाता है, उसके बाद एक एक चीज़ जैसे ट्रॉली कैसे बनानी है और फिर केस में कैसे असिस्ट करना है, वो सारा कुछ हम स्टेप वाइज हमें उन्हें बताना होता है। बस
जी, थैंक यू सो मच। अभी समय है, ये तो जनरल, एक बार उनको बोलना पड़ेगा उसको पीछे। नवनीत, एक स्लाइड है तो मैम दिखाना चाह रही है जिसमें हंड्रेड्स ऑफ स्टोन्स है छोटे छोटे, तो शायद रेयर सर्जरी रही होगी किसी समय, तो उसकी भी एक स्लाइड देख लेंगे। तब तक हम नेक्स्ट टॉपिक पे चलते हैं।
Just to add one thing.
जी।
Since Mansi said that there's no robot who can operate independently, so there's a robot has come. His name is Star, who we recently had a trial, and that robot did independent laparoscopic cholecystectomy, not in human but ex vivo, and that robot has been tested for robot-assisted colectomy also. So now we have robot who can. No surgeon is required. Robot did it himself.
मेरा प्रश्न है कि इसके पीछे एलन मस्क तो नहीं है?
I don't know.
इसमें मानसी ने बहुत अच्छे से एक्सप्लेन किया हर चीज़ को, और रेखा ने भी अच्छे से एक्सप्लेन किया, बट शी मिस्ड सम पॉइंट्स, क्योंकि वो सब चीज़ें एक्सपीरियंस के साथ ही आती हैं, तो उसमें कोई है नहीं बुरा।
आपके सानिध्य की जरूरत है। हाँ, क्वेश्चन अगर कोई हो तो ले सकते हैं। हाँ, माइक पीछे एक और है, एक और है, सुनिए। हाँ, ले ले।
हेलो डॉक्टर कार्तिक से स्लज और स्टोन के साथ साथ मैं पोलिप के लिए उसी के संदर्भ में पूछना चाहूँ, पोलिप का क्या रहेगा आपकी?
पॉलिप अगर 1 सेंटीमीटर से ज़्यादा हो तो इट हैज़ हाई रिस्क ऑफ मेलिग्नेंसी, सो सिंगल पॉलिप should operate. चल तो रहा है।
I think on है वो, लेकिन
Single polyp you should operate. If there are multiple polyps, then it can be benign, so you can leave that. If it is symptomatic, multiple polyps symptomatic, operate. Multiple polyp asymptomatic, don't operate. Single polyp symptomatic or asymptomatic, operate. More than 1 centimeter, do a open cholecystectomy, not lap cholecystectomy. Though standard is laparoscopic cholecystectomy as of now, but if it is more than 1 centimeter polyp, you should opt for open cholecystectomy because high risk of spillage of bile. Then it can be, it can upstage the disease from T1A to M1, which is stage 4.
Sir, my question is that after surgery, patient has to, what are the things patient has to change for the rest of life? What are the modifications he needs to do after the surgery?
hardly for 3 to 6 months, the patient has to avoid oily and spicy food. After that, he can live a longer life. Though it is said that after laparoscopic cholecystectomy, since you don't have any reservoir, so the pressure inside the bile duct increases. That is why you get a dilated bile duct in all these patients who have undergone laparoscopic cholecystectomy. That should not be a worrying sign for that. Nothing is to be done.
Okay.
Thank you.
So one thing is clear, approach कोई सी भी हो, but nurses are indispensable. Thank you so much. मैं सभी पैनलिस्ट को बोलना चाहूँगा. एक त्रिलोक जी.
से क्वेश्चन है, समटाइम टेस्ट bad tissue around. How can you define this is cystic duct or common bile duct?
तो वही नीचे सेशन अगर आपने सुना होगा तो उसमें बात कर रहे थे, जब भी ऐसे डिफिकल्ट गॉल ब्लैडर आपको मिलता है तो यू शुड बेल आउट. सब टोटल कोलेस्टेक्टमी करके बाहर आना है. आपको फंडस पे गॉल ब्लैडर खोलना है, स्टोन निकालना है, जितना नीचे जा सकते हो जाना है, अंदर से सिस्टिक डक्ट ढूंढना है, बांधना है उसको, और जितना गॉल ब्लैडर काट सकते हो काटना है. अगर ये नहीं करेंगे आप, the high chances you will injure common bile duct and the patient will land in trouble.
But nowadays we are introducing some dye. No.
So ICG definitely can be used. That's known as indocyanine green dye.
Yeah.
But उसका disadvantage ये है कि आपको ना वो 4 से 6 घंटे पहले देना पड़ेगा.
Yeah.
And आप encounter नहीं कर रहे हो कि difficult gall bladder है. अच्छा, इससे याद आया, I should be telling this to you guys that okay, we anticipate the red stigmata, red flag signs for a difficult gall bladder, right? क्योंकि डिफिकल्ट गॉल ब्लैडर है, आप लैब स्टार्ट कर रहे हो केस, आपको ओपन में कन्वर्ट करना पड़ेगा. एंड आई थिंक एज नरगिस मैम सेड कि नर्सेस शुड बी वन स्टेप अहेड ऑफ द सर्जन, राइट?
दिस इज माय क्वेश्चन.
इट हेल्प्स इन लॉट ऑफ थिंग्स. आपका सर्जरी ड्यूरेशन कम हुआ, आपके ओटी कंज्यूमेबल्स कम हुए, पेशेंट को मॉर्बिडिटी कम हुआ, द लॉट ऑफ थिंग्स इन दैट. तो अ नर्स शुड ऑलवेज बी वन स्टेप अहेड ऑफ अ सर्जन. दैट इज व्हाट आई फील एंड दैट हैज हैपेंड विद मी हियर आल्सो. मैं विपल स्टार्ट किया था 7 घंटे में करता था. मेरे स्किल्स उस टाइम पे अच्छे नहीं थे, जूनियर स्टाफ हुआ करता था. एंड पे जाते जाते 5 घंटे में करता हूँ. सीनियर्स भी मिले मेरे को, बट मेरे स्किल्स भी इंप्रूव हुए. तो ये एक नर्स की वजह से भी हुआ और मेरे खुद के स्किल्स भी बढ़े. तो ये बहुत ही जरूरी है. 2 घंटे पेशेंट कम जिए में रहा. दैट इज वेरी इंपॉर्टेंट, राइट? कमिंग टू दिस क्वेश्चन जो आप बोल रहे थे आईसीजी के बारे में, आप कभी एंटिसिपेट नहीं करोगे कि डिफिकल्ट गॉल ब्लैडर होगा. वेरी रेयरली यू विल फाइंड इट. तो वो 6 घंटे पहले देने वाला प्रॉब्लम होता है. अब अगर वो आपने पहले दे दिया, जैसे
तो
अभी जिस सेंटर में मैं हूँ वहाँ पे हर पेशेंट को 6 घंटे पहले दिया जाता है गॉल ब्लैडर लैप कोली के पहले. उस टाइम पे आप बस एक बटन दबाओ, इंफ्रारेड कैमरा ऑन होगा और आपको बाइल डक्ट दिख जाएगा ग्रीन कलर का. उस ग्रीन कलर की बाइल डक्ट से ऊपर रह के आप कोलेस्टेक्टमी कर सकते हो. एंड द रेड फ्लैग साइंस आई वाज टेलिंग अबाउट कि किस पेशेंट में आपको ओपन में कन्वर्ट करना पड़ सकता है, वो है एक मेल लैप कोली. अगर किसी मेल को हो रहा है क्योंकि उनका पेन का थ्रेशोल्ड बहुत ही हाई होता है, उन्हें दर्द हो रहा होगा, वो अल्ट्रासाउंड नहीं कराएंगे और बाद में गॉल ब्लैडर फाइब्रोसिस हो जाएगा एज कम्पेयर टू फीमेल्स जिनको हल्का सा भी दर्द होगा, वो अल्ट्रासाउंड करा के सर्जरी करा लेंगे.
थैंक यू.
सर्जरी का नो दैट
This is
in books.
This is true. No, this is true also.
No, that's reality, sister. You can see it in books. It's written. It's written. तो मेल,
हाँ,
अगर मेल गॉल ब्लैडर है तो डिफिकल्ट है. पोर्टल हाइपरटेंशन है पेशेंट को, डिफिकल्ट है. पेशेंट का गॉल ब्लैडर कॉन्ट्रैक्टेड है, डिफिकल्ट होगा. अगर आपने अल्ट्रासाउंड रिपोर्ट देखा तो लॉन्ग स्टैंडिंग हिस्ट्री है, 10 साल की 15 साल की हिस्ट्री है, डिफिकल्ट होगा. उस टाइम पे आप सबको रेडी रहना चाहिए कि हाँ ये पेशेंट ओपन में कन्वर्ट हो सकता है या फिर इंजरी हो सकता है, तब भी ओपन में कन्वर्ट होगा.
थैंक यू सर. एंड
तो जब बड़े बात करते हैं तो ऐसे लगता है छोटों को बस सुनता ही रहना चाहिए, सुनते रहे. ऐसे कुछ डिस्कशन चल रहा था त्रिलोक जी का और डॉक्टर कार्तिक का. अभी हम नेक्स्ट टॉपिक की तरफ मूव करते हैं. थैंक यू सो मच तीनों पैनलिस्ट को और दोनों स्पीकर्स को, रेखा जी और मानसी जी को. अभी हम बात कर रहे थे जो जनरलाइजेशन की, जनरल सर्जरी वाला पार्ट. अब आता है कि एम्स वाला पार्ट, कि पेशेंट एम्स में किस लिए आता है, किस बीमारी के साथ आता है, डायग्नोज के साथ आता है. थोड़ा सा आगे बढ़ते हैं. कार्सिनोमा गॉल ब्लैडर को कवर करने के लिए हमारे बीच में एज ए मॉडिनेटर है मिस वैष्णवी, नर्सिंग ऑफिसर मेन ओटी एम्स, और पैनलिस्ट में डॉक्टर यशवंत सीनियर हमारे जीआई सर्जन हैं, और मोहिनी जी हैं पैनलिस्ट में, और मदन जी. आप तीनों ज्वाइन कीजिए. पैनलिस्ट में हमारे साथ डॉक्टर यशवंत जीआई सर्जन आगे हैं, और मोहिनी जी और मदन जी. एक बार वो आप दिखाएंगे दोबारा इमेज जो है. जो हम मिस कर गए थे? ये वाली जो इमेज है जो हम मिस कर गए थे, जो मैम दिखाना चाह रही थी, जिसमें काफ़ी सारी स्टोन्स है.
Okay, good morning everyone. I am Vaishnavi and today I will be discussing about extended cholecystectomy for carcinoma gallbladder. We will be talking about the nursing perspective of this diagnosis and the surgery. Okay, so let me give you a brief introduction about gallbladder carcinoma. Gallbladder carcinoma, if we look at it from the world perspective, if we look at it as a global perspective, it is a very rare malignancy, but for us Indians, we have a bad luck because in north and northeastern belt, it is a very common cancer. We encounter this carcinoma gallbladder very frequently in our OT also. And the prognosis for this disease is very poor because usually when it is diagnosed, just the carcinoma gallbladder, the disease has prognosed a lot. It can be diagnosed either incidentally or if the mass is palpable on the patient. And when the mass is palpable, the disease has usually prognosed a lot. So surgical resection and some adjuvant therapies, they can help the patient. Palliative chemotherapy is also okay, so let's talk about some chemotherapy. So gemcitabine and cisplatin, they are first line chemotherapy drugs for fit patients. Regular surveillance and close monitoring is very important for gallbladder carcinoma patients. If we talk about the microscopy of this disease, so most commonly the tumor is adenocarcinoma, followed by a squamous cell carcinoma or adenosquamous or carcinoid tumors. The tumor can be localized or lymph node can be involved and it can have distant metastasis. And important point to notice that it is a very aggressive tumor. Okay, so a brief introduction about cholecystectomy, extended cholecystectomy. Extended cholecystectomy or radical cholecystectomy. It is a surgical procedure in which we remove the gallbladder, a portion of the liver and the lymph nodes. It is primarily performed for gallbladder carcinoma. So this is an extended approach as compared to the laparoscopic cholecystectomy or robotic. It aims to achieve a better oncological outcome. Okay, so let's take a brief review of the anatomy. Here you can see the neck, body and fundus of the gallbladder. You can see cystic duct, common hepatic duct forming the common bile duct. Next, let's talk about the layers of gallbladder. So this is relevant because we need to discuss the staging of the carcinoma. And to understand that better, we need to have a quick look about the layers. Okay, so this layer will be talking from inside to the out. So the innermost layer is the epithelium, followed by lamina propria, muscularis, perimuscular fibrous tissue and serosa. So these layers, they are different from the general GI tract layers in the sense that gallbladder has no submucosa. Gallbladder, the muscularis layer of gallbladder is irregular, it is not well layered. It has a purpose because it is irregular because it helps in concentrating the bile, which is its primary function. Next, let's see the segments of the liver. As you can see in this 3D model, the liver is anatomically divided into 8 functionally independent segments. Right, I hope you can see all of the 8 segments here. Okay, so let's take a look here. You can see the anterior and posterior view and the segment 4. It is divided in two parts, 4A and 4B. The upper portion is 4A and the lower portion is 4B. This is relevant because for extended cholecystectomy, part of segment 4B and segment 5 is also resected along with the gallbladder. Let's talk about epidemiological triad for the carcinoma gallbladder. Okay, so we'll be talking three components: the host, the environment, and the vulnerable gallbladder. Can anyone tell me what is the most common age in which? Can I move? Okay, so I was asking, can anyone tell me about the age group in which this disease is most commonly found? It is mostly in the later years of the life. From 50s to 70s, you will mostly encounter female. Females are more prone to carcinoma gallbladder, about 1:2 to 3 times more likely than a male to have. And then there is parity, age at first pregnancy, tobacco. Let's talk about the environment. Environment can be infections such as salmonella or H. pylori infections. There can be irritants like red chili pepper or heavy metals, like they are carcinogenic, so they can cause carcinomas like nickel, cadmium, some toxins. And now we'll talk about the gallbladder factors, that is cholelithiasis. Cholelithiasis, as we have discussed before, it is a very common prerequisite for carcinoma gallbladder. Can anyone tell me the type of stones that we encounter in a gallbladder? Yes. Okay. So porcelain gallbladder is also one very important factor in Mirizi syndrome, gallbladder polyp, as Dr. Karthik explained. Okay, now let's talk about sign and symptoms of gallbladder. Usually in the beginning stage of this disease, the sign and symptoms are very vague. It is very hard to diagnose, but if a person were to exhibit the sign and symptoms, what do you think would be the sign and symptoms? The first would be abdominal pain. Usually in the upper right quadrant, right where the gallbladder is you will experience pain. You can see here, this is a referred pain for gallbladder and liver diseases. So you can see the highlighted areas in the red where the pain is marked. Like if a patient tells you that I am experiencing pain here, you can think that this might be related to liver or gallbladder. So there can be abdominal mass that is palpable in the right upper quadrant in advanced stages. Then jaundice because of obstruction, nausea, vomiting, dyspepsia, loss of appetite, weight loss. Fever can be a symptom because it can be secondary to infection or if cholangitis develops. Pruritus due to jaundice. Late features can be hepatomegaly, cachexia, and bone pain in case of metastasis. Okay. Now for diagnosis, we can conduct an ultrasound abdomen, a CT. We can do US guided FNAC, we can perform LFTs, MRCP, laparoscopy. CA19-9 is also used to diagnose. Okay, so here you can see the ultrasound of a gallbladder. Here you can see the gallbladder image and the mass is also. It is, if you see black portions divided by the white thing, the white portion is the tumor. Okay, now let's talk about staging and grading. So for staging and grading, we do a T and M classification. Can anyone tell me what T and M stands for? Tumor, N for nodes and M for metastasis, yes. Okay, first so tumor, it can be TX, T0, TIS, T1, T2, T3 and T4. So TX is when the primary tumor cannot be assessed. T0 is when there is no evidence of primary tumor. T1 is when the tumor invades the lamina propria or muscular layer. You can correlate the tumor sizes with the image that has been provided. Okay, so the level T1 is also divided into two parts, T1A and T1B. T1A, the tumor invades lamina propria, and T1B, tumor invades the muscular layer. In T2, the tumor invades perimuscular connective tissue, and T3, the tumor perforates the serosa and it directly invades the liver and other adjacent organs. For T4, it invades to the main portal vein and hepatic arteries. The next category is N nodes. It is NX, N0, N1 and N2. In NX, the regional lymph nodes cannot be assessed. N0 regional lymph node metastasis ho chuka hai. N1 metastasis nodes along the cystic duct. N2 it metastasizes to periaortic, pericaval and superior mesenteric artery. Metastasis M0, N1, M0 no distance spread, and M1 it has a distance spread. Okay, now stages, it can be from stages 1 to 4B. Okay, so if you look at the stages, we usually operate till stage 2. After that, the disease becomes unresectable. That is T3A, when the tumor size is 3. If we take a look back, so T3 is when the tumor has perforated the serosa. At this point, the tumor is very hard to resect, so it is usually avoided. Now let me give you some information about extended cholecystectomy. Here you can see the extent in which extended cholecystectomy is performed. You can see the gallbladder is removed along with the margin of liver, the blue portion, and you can see the regional lymph nodes that are also removed along with that. 2 centimeters of liver margin is cleared from the liver bed. This is how an extended cholecystectomy looks. You can see the gallbladder and the liver margin that is being resected along with it. Now, okay, here you can see CUSA and bipolar are being used. Why CUSA and bipolar, anyone? Liver is a very highly vascular organ, right? So whenever we manipulate liver, it has a tendency to bleed. So bipolar and CUSA, they are very important instruments. Without them, we usually never operate liver. Next, this is a specimen of gallbladder after extended cholecystectomy. In A and B, you can see the anterior and posterior parts of the liver. You can see the liver margin in the image C. You can see that the gallbladder has been cut open. You can see the stones, as we've discussed that cholelithiasis was an important risk for developing carcinoma gallbladder. You can see the thickened gallbladder and the liver margin and the lymph nodes that have been excised. Okay, now let's move on to the intraoperative nursing role. So for intraoperative nursing role, our part begins when the patient enters the OT and it is continued till the patient has left the operation theatre. Till then the patient is our responsibility and we should do everything we can to provide care to patient. Okay, so I've divided this part in 3 sections. So the first part is before induction of anesthesia. So before induction, it is almost same for all of the surgery. We identify the patient. We identify who the patient is, what the procedure is, what is the site, if the NPO status has been confirmed or not. In this case, now we always ask the patient, what have you eaten? Because I heard from an anesthetist, they said ki aapne kuch khana khaya. So for some patients, na khana is like a proper meal. They will not count if they had 2 biscuits or they had some water. So you need to ask them ki chai, biscuit, pani, if anything they have eaten, because this is something that doctors they have encountered in V2. We identify the patient using a surgical safety checklist. We identify the patient, we cross-check with a wristband, case sheet and consent. This is the WHO surgical safety checklist that we have in our OT. Next is the consent form. This consent form we always verify. Here in the first image, the consent of the patient, the name of the procedure and the date of the procedure under GA or LA is always specified, and the second picture is where the signature of the patient, their relatives and the surgeon is taken. For minors, now there is the second section in which minors and unconscious patients, the consent is taken there. Okay, so before induction, obviously we ask the patient if they have any comorbidities or any allergies, like allergy with any medication or latex allergy. Sometimes we encounter in our OT. Like I said, we verify the NPO status, we confirm that the airway assessment is done, if it is a difficult airway or not. And then we make sure that the equipments are ready, suction, the OT table, the OT lights, cautery machines, etc. All of them should be functioning to ensure smooth functioning of OT. Next, this is a supine position that is given in radical cystectomy. You can see here, the patient here has been cleaned and draped. The midsection has betadine on it. This is a before skin incision. We prepare a basic laparotomy trolley. We use a major all laparotomy set with a vascular set. This is a basic trolley, and these are the instruments that we use for incision. You can see 2 tooth forceps, 1 skin marker, and a scale along with the blade. Now, before skin incision, obviously the patient is painted with betadine and draped with sterile linen using sterile techniques. In this operation, we use 2 machines. One is our Martin cautery machine, and one is an argon beam coagulator. For that, we use 2 grounding pads on patients. The first image is of an earth pad that is applied to the patient. Can anyone tell me where the earth pad should be applied? And? Ma'am has said near to operating area. Okay, so you can see. Yes. You can see here in the image also, this is the circuit that it needs to complete, and we should ensure that the earth pad has been applied uniformly, because if not, then it can also cause thermal injury to the patient. Next, we need a bipolar cautery, harmonics, and monopolar cautery. We use 2 monopolar cauteries and 1 extendable cautery. Our staff from OT, can anyone tell me why do we use 2? Why not just 1? Why 2? Yes, because extendable. Yes. Yes. Yes, in our OT we use 2 for convenience. One can be used for deeper layers and other for skin. Then ligashore and CUSA, like I said, this is a very important instrument for liver surgeries that would be covered in our hepatectomy sessions. And argon beam coagulator, this is an argon beam machine and the probe. Thomson retractor, this surgery requires a retractor like Thomson or Rochard. The preferred one in our OT is the Thomson retractor. After skin incisions, like I said, these surgeries have a tendency to bleed. So we hand over the instruments to the surgeon in a sterile way, making sure that the sterile field is not broken. Then we make sure that all of the needle sponges, we know where they are. This image here is of a multi-fire applicator. They are used for ligating any bleeding vessels. 405 sutures are also used. This is my colleague, she is loading a suture here. Hemostatic agents such as snow, Surgicel, Surgiflow, Flow Seal or Tissel, they are also kept ready in case any major bleed has occurred. Now before closure, we make sure that the final counts have been done with the circulatory nurse. We make sure all of the sponges, tail gauze, needles and instruments are counted. And then we use the following sutures: number 1 Proline, loop nylon, Stratafix, skin stapler. These all can be used. And then thank you.
हमारे पैनलिस्ट इसमें कुछ ऐड ऑन करना चाहेंगे?
हेलो, जैसा कि एक प्रकार से लीवर सर्जरी है, उसी हिसाब से रेडी रहना हमें. ये पार्ट ऑफ ए लीवर सर्जरी. Bleeding is the main concern in this surgery. So the wide range of the hemostatic agents should be ready in this case. like surgical, surgiflow, slow, fibrillar, flowsil, tissue glue, etc. There is a huge area of bleeding, and the liver is a surface organ, so can't able to control the bleeding. So bleeding is the main concern.
So Vaishnavi has covered most of the stuff. I would just like to reiterate that the disease has a very poor prognosis. So in case I have doubt that any patient might have some kind of malignancy, I would rather err on the side of safety. So many times patient come with doubtful diagnosis. We don't do routinely FNAC to confirm the diagnosis. We take up the patient for surgery and plan an extended cholecystectomy, because if the biopsy turns out to be benign, it's not going to harm the patient. And this surgery doesn't have any kind of bowel anastomosis or any kind of anastomosis. So per se post-op morbidity is not expected. So it's a simple surgery if the surgeon knows how to do it. So like I said, I would like to err on the side of safety. Coming to the intraoperative management, like everyone has told before, it is always good for the assistant to know what step is going to happen next. And that is what we expect out of the assistants. So if they know what is going to happen next, they'll know what is to be given. The main concern that surgeons will be firefighting is bleeding. And we are at the porta, when we are doing lymphadenectomy especially, even a small nick can cause humongous amount of bleed. The portal vein bleeds like anything. So during lymphadenectomy, we expect a 5-O-proline to be ready, hamesha. So we can't run for suture at that time. Within seconds, patient will lose liters. So that again adds to the morbidity. So that is one thing that you need to be sure about. Second thing is vessel loops, which I know, everyone will know and they'll be ready with it at that point of time. And when we are at the liver wedge again, like Madan also told, the bleeding is not from a particular point. It's very difficult to control liver bleed. It is from the bed. It is from a wide surface area. Although we take just a 2 centimeter wedge, the wedge is going to bleed from everywhere. We can control the inflow, which is in our hand. We do Pringles. But then the bleed that happens, the back bleed, which they say, which is more important in liver resection, which comes from the IVC, is very difficult to control, and we can't take control of the IVC, which is behind the liver. In such a case, we tend to lift, we ask the anesthetist to give Trendelenburg. So when Trendelenburg happens, the foot is going to hit the Mayo. So that in all liver surgeries, the Mayo should be at a higher level so that the anesthetist is able to lift the foot end of the table. So that needs to be checked before surgery. Rest, like Madan told, we need to be ready with all kinds of hemostatic material at our disposal so that we can control bleed. It's going to be a surface bleed. And finally, as of now, the standard of care is open surgery. Laparoscopic extended cholecystectomy is still not in vogue. There is still evidence that is coming up. Maybe in a few years we might start doing laparoscopic extended as well.
डेलीगेट में से किसी का कोई प्रश्न हो? आपके तो आज मैं पीछे बैठे हमारे सारे डेलीगेट से रिक्वेस्ट करूंगा कि आप प्लीज़ मेंटेन साइलेंस, अदरवाइज अच्छा नहीं लगेगा अगर हम डिसिप्लिन में नहीं रहेंगे, बिकॉज लर्निंग कॉम्प्रोमाइज़ होती है. बहुत लोग हैं यहाँ पे सीखने के लिए आए हैं. और अटेंडेंस शीट में आप जरूर अपना साइन कीजिए. मेल आईडी प्रॉपर लिखना है, बिकॉज सारे जो सर्टिफिकेट हैं वो आपके मेल पे आएंगे. और सारे सेशन अटेंड करना ज़रूरी है. आप कुछ भी मिस करते हैं सर्टिफिकेट नहीं मिलेगा. ये क्लियरली डायरेक्शंस हमारे को ऊपर से दी गई हैं, क्योंकि इस सबका ऑडिट भी होगा बाद में, है ना. तो इसको थोड़ा सा सीरियसली लेंगे हम. तो लोग जी कुछ प्रश्न थे आपके मन में, संशय थे जी?
We just cover all entire surgery. No one asks regarding blood volume.
जी.
हमें ब्लड बैंक में इन्फॉर्म करना है, नहीं करना है, कितने यूनिट हमने अरेंजमेंट है. नो वन टेल. दिस इज अ मिसिंग पॉइंट.
तो इस पे मैं प्रश्न पूछने वाला था, जो मैं जिसके लिए रेडी था. आपने भी बिल्कुल पहले पूछ लिया. मैं ये सवाल पूछना चाह रहा था मोहिनी मैडम से कि एज ए फ्लो नर्स आपके मन में क्या चीज़ें चल रही होती जब ऐसे कॉम्प्लिकेटेड सर्जरीज जब चल रही हो, और जब आपके जो ओटी नर्स है, जो स्क्रब नर्स है, उसको आप कैसे कंसोल करके रखते हो, कैसे मोटिवेटेड करके रखते हो कि मैं पीछे से क्या कुछ अरेंजमेंट कर रही हूँ? कुछ बातचीत होती है आपके बीच में ऐसे?
Yes, sir. एक्चुअली जो भी हीमोस्टेटिक एजेंट्स हैं वो सब ऑलरेडी बताया है, वो हमें रेडी रखना है। और ब्लड के रिगार्डिंग भी एनेस्थीसिया वालों से पूछते हैं 2 to 4 यूनिट्स, वो ऑलरेडी पेशेंट शिफ्ट होता है तभी बोलते हैं कि 4 यूनिट्स ब्लड अरेंज है फॉर दिस पर्टिकुलर सर्जरी। एंड इन केस ऑफ CAGB वी अरेंज दी मशीन्स लाइक क्यूसा एंड आर्गन, वो हम मतलब ज़रूर रखते हैं उस OT में।
जी जी, बहुत बहुत धन्यवाद। इसके अलावा किसी का कोई प्रश्न? किसी? जी मैम प्लीज़।
And those who will be decided to the patient.
डॉक्टर साहब।
So basically, for all malignancies, it is currently recommended to have a multidisciplinary team meeting. So any cancer patient that comes to us, the first part is to stage the disease. We do CT scan. In CAGB, we also recommend PET scan. So once we have the stage at hand, we call the medical oncologist, we call the radiologist, we as surgeons also go there. We call the patient as well. So it will be a combined decision making so that there won't be any mistake. So everyone will give their inputs. What will be best for the patient will be personalized and the care should be personalized. So that is how it works.
It will be after the surgery or before?
Chemotherapy you mean?
Yeah.
That depends upon the resectability of the disease. If the disease is resectable, see, CAGB is a very aggressive disease and it usually does not respond to chemotherapy. So if the disease itself is resectable, we go ahead with surgery upfront. In case the disease is not resectable, it is involving the vessels or the resection is going to cause more harm to the patient upfront, we give them a trial of chemotherapy. So that will downstage or shrink the tumor and later on we can plan surgery for the patient.
Okay, thank you.
So now thank you so much तीनों पैनलिस्ट का। जी हाँ, अब मैडम का भी एक प्रश्न है, जी बताइए।
As we are working in GI surgery OT, so nowadays we are seeing frequently cases of CAGB, and that mentioned acute CAGB. And when we go through the file, that we seen that patient had a 1 month back cholecystectomy. Okay. So I think nowadays is it increasing this, or we can save in the same surgery, like if patient have a cholecystectomy 1 month back, so is it possible that we can save again GA for CAGB, or any method so we can use during the cholecystectomy we can judge that patient can have CAGB or any stage of cancer during the cholecystectomy, normal cholecystectomy?
Meaning
yes,
those that are planned for simple cholecystectomy,
yes.
you're asking if they can be, I mean we can predict if it is malignancy
yes,
or not.
how we can predict, matlab, is it possible to predict the any
Per se, when we go inside and see at the gallbladder, we look at its surface basically. So we are in laparoscopy mode, we won't be able to palpate it. So it is just we'll be going by visual cues. If we are able to make any hard structure, which is difficult on laparoscopy, but experienced surgeons sometimes are able to make out something hard. But that too we can't be sure, because stone also feels hard. After we resect, we might end up seeing a stone. But usually stone moves within the gallbladder. So if there's something there is immobile within the gallbladder and it is hard and stuck at one point, and they fall within the typical clinical picture, say a middle-aged or a elderly female coming from North India, then again, like I said, I would like to err on the side of safety. So I would convert the procedure into open. I would take a liver wedge and then send it for frozen.
yes.
The thing is that we cannot do a simple cholecystectomy if we are suspecting malignancy at any point, because once you breach the plane between gallbladder and liver, there is going to be theoretical risk of malignancy spreading into the peritoneum, which at that stage becomes metastatic, so we can't do anything. So if there is any doubt, it is always safe to do a liver wedge. Nowadays, even surgeons, like I said, laparoscopic extended cholecystectomy is being investigated. So in such doubtful cases, you just take a wedge of liver and send it for analysis. If it comes out to be malignancy, you can do the lymphadenectomy as well. So that is how I would approach it.
I think now is the time when we move to next topic. Thank you so much, all three panelists. अभी थोड़ा डेप्थ में चलते हैं और जीआई की सबसे कॉम्प्लिकेटेड सर्जरीज और ऑल इन ऑल भी सबसे कॉम्प्लिकेटेड सर्जरीज विपल्स आप सभी ने सुना ही है. ट्यूमर ऑफ हेड एंड पेंक्रियाज विपल्स प्रोसीजर के बारे में हमें बताने के लिए है हमारे मॉड्यूलेटर के रूप में मिस कोमल, नर्सिंग ऑफिसर मेन ओटी, और पैनलिस्ट में डॉक्टर यशवंत हैं, कंटिन्यू करेंगे, मिस उर्वशी जी हैं और दीपक सोनी जी हैं.
it is not getting.
ओके है यहाँ से स्क्रीन में तो है.
हाँ. So, very good afternoon to one and all present over here. So, my topic of discussion is CA pancreas with Whipple procedure, which is the primary surgical procedure for CA pancreatic head. So, let's start with the discussion. So, as the topic says, pancreatic carcinoma. So, it is a term that defines pancreas which has cancerous cells arise, and its location is in pancreatic head for 65% of the cases, in pancreatic body and tail for 15% of the cases, and there are 20% of the cases where cancerous cells are infiltrated in pancreas diffusely rather than forming a distinct mass. So a normal pancreas has two glands, as we all know, exocrine gland, which sends digestive enzymes to small intestine, and endocrine glands, which regulate body metabolism, like for example maintaining normal blood glucose level. And over 95% of the pancreatic cancers arise from pancreas's exocrine tissue, of which the tumor arising from the epithelial cells which lines the pancreatic duct accounts for vast majority of cases. And this type of pancreatic carcinoma is called as pancreatic adenocarcinoma due to the cells showing glandular-like appearance under the microscope. Generally, this type of pancreatic carcinoma is formed in head and neck, but sometimes it can be formed in the tail portion of the pancreas. Around 5% of the cases of pancreas's exocrine carcinoma, it is due to malignancy in acinar cells. These are the cells which produce digestive enzymes, and around 1% of the cases it is cyst adenocarcinomas, or we can say malignant cysts. There are also other types of pancreatic carcinoma, but those are even more rare. So generally this pancreatic carcinoma is imposing a significant global health burden with incidence and mortality rates rising over the past 3 decades. While traditionally it was associated with aging, and but the recent data indicates that there is rising or increasing burden among younger population. It is the 12th most common cancer worldwide, and due to poor prognosis, it is the 6th leading cause of cancer-related deaths, which contribute to 5% of all cancer-related fatalities. Although 5-year survival rate has significantly improved because of the advancements in diagnostic and treatment techniques, but still it remains one of the lowest, standing at 12.8% compared to other gastrointestinal malignancies. So what does ICMR say? The age standardized incidence rates for pancreatic carcinoma varies differently across the world, from as low as 0.6 per lakhs person per year in the regions of Asia to as high as 12.6 lakhs persons per year in the regions of West. In India, the incidence of pancreatic carcinoma is less when compared to Western countries. So traditionally associated with age, as I've already explained, or considered as a disease of elderly with a median diagnosis age of 70 years, the pancreatic carcinoma shows a rising incidence among younger individuals. And according to WHO, the death toll due to pancreatic carcinoma is projected to increase in coming decades. So generally these pancreatic carcinomas are caused by genetic mutations in ductal epithelial cells, which can either activate oncogenes which promote cancer, or it can also inactivate tumor suppressor genes. Either way, both will lead to uncontrolled cell growth and multiple immune responses, for example stress responses or inflammation. Although exactly it's not clear why these genetic mutations that trigger pancreatic carcinoma develop in the body, but there are well-known modifiable risk factors to us, such as smoking, which increases the risk by 2 to 5 folds, then obesity and diet high in red meat. Then there are non-modifiable risk factors like being male, being African American, and being over 65 years of age. There are certain diseases which increases the risk to develop this pancreatic carcinoma, like diabetes, chronic pancreatitis, and liver cirrhosis, all of which are associated with high alcohol consumption.
So there does seem to be an indirect relationship between pancreatic carcinoma and alcohol consumption. Other important risk factors are family history with inherited mutations in BRCA2 genetic mutation, which is the most common cause, and second one is PALB2 genetic mutation. Other risk factors include occupational exposure to chemicals, dry cleaning and metalworking industries, and possible infections with H. pylori and hepatitis B, although there are no known significant clinical evidences to support this. Generally, initially the symptoms are vague, like nausea, vomiting and fatigue. There may be a weight loss due to either cancer-associated anorexia or the malabsorption, which is generally due to obstructed pancreatic duct, which can lead to steatorrhea. There is another specific symptom, which is mid-epigastric pain, which often radiates to mid and lower back and often worsen when the patient is lying flat. The symptoms are often affected by the location of the tumor, as if the tumor is present at the head of the pancreas, then it will block the CBD and the bile drainage will be not happening, and in that case the person will be present with obstructive jaundice and he will have loss of appetite, darker urine and lighter stools, and eventually the person may develop this pruritus and may find their skin turn yellow. Other symptoms are Trousseau sign of malignancy, which is when blood clots are felt like small lumps under the skin and over the time may migrate to different locations. Next one is Courvoisier sign, which is when gallbladder is enlarged and palpable, but it is not at all tender to touch for the patient, which is unlike gallstones. This is this sign signifies that the tumor is present in the head of the pancreas rather than in the tail portion. Then if the endocrine function is affected, the new onset of diabetes in older patient signifies there may be the pancreatic carcinoma in the patient. So in majority of instances, the pancreatic carcinoma is diagnosed in symptomatic patients only when it has already spread regionally or distally and no longer is resectable. But if identified at early stages, the lesions may be resectable and initial testing is guided by clinical presentation. Laboratory findings for pancreatic carcinoma are generally not specific, and both serum amylase, serum lipase levels will be elevated. Along with that, tumor markers like CA19-9 antigen and CEA levels will also be elevated. But since these aren't specific to pancreatic carcinoma, so as they may be elevated in the person without cancer, like the person who smokes, so these can't be used for diagnosis. And also when there are some other related problems like obstructive jaundice, in that case the level of bilirubin, alkaline phosphatase and transaminase will also be elevated. Diagnostic imaging help us to identify potentially malignant lesions and evaluate for resectability, that is to assess extent of tumor, the involvement of local vascular key structures and identify metastatic disease. First one is ultrasound abdomen, which is the initially recommended test, and especially if the patient presents with the jaundice. It is highly sensitive for biliary obstruction and large tumors, but it may overlook the small lesions or tumors of pancreatic body or tail. The other diagnostic measures like PET-CT and other advanced imaging techniques can also be used to support and confirm the findings. Then for CT abdomen, we do pancreas-specific triphasic protocol, which has 3 phases. First one is earlier arterial phase, which helps us to evaluate involvement of aorta, celiac trunk and superior mesenteric artery. Through these pictures, one can also appreciate orientation, anatomy and course of vessels which are significant to pancreatic carcinoma. Then next one is parenchymal phase, which helps to evaluate involvement of pancreas itself. Then next one is portal venous phase, which helps us to evaluate the involvement of portal vein and other significant adjacent veins. Then this is the CT of the patient. I hope everyone can appreciate there is one hypodense lesion present in the pancreatic head, and there is sub-centimeter hypodense lesion in the pancreatic body also. This is the another picture, CT, showing the classical double duct sign present in pancreatic carcinoma, specifically the head carcinoma. It is basically because of the obstruction which is caused by the tumor at the head, because of which bile drainage will be blocked and it will lead to dilation of both CBD and pancreatic duct. So for diagnostic confirmation, we do endoscopic ultrasound, EUS, and tissue sampling. This EUS involves a flexible echo endoscope which has a transducer at its tip. It sends the sound waves and then detect them back and then convert the images into the data into detailed images of pancreas and surrounding abdominal organs, and those are then interpreted by the surgeons. Actually, with EUS, we have FNA also. It is a procedure which combines imaging, tissue sampling, and occasional pancreatic cystic fluid sampling. So it is a very important test which helps us in examination of an array of pancreatic conditions. Then we do intraoperative frozen sampling. It is a rapid histopathological examination of the tissue sample which is extracted during surgery. We do quick freezing, slicing, staining, and then tissue sample is observed under the microscope, and all in 30 minutes. It's basically done to assess the surgical margins and identify the nature of the lesion. Then after that, there have been notable advancements in the pancreatic imaging using multimodality approach, although each imaging modality has its own advantages and disadvantages, not only for diagnostic purpose but also for treatment and follow-ups. 3D reconstruction techniques help the surgeons to understand the relationship between tumor and surrounding structures in a better way, and hence make surgery more easier and safer, as it allows surgeon to virtually remove the tumor and mentally visualize the relative relationship among all those structures. Then iterative reconstruction algorithms uses computational processes to reduce the image noise, and that means to eliminate the unwanted image distortion and hence improve image clarity and diagnostic accuracy. Then, as we all know, standard MRI projects the high resolutional images of the anatomical structures of pancreas and abdominal organs, but this functional MRI goes beyond just simply showing the anatomical size and location of the tumor. It provides in-depth insight into biological activity of the tumor and reveal characteristics like cellular density, blood flow, and can even analyze tumor metabolites also. So it aids in distinguishing the benign tumor from the malignant lesion. Then hybrid PET MR combines the PET's metabolic information with the MR's excellent soft tissue contrast and functional imaging to help in improved diagnosis, staging, and also prediction of the treatment response evaluation. These all new techniques are expected to become widely used and to show excellent performance in pancreatic cancer imaging in the near future. So only 10 to 20% of the cases are present with resectable tumors, while 30 to 40% of the cases present with borderline resectable disease, and 50 to 60% of the cases are already which are already having advanced or metastatic disease. The treatment is based on tumor resectability, patient performance status, and comorbidity profile, along with shared decision making and multidisciplinary care. Chemotherapy might also be given as a new adjuvant, that means used to shrink tumor before surgery, or adjuvant as an adjuvant therapy, that is after surgery, or to help those individuals which can't have surgery at all. For the primary surgery for pancreatic head carcinoma is Whipple procedure, which involves the resection of pancreatic head, distal stomach, duodenum, gallbladder, and common bile duct. Then we have pylorus preserving pancreaticoduodenectomy with reconstruction methods like enterostomy, Roux-en-Y, and Billiroth II. For pancreatic body and tail carcinoma, the surgery involves resection of left side of the pancreas with splenectomy. Here our department, in our institution, our department performs minimum 10 Whipple surgeries per month. Then the collaborative, coordinated, and effective effort of the entire surgical team has only one common goal to achieve, that is the safe and successful surgical procedure. And it involves open communication, mutual respect, designated roles, and accountability among all the members. So before surgery, the OT is prepared. This part has been already explained. Cleaning and disinfection of the all surfaces, floor, and OT table is done. Patient is identified according to WHO checklist. Then after putting epidural line, patient is given supine position, and at that time antibiotic prophylaxis within 30 minutes of incision is confirmed. Then deep vein thrombosis prophylaxis and cautery pad placement to prevent cautery burn is done. Then after that, primary preparation is done. The surgical site is exposed, and the site is cleaned in 3 steps. First one is 4% chlorhexidine soapy solution. Then next it is cleaned with spirit, and after that entire surgical site is painted with 10% betadine solution. Then patient draping is done in layers. Firstly, the surgical field is created with disposable OPTs, then with green linen, and then means entire the patient draping is done in such a way that only surgical field is exposed and all other patient body parts are covered with sterile linen. Then preferred incisions for Whipple's procedure are the right subcostal incision with upper midline extension, that is also called Markochi incision. Then right subcostal with left extension. Then midline laparotomy, which is done in patients who have narrow subcostal angle. Then before giving an open incision, surgeons often prefer to do a staging laparoscopy to assess the tumor resectability and to find any metastasis if present, and if suspicious, we send intraoperative frozen tissue sample. Then for open case, the instrument sets are generally have been explained. Laparotomy set, which carries basic instruments, then vascular set, which carries fine instruments along with clamps, basin, and retractor set, that is Rochard or Thompson as per surgeon's preference. This is the picture showing normal laparotomy set instruments. Then vascular set, which include clamps like these are the Bulldog clamps, then Cooley clamps, Setinsky and DeBakey clamps, as well as fine needle holders to do fine suturing. This needle holder is called Castro needle holder. It is used widely in our department, by our department, for fine suturing during anastomosis also. Then this is the picture showing Thompson retractor set. The blades are placed at the incisional site to expose the abdominal organs. Then this is the video showing the Rochard retractor placed. Then this is the final setup for the open case by the nursing team. Energy sources have been already explained. One thing I would like to explain, this harmonic instrument, which is an ultrasonic instrument. It cuts the tissue and coagulate blood vessels simultaneously with the help of ultrasonic vibrations instead of electricity or heat. Then special requirements which we have to keep ready for Whipple procedure are obviously sutures. First of all, sutures are very important. Then for anastomosis and bleeding purpose also. Then the absorbable sutures which we keep ready are Vicryl and PDS. Then non-absorbable sutures like silk and nylon for final closure, and Prolene, which is having a good tensile strength for any potential bleeding, are to be kept ready. Then we use Sutupac of different sizes and LT applicators with clip. The primary function is hemostasis and ligation of the ducts and blood vessels. These clips are made up of titanium or stainless steel and are non-absorbable. They provide a secure and reliable closure and are faster alternative to suturing. Then we also keep ready vascular loops, slings, which have different color coding, and as well as this umbilical tape. The primary function is retraction and exposure. For slings, we also use these slings for identification also. When multiple structures have common origin, to prevent errors, we put slings, and they give us a very good retraction without causing any damage. So this umbilical tape is also very versatile tool. It is passed across the pancreatic neck or body to provide a secure grip, and it allows surgeon to do anterior retraction of the pancreas and hence to visualize portal vein and other significant vascular structures. Then we also keep ready surgical staplers for resection, that is Echelon. We have 2 sizes, 60 and 45, along with NTLC 55 and 75 stapler. Then hemostatic agents are to be kept ready, and drain devices. Then I will quickly brief the steps of the tumor resection. First one, preferred incision is given, then retractors are put, then cauterization is done, and the tumor relation to SMA and celiac trunk is checked by the touch. Then stomach and transverse colon attachments are freed from the pancreas. Then hepatoduodenal ligament is cut, which contains portal vein, hepatic artery, bile duct is dissected, and then GDA is ligated, which exposes the portal vein. Then cholecystectomy is done. Then CBD is clamped, preferably with the bulldog clamp to prevent any bile leakage. And the dissection of portal vein is continued towards the pancreas. Then retropancreatic tunnel creation is also done with gently separating SMV from the pancreatic neck, and this step is avoided when the tumor invades portal vein and SMV. Then ligament of Treitz is identified, and the jejunum is divided. After that, the stomach wall is freed from the omentum, and distal stomach is also divided. For jejunal division, we use echelon 60 mm blue stapler preferably, and for gastric division, we use NTLC 75 mm green stapler. For pancreatic division, we put hemostatic sutures on the either side of the pancreas, and the pancreas is cut with the sharp electrocautery. And after that, the pancreatic head and uncinate process is separated from the SMV, and while doing so, the small veins and vessels are clipped and ligated along the way, and after that, specimen is removed, and any hemostasis bleeding is controlled and hemostasis is ensured. So this is the picture showing the comparison between pre-operative and post-operative situation. Here we can appreciate this is the gray mass showing or depicting the tumor in the head of the pancreas, and the structures which are depicted as transparent will be resected. And in post-operative picture, you can appreciate the final anastomosis. First one is end-to-side anastomosis, which is PJ. Pancreas is sutured to the jejunum. Then second one is HJ, that is CBD is sutured to jejunum. Then next one is GJ, that is gastrojejunostomy, and last one is JJ, that is enterostomy, which is between afferent and efferent loop of the jejunum. And this blind proximal end of the jejunum is closed. This is the video showing loading and unloading of the echelon stapler. This is the video showing loading of the NTLC stapler. This is the video showing firing of the surgical stapler NTLC 75. This is the video showing, actually after firing the stapler, we put LT clips at both the ends to ensure additional tissue compression and hemostasis. So after surgical resection, final closure is done. The internal layers of the abdominal wall are sutured, and then the external closure is done with suturing and skin stapler. So what are the complications of this Whipple procedure? First one is most important, delayed gastric emptying, then anastomotic leak, which is both from PJ and HJ, then exocrine and endocrine pancreatic insufficiency, small bowel obstruction, intra-abdominal abscess or sepsis, GI hemorrhage or iron deficiency, anemia. Post-op stay is for 10 days minimum. In that phase, we have to monitor for the complications, and first follow-up is after 5 to 7 days after discharge. And at that time, wound status, prognosis are also monitored, and histopathological report consultation is also done at that time only, and which helps us to identify the need for chemotherapy. So coming to conclusion, pancreaticoduodenectomy is the sole curative treatment option for most tumors affecting the pancreatic head and uncinate process, periampullary region and distal bile duct. While it is a complex procedure having a comprehensive understanding of anatomy, diagnostic imaging, intervention, surgical procedures, perioperative and postoperative management, and early recognition and treatment of complications, is paramount for optimal patient outcomes. Adequate education for clinicians, nurses, and the entire surgical healthcare team is imperative, emphasizing the need for a multidisciplinary approach. These are my references. Thank you.
I think Komal has covered well about the pancreatic carcinoma. She has well explained us about the diagnosis, symptoms, risk factors, and investigation and treatment, including surgical intervention, even the steps. She has explained us well done, Komal. And we know while removing the part of the pancreas acts as an exocrine and endocrine glands. So both the function of the endocrine and exocrine glands affects after pancreatic jejunostomy. So patient may suffer many conditions after the surgery. So whole success of the surgery depends on the post-operative care is also important. There are many challenges in front of us after the post-operatively, like pain management is very important because of such a major surgery. Patient have much pains, so it must be covered with the PCA or thereafter some oral painkillers. And dietary management is also important because of exocrine and endocrine, both functions are affected badly after the pancreatic jejunostomy. And obviously enzyme supplement is very important to aid in the digestion of fat, carbohydrate, and protein in our intestine. And activity and exercise are also important, starting with some short walks, and after depends on the tolerance of the patient. And overall comes to, then we come to regular follow-up is very important because this is a major surgery, so then patient had to go on for long period to come contact with the surgeons for monitoring of the surgery. Otherwise, I think Komal has well explained us. So round of applause for her. Good, Komal. Thank you. Anything anyone want to ask?
डॉक्टर यशवंत, आप कुछ ऐड करना चाहेंगे?
I think everything was covered, just that I would like to add that the most critical part in the surgery is around the superior mesenteric vein and the vessels. So there are certain markers which can help you know that the surgeon is approaching that part. We generally ask for a blunt tip Kelly with jelly. So once that is asked by the surgeon, you can know that we are on the portal vein. And you need, like I told before, we just need a hemostatic stitch, 5-0 ready at all times from this point onwards. And also you need to remind yourself that whenever it starts to bleed, one hand of the surgeon will be stuck. The first step is to apply pressure. So left hand is automatically stuck. Although we need the suture as quickly as possible, it is equally important that the suture is correctly loaded so that we'll be able to take suture there onwards without needing to adjust it. So that is necessary. Otherwise, I think everything else was covered. Any doubts?
Madam Urushi, आप कुछ ऐड करना चाहेंगे?
I think Ms. Komal has covered very well. As part of OT team, I think all the parts she has covered intraoperatively, she's very well explained it. Nothing to be added. If anybody have any query.
एक क्वेरी तो सभी के दिमाग में ये रहती है ओटी नर्सेज के लिए कि यार ये इतना लंबे टाइम तक इतने बड़े बड़े केस में खड़े कैसे रहते हैं. इसके ऊपर आप ज़रूर बताइए कि मतलब हम तो 1-2 घंटे खड़े रहते हैं तो उसके बाद पानी वानी पीने का चाहे इसी में मौका मिल जाता है. बट ओटी में जब आप विपल्स करा रहे हो तो 4 घंटे 5 घंटे 6 घंटे, तो आई थिंक मतलब वहाँ पे ऐसे लगता है कि डॉक्टर्स और नर्सेज को वहाँ पे सलूट तो बनता है. मतलब तो वो अपने आप को कैसे आप ढालते हो, मतलब ये थोड़ा सा आप बता दीजिए.
सर दिस इज द पार्ट ऑफ आवर जर्नी नाउ. जितने भी हम ओटी नर्सेज हैं, हम लोग स्टार्टिंग में सब रोते हैं कि हम कहाँ फंस गए आगे, लेकिन जब करने लगते हैं दिस इज द बेस्ट आई थिंक इन नर्सिंग पार्ट वी कैन डू. जज्बा है, करना है तो करना है. 6 घंटे क्या 12 घंटे भी खड़े रहेंगे.
नहीं, अभी मैं देख रहा हूँ 1 घंटा बैठने में भी ऐसे लग रहा है कि यार थोड़ा सा बाहर चले जाए क्या. नहीं हो रहा अभी 1 घंटा हो गया 2 घंटे, एक बार बाहर चले जाए. लेकिन ओटी जो नर्सेज है, डॉक्टर्स हैं, मतलब
और सपोज जिसको पता है कि मैं 6 घंटे 8 घंटे जा रहा हूँ, वो अपना इनपुट आउटपुट पहले मेंटेन करके चलता है।
ये बात मैं बोलना नहीं चाह रहा था, इन्होंने कवर कर दी। सभी के दिमाग में यही आता है, यार ये कैसे, कोई डायपर वाइपर तो नहीं है, मतलब चलिए अच्छी बात है, मतलब स्टेमिना होती है। जो बहुत बहुत धन्यवाद। जी जी प्लीज।
Sir, I just want to know, how do you decide when to operate the patient and when to leave him just on the palliative care, in this case particularly?
It is a common thing for all malignancies. Anything which is spread, basically we call it metastatic disease. So when the disease has reached the final stage, there is no point in resecting disease from one part. So such patients go to palliation. If the disease is localized to one part and it is resectable, always surgery is the best thing. Of course, there are other reasons as well to keep the patient up. For example, a patient with 90-year-old guy who's coming to us with a malignancy, his actual lifespan may be 6 or 7 months. So there is no point in subjecting him to such a morbid procedure. That depends upon his performance status basically. It does not mean 90-year-old I won't operate. I'll also see how much active he is, whether he'll be able to tolerate the surgery or not. So it's going to be a mixed decision. It's not just based on the disease as well.
And one more thing, sir, actually we work in OT only, so we don't know about the follow-up of the patient. So I just want to know, what is the success rate or prognosis of the patient after Whipple's procedure?
That's a very, very good question. Actually, we speak so much about Whipple's. It's one of the most researched surgery till date. We call it the pinnacle of surgery and all that. But ultimately, what is going to decide is the tumor biology. So, if you see studies, the 5-year survival rate after a treated Whipple's procedure is 30%. That may be due to multiple reasons, but of course, in most of them, they come back with metastasis. So, what I'm trying to say, it is an aggressive malignancy. Any HPB malignancy, for that matter of fact, is an aggressive malignancy. So, but we can't just say that it's going to come back and defer treatment for it. So, 30 out of 100, I'm going to save 30. Okay. And as time goes on, chemotherapy is taking over. There are better and better chemotherapy, immunotherapy that is coming up, which is able to prevent distant metastasis. So, maybe at some point, our prognosis is going to improve. But at this point, it is still, at post-Whipple's, the 5-year survival rate is 30%.
Thank you, sir, for the answer.
थैंक यू। अभी हम नेक्स्ट टॉपिक पे मूव करते हैं। थैंक यू सो मच हमारे तीनों पैनलिस्ट को और हमारे स्पीकर को भी, कोमल को बहुत अच्छा आपने एक्सप्लेन किया। अभी हमने इसमें 3 एनास्टोमोसिस पढ़े, आपने पीजे, एचजे और जीजे, पैंक्रियाज से रिलेटेड और लीवर और स्टमक से। तो उसी में पीजे को मतलब पैंक्रियाटिक जेजुनोस्टोमी को क्लियर करने के लिए और ज़्यादा एलैबोरेट करने के लिए रूपाली हमारे साथ हैं, और पैनलिस्ट में डॉक्टर कार्तिक हैं, नरगिस मैम है और वैष्णवी जी हैं। तो आप से भी रिक्वेस्ट है कि आप अपनी सीट जो है, पैनलिस्ट में डॉक्टर कार्तिक, नरगिस मैम और वैष्णवी जी, प्लीज। इस सेशन के बाद लंच होगा, ठीक है? तो और लंच के इमीडिएटली बाद, चूंकि हम 1 घंटा लेट चल रहे हैं, तो इमीडिएटली हम टाइम वेस्ट नहीं करेंगे, इमीडिएटली नेक्स्ट सेशन के लिए आएंगे।
Good afternoon, everyone. Myself Rupali Verma, nursing officer. So you have seen in the previous session from the patient when it enters the OT till the resection part, painting, draping, time out, everything we have seen in the last session. So I will not repeat that. So I will continue with the another part, that is anastomosis part. So intraoperative nursing management on PJ, HJ and GJ. So coming to the anatomy as it has been covered already. So I will be highlighting only the parts of the pancreas: head, neck, body and tail. In Whipple's we give incision to the neck part, and in the second picture you can see the borders of the pancreas, inferior border, posterior view. Then this is the posterior view of the pancreas, then posterior surface and superior border. This is the pancreas that you can see. Then arterial supply to the head, superior and inferior pancreatico-duodenal arteries, body and tail branches from splenic artery, venous drainage, drain to portal vein. Okay. So now coming to the main anastomosis, that is pancreatico-jejunostomy. So as you can see in the pictures, this pancreatic duct is been sutured to the jejunum because the major part is been resected out. So pancreatico-jejunostomy is a surgical procedure in which the pancreatic duct is anastomosed to the jejunum, usually to facilitate drainage to the of the pancreatic secretions. So coming to this, what are the indications? As we have seen in the Whipple surgery, this is the part of Whipple surgery. So more indications can be chronic pancreatitis, painful chronic pancreatitis with dilated main pancreatic duct more than 6 to 7 mm, pancreaticolithiasis, stricture of main pancreatic duct, traumatic pancreatic injury, PG as a part of other surgery like we have seen Whipple's procedure, and rare indications like pancreatic ductal stricture due to benign causes like atherogenic, inflammatory, post-traumatic, pseudocyst of pancreas communicating with the pancreatic duct. So what are the types of pancreatico-jejunostomy? So there are basically two types. First is dunking or invagination of the PJ. So if you see, this is a pancreas, so jejunum is been dunked inside it. So pancreatic stump is dunked into the jejunal lumen. Jejunal wall is sutured around the pancreas. So why we do this dunking procedure? If we can't see the duct or the duct is too small, less than 3 mm, we do this procedure. Soft pancreas, fragile tissue, so in this case we do dunking procedure. Then duct to mucosa. Pancreatic duct is directly sutured to the jejunal mucosa. Duct to mucosa alignment is there. This is duct, this is jejunum, direct duct is been sutured. So indications can be when duct is visible and is large, more than 3 mm, firm and hard pancreas, so we can use this procedure. Then dunking. Dunking are also of two types. If we see a jejunum, there is a cut resection part where we have put on the stapler. Either we cut that suture part and then we do the anastomosis, that is end-to-end anastomosis. End of the pancreas and the end of the jejunum. So this is in the picture you can see end-to-end pancreato-jejunostomy. The second one is end to side. End to side, we side of the jejunum, not the suture lining. We don't remove that stapler lining and we then anastomose to the pancreas. This is the duct to mucosa anastomosis. This is the picture. Like we are tying this duct to the mucosa. In this we make an enterostomy by fine tip. I will show later in the picture. So what are the preparations? We have already discussed all the preparations like basic instrument setup. This is a basic instruments like artery, mosquito. You can see over here the slings and the kidney tray, incision tray. Next is vascular instrument. This is also already covered. And you can see in the right corner, there are left corner, there are rubber shots kept over there. So I will be highlighting this rubber shot that I will tell you later. Then this is the retractor. These are the energy sources and the retractors. These all are already covered, so I will be skipping this part. Now colorectal scope. So first we see this video. This is the scope. Colorectal scope. So why colorectal scope? If there is the abnormal biliary anatomy, so we use this colorectal scope. Okay. Now the main part of anastomosis is sutures. So I will be discussing mainly the suture part. This is also the main nursing role in the anastomosis. Number one is 3O or 4-O-proline. Why 3O, 4-O-proline? to oppose seromuscular layer of jejunum to the posterior capsule of the pancreas. This is the pancreas, the posterior capsule is been opposed to the seromuscular layer of the jejunum. So 3-4-proline, these are non-absorbable sutures, so it are being used in this. The next one is 5-OPDS double-ended. It is used for the anterior layer of the duct. Why double-ended suture only? Double-ended because there should not be not inside. So for the anterior layer we use this double-ended suture, and 5-OPDS single-ended for the posterior layer of the duct. And why PDS only? PDS is absorbable suture, or we can say it is a delayed absorbable suture of the life of 6 to 7 months. So it is being used for this anastomosis. This PDS is polydioxanone suture. Now the needle holder and forceps, the main crucial part while handing over to the surgeon for their easy work, that is vascular needle holder. These are small PDS and Proline are small needles, so it cannot be holded in the large needle holders. So we use these vascular needle holders and vascular forceps for the accessibility and for clean work for the surgeon. This is a picture of loading of the suture. Not picture, this is a video. This is how we load the video, load the suture. Okay. Now special requirements. While doing this anastomosis, what are the special requirements? First is eye needle. It is only used in the dunking pancreatojejunostomy. Why only in the pancreatojejunostomy? Only in the dunking procedure. In this, after taking seromuscular layer of jejunum to the posterior capsule of the pancreas, previously place 3O silk on the superior and inferior border of the pancreas, then that thread of the silk is passed through the eye of the needle and taken out via the jejunum separately. So why can't we use a double-ended suture? Because we have taken this 3O silk. This 3O silk comes only for this, comes as a single needle only. So for this we use the eye needle, so we can use it as a double needle. So you can see the picture of eye needle. Now infant feeding tubes. Infant feeding tubes is used for cannulation. What is cannulation? See, these are different sizes of the tubes. Starting from the gray that we can see 5, 6, 7, 8, 9, 10. It is used to dilate the pancreatic duct. And for the identification of the pancreatic duct, we use these infant feeding tubes. And second is fine tip cautery for enterostomy, that I have told, ductal mucosa anastomosis. So this fine tip cautery is being used. Now this is a video of the pancreatic jejunostomy. Cut surface of the pancreas with duct being shown. See, this is the IFT which I have told for the dilation and identification. Now the suture is being taken from the jejunum to the seromuscular on jejunum to the posterior border of the pancreas. You can see clearly. I have told you the suture. Sorry for skipping. I'll play it again. So here, if we are keeping the stage suture, as I have told the rubber shot, these rubber shot are being used to tie this suture, to hold the suture. You can see very well in the video. To ensure the length of the jejunum is equal to the pancreas of the diameter, we use this. Now this is being ligated. Now the duct suture are being taken. See, you can see that there are suture placed, multiple suture are placed. These are being held by rubber shots. Okay, so I'm skipping this video now. Now coming to the hepaticojejunostomy. What is hepaticojejunostomy? As we have seen in the last session, the second anastomosis, the main anastomosis is hepaticojejunostomy. Surgical procedure in which the hepatic duct is connected to the jejunum. It creates a bypass for the bile to drain from the liver to intestine when normal pathway is blocked or removed. As we have seen, we have resected the part. So now this will be drained into the jejunum. You can see in the picture how it is being done. Now what are the indications? Benign causes can be choledochal cyst excision, bile duct stricture, primary sclerosing cholangitis, and malignant causes are cholangiocarcinoma proximal to the bile duct cancer, pancreatic head carcinoma, gallbladder carcinoma with the biliary obstruction. So where HJ is done. HJ is done 5 to 10 centimeter distal to PJ. Where the PJ is done, then we see 5 to 10 centimeter distal, then we do HJ. End of the bile duct to the side of the jejunum. Okay. Now what are the sutures? Again the main part of our nursing officers, the sutures. So posterior layer, for the posterior layer we use PDS, that is absorbable, 4O and 5O, and the knot is inside. Then permanent suture can be nidus to the stone. So why absorbable suture? Because knot is being come inside now. So if we use those suture which are not absorbable, this can be can create stone in later life. So we skip this. Then anterior layer PDS or proline 4O or 5O because knot is outside. So we can use proline, but we prefer PDS because it is absorbable. Because knot is outside, so there is no any chances of the stone formation. So these are the pictures of 5O proline and 4O proline and 5O PDS. Special arrangement for this: if bile leak, smaller sutures like 6O proline and PDS are being prepared, and for this we use Castro needle holder that we have discussed before also. Castro Vigo needle holder. Now this is a video of HJ. Hepaticojejunostomy being done. Corner sutures as again the stay suture stay is taken, but see, you can see the rubber shot. So we have to prepare in the preparation. Now knot is being tied. Okay. Now gastrojejunostomy. Now third anastomosis is gastrojejunostomy. The gastrojejunostomy is a surgical procedure in which the direct connection is created between the stomach and the jejunum. So now we have seen two anastomoses. These two anastomoses are retrocolic. See, if you see, this is the transverse colon. So behind the transverse colon we take the two anastomoses, that is retrocolic. That is PJ and SJ from the behind of the transverse colon, and from the front we take GJ, that is anticolic. Now what are the indications? Indications are obstructive causes, pyloric obstruction or duodenal obstruction, advanced gastric cancer causing gastric outlet obstruction, chronic duodenal ulcer with scarring or stricture, pancreatic head cancer or periampullary carcinoma causing obstruction, elective bypass for unresectable disease as a part of other surgeries like during Billroth's second partial gastrectomy or Roe and Y gastrojejunostomy. So now the sutures, GJ is done in the double continuous layer, 3O-proline and 3O-PDS. By 3O-proline and 3O-PDS. GJ is done 30 to 40 centimeter distal to HJ. The before we have seen that 10 to 15 centimeter distal to the PJ, HJ is done. Now 30 to 40 centimeter distal GJ is done. Now before and after surgery, this you have seen before also. So this is the part. First one is PJ, pancreas to the jejunum. The second one is bile duct attached to the small intestine, HJ, and the third is stomach attached to the small intestine, GJ. Now you can see the number one is, can anybody tell? Number one is? Number two? And number three? Okay. So FJ versus NJ. Feeding jejunostomy, T-tube is inserted for feeding access and fixed by 3O silk or 3O vicryl. So this is the picture of T-tube. Size is decided by the surgeon, but we prefer 12 French of T-tube. Now nasojejunal, also known as fracas tube. You have also heard of fracas tube. This is inserted from nose to the jejunum. It is inserted from the nose to jejunum with the help of the anesthesia. Because this is being inserted during the surgery, so with the help of anesthesia. This is the picture of fracas tube. So which we have to insert, FJ or NJ? So this is only the surgeon's preference. Now drains. Anterior to PJ, we usually keep this Romovac drain, 16-14 French, and posterior to SJ, we keep this abdominal drain, 30-32 French. Now hemostasis. Hemostasis is the main part. After the anastomosis, everything is been done. Now we will see for the hemostasis. So we have to keep ready bipolar, monopolar. Proline 4O should be ready if there any kind of bleeding. Hemostatic agent like Surgicel, Fibrillar, Snow, Tissel, Surgiflow, Flossil as demanded by the surgeon. If any event of anticipated chyle leak, Proline 4O or Ligaclip should be ready. If there by chance any leak. Before closure, we all know sponge नहीं छोड़ने हैं पेट में, so we verify the sponge, tail gauze, slings and instrument count and patency of the drain. Now specimen, this is the main part. Patient आता ही ये specimen के लिए ही है, histopath के लिए. So verify patient specimen, histopathology in formaldehyde solution 10%, and if there is any culture in sterile container, and these should be labeled very clearly. Now closure, abdominal sheath closure by loop nylon, that is non-absorbable suture, you can see in the picture. And nowadays we are using this Stratafix also. This has PDS material, absorbable suture. And after the sheath, we use skin stapler or 3O nylon. This is 3O nylon and this is skin stapler, you can see in the picture. And then the last part is dressing. Thank you.
थैंक यू रूपाली, और बहुत ही अच्छा आपने एक्सप्लेन किया. इसके अलावा आप कुछ इसमें कुछ गैप फिल करना चाह रहे हैं डॉक्टर कार्तिक, नरगिस मैम आप?
I feel the session on pancreas had been really interesting and comprehensive, starting from the Komal's presentation. It was too exhaustive, I would say. I would say it's for probably the person who are preparing for an examination. It was that much exhaustive. Only few points were missing. I will tell her later. And this reconstruction part has been extensively covered as well. This pancreas topic has been very close to my heart, and she's presented so well, and she has even assisted me in so many pancreaticojejunostomies and hepaticojejunostomies. So yeah.
So we'll share this link with the NORCET 9 aspirants.
Definitely.
So
and also, I was not expecting that even Vaishnavi will cover so much of theory about CAGB. I thought it is just intraoperative part, though it is actually very important for upcoming examinations maybe.
So इस पे बहुत ज़्यादा लंच का टाइम हो रहा है, मैं देख रहा हूँ सभी थोड़ा से डेस्परेट हो रखे हैं, मतलब कुछ चाहिए, एनर्जी चाहिए, तो हम बहुत ज़्यादा इसको स्ट्रेच नहीं करेंगे. तो मैं बस इतना सा आपसे एक प्रश्न करना चाहूँगा नरगिस मैम आपसे, कि आप एक बार सभी को बताइए कि ये जो विपल सर्जरी होती है, ताकि लोगों को पता रहे जो बेसिकली जो ओटी नर्सेज नहीं है, कि कितने इसमें स्विचेस आपको यूज़ करने पड़ते हैं टोटल पूरी सर्जरी में, और कितने इंस्ट्रूमेंट होते हैं. देखो आपको ये तो हमें सभी को ही पता है, जो ओटी में काम करते हैं स्पेशली उनको भी पता है कि आपको हर काउंटिंग पूरी करके देनी पड़ेगी, जितने इंस्ट्रूमेंट हैं, जितने स्विचेस हैं, और जितने गॉज और ये पैड वगैरह, स्पंज वगैरह जितने भी यूज़ किए हैं. तो एक बार हम सभी को पता होना चाहिए कितनी बड़ी सर्जरी है और इसमें कितने सूचर्स और कितने इंस्ट्रूमेंट यूज होते हैं. दूसरा वाला
इसमें सूचर्स की कोई कमी नहीं होती. अराउंड 60 to 70 सूचर पर सर्जरी एंड इट इंक्लूड्स एब्जॉर्बेबल, नॉन एब्जॉर्बेबल फॉर ड्रेन फिक्सेशन, and I think it's more than 70 sutures because some sutures we are taking one bite only, so that is why the count becomes more and more.
तो 60 सूचर्स उसमें भी अलग वैरायटी देन काउंटिंग करानी है. आप सोचिए कितना वो स्ट्रेस में होंगे, कितने प्रेशर में होते हैं जो.
And especially for the nurses, it is very difficult to count 60, 70, 100 needles every time she has to take back from the surgeon, and needles are very minute, so it is very difficult. Still we keep counting of all these things. So instruments especially we count always before the closure, and whatever is missing we always inform the surgeon. If it is not inside the abdomen, then it might be on the floor, but anyway we have to search it. If anything is missing, we are not getting it, either it's sponges, tail gauze or instrument or needle. If the minute needle is not there, then we have to get the x-ray or the fluoroscopy of those items, and once it's found, it's good. If not found, we have to inform the surgeon, and it is missing somewhere. If it is not inside the abdomen, then it is missing in the linen or on the floor. But once we are confirmed inside, it's not inside, then we close the abdomen.
वैष्णो जी, आप इंस्ट्रूमेंट के बारे में थोड़ा सा बताएंगे कितने इंस्ट्रूमेंट इसमें यूज होते हैं. सो अभी तो सूचर ही सुने हमने कि 60 समथिंग इतने होते हैं, ये तो मिनिमम आपने एवरेज बताई होगी. इंस्ट्रूमेंट कितने यूज होते हैं?
Sir, instrument count is also a lot in Whipple surgery, and it's not just the sets, right? We are talking about कि हमारे पास towel clips हैं, we have arteries, mosquitoes, ये तो हैं. Plus we have the retractors also. Those Thompson का, I think all of us can relate with Thompson के जो rods होते हैं, they're very heavy for us to lift even sometimes. I think लड़कों के लिए it is a bit easier, but after a 6-hour surgery, lifting that rod becomes a gym exercise sometimes. But हाँ, instruments are also a lot like.
तो मतलब मेल के लिए आसान होता है सर्जरी में असिस्ट करना?
Relatively, maybe a little bit like 19-20
को हटाया जा सकता है.
Strength wise, sir, strength wise.
Politics. There is no difference whether male is assisting or female is assisting. Once
it's
you have a
exhausting,
knowledge
sir, all
of
of
that
us, sir.
procedure, what they are doing, that is.
लंच में जाने से पहले थोड़ा सा एनर्जी के लिए.
All the staff that we have here are well trained enough to handle all the needles and instrument counts. So it is irrespective of male or female, but apparently is this thing of lifting the rods of Thompson, and that is.
नहीं, मेरा प्रश्न इसलिए था कि वो ऑनलाइन जब जाएगा तो पूछेंगे आपने 80-20 वाला क्यों नहीं उठाया. तो बेरोजगारों को ये लगता है कि हम 80-20 हर जगह चर्चा.
I think there should be a solution for it. And Kanish, I would like to tell, in our hospital where I was trained, we were having a female surgical ward, male surgical ward, female medical ward, male medical ward. So that kind of, when we have a wards, we can post accordingly. So I don't think there is a concept of this thing.
हमारे साथ ICU से कौन है यहाँ पे अभी? AB8 ICU से कोई है अभी? AB8. तो ब्रिजेश जी, आप एक बार माइक प्लीज. ब्रिजेश जी को माइक.
ये मेरा ऑनलाइन चला जाएगा.
एक बार माइक लाइए प्लीज. अच्छा दिखा रहा. ओके, थॉमसन रिट्रैक्टर नीचे काउंटर में भी है, तो आप देख भी सकते हैं. जो मैडम वैष्णो जी बता रही थी उसके बारे में सभी को देखना है. विजय जी, विपल्स आपके पास आते होंगे पोस्ट ऑप में, सो क्या चैलेंजेस रहते हैं, थोड़ा सा आप बताएंगे सभी को. मतलब
मेनली पेन मैनेजमेंट का होता है उनका.
इतनी बड़ी सर्जरी हुई है तो ऑब्वियसली पेन मैनेजमेंट. उसके अलावा कुछ और आपकी एक्सपर्टीज जो बताती हैं सबको?
नहीं, पोजीशन का है. अगर उनको पोजीशन एवरी 1 अर्ली 2 अर्ली पोजीशनिंग है वो इम्पोर्टेंट रहता है, और पेन, बस मेनली ज़्यादा यही है.
तो बहुत मतलब चैलेंजिंग होता होगा दूसरे कंपैरेटिवली दूसरे केसेस के.
हाँ, क्योंकि ये लंबा प्रोसीजर होता है तो हमें ज़्यादा से ज़्यादा मॉनिटरिंग करनी है, सारा चीज़ देखनी है, तो थोड़ा ध्यान ज़्यादा रखना होता है इनका.
तो एक बार जोरदार तालियां जो भी इस पूरी केयर में लगे हुए हैं. एक दीपक जी का एक सवाल है, ले लेते हैं, उसके बाद फिर लंच की तरफ हम.
Dr. Karthik, I want to know that suppose after PJ or HJ patient has shifted to ward, and suppose there is a leak, bile leak and pancreatic leak, how, what will be the patient's complaint, and how as a surgeon you will diagnose that, and what will be your step?
ये बहुत अच्छा प्रश्न है कि बाइल लीक अगर हो तो आप उसको अर्ली डायग्नोज कैसे करेंगे, और बहुत चैलेंजिंग भी हो जाता है उस बाइल लीक को मैनेज करना.
This bile leak and pancreatic leak has been defined by International Society for Pancreatic Surgery. We have a few guidelines on that. So on day 3 we do drain fluid amylase, because pancreas secretes amylase and serum amylase and lipase increases. So we do drain fluid amylase, and if the amylase is high, more than 3 times the normal lab value, for Aiims the value is 100. If the value is more than 300, then we know that okay, pancreatic anastomosis is leaking. But it is controlled one. It is, till now it is a simple biochemical leak. Only if the patient develops fever, sepsis or maybe intra-abdominal bleed, you must have heard that Whipple's का patient है, bleed हो गया, OT लेना है, तो वो सब चीज़ें होती हैं. Only if the patient develops bleeding, fever, then only we know okay, this is going towards grade B or grade C. Where grade C, mostly patient dies. That is the morbidity of this procedure, that if patient develops pancreatic leak and he develops post-pancreatic hemorrhage also, the survival rate is just 50%. In hospital survival rate, I'm telling you, 50% of the patient who develops bleeding dies in hospital. ये किताबों में लिखा हुआ है. तो उसको जल्दी पकड़ना is very important. Yes. And regarding the bile leak, again we can do drain fluid, bilirubin, but bile is clearly visible in front of us that we have bile leak. The bile leak is usually managed with the PTBD. We get it done in the post-operative periods. And if we have a high-risk anastomosis, we may stent the HJ and PJ with the T-tube. You must have seen that we take 14 French T-tube and we take it out just after the HJ. So,
okay, good.
Yeah, thank you, Dr. Sahab. Before we go for lunch, there is one announcement to make. एक तो आपका जो 2 पेपर आपके पास आए हैं, अटेंडेंस वाला अलग है, मेल आईडी वाला अलग है, तो आप मेक श्योर कि आपने अपनी मेल आईडी अलग अच्छे से लिखी है. जिनकी ऑलरेडी है बहुत सारे लोगों की, वो दोबारा ना लिखे. और दूसरा, अटेंडेंस के लिए अभी 3 से 6 वाले में एक रैंडम हम एक अटेंडेंस लेंगे जो फुल एंड फाइनल होगी. और तीसरी अनाउंसमेंट ये है कि ये जो सेशन है, अगर जिसका ऑफ है, अगर लेना चाहते हैं तो आप एक बार हैंड रेज कर लीजिए. अगर कल वाला जो सेशन कोई लेना चाहता है तो हमें इन्फॉर्म करना पड़ेगा अरेंजमेंट्स के लिए. कल भी फुल डे हाफ डे सेशन है जेल ऑडिटोरियम में, 4 बजे तक है. उसमें लंच एंड ऑल सब कुछ है जैसे ये वाला है, बट वो ऑडिटोरियम के बीच में होगा. अगर किसी को क्रेडिट आर के लिए या कुछ नॉलेज के लिए अगर किसी को भी लेना है तो कोई बात नहीं, आप लंच कर लीजिए, उसके बाद आप बता देना, मैं दोबारा पूछ लूँगा. ये अभी शायद हमारी इंद्रियां वहाँ लगी हुई हैं. ठीक है, थैंक यू सो मच. अभी हम वापस मिलते हैं.
देख लेना.
अभी लाइव तो नहीं है ना, कुछ लाइव तो नहीं है ना, तो मैं गाना गा दूं एक? अरे यार,
उर्वशी जी हैं यहाँ पे? हाँ, एक बार कॉल कर लीजिए, फिर अगला सेशन शुरू करते हैं। मदन, उर्वशी को बुला लो। और सुनैना जी हमारे साथ हैं, मदन जी, कैलाश जी हैं। हाँ, बुलाना पड़ेगा एक बार, 5 बजे बुलाना पड़ेगा 2 मिनट के लिए तो सर को 5 मिनट। अभी तो लोग नहीं है ना, 5 बजे।
अमित जी, हाँ यहाँ ये थोड़ा सा, हाँ वो, हाँ एक सेकंड, नहीं वो आ रहे हैं, अच्छा आपने पेन ड्राइव दे रखी है ना?
आपका तो ये रहा।
अच्छा वो दे रखा ना इनका।
आप एक बार उनको बोल दो कि वो उर्वशी नाम से जो होगा ना वो इसमें कर दो।
पहले वीडियो बनेगी।
ये रहा आपका,
आपकी यहाँ से समझ रहे हो?
सुनो ये रहा।
ये मतलब
आ गया ना ये, बस आ गया। चलिए शुरू करते हैं पोस्ट लंच सेशन। हाँ बस यहीं बैठ जाओ आप, 1 मिनट बुला, परिचय के साथ बुला लूँगा। तो ऑर्गेनाइजिंग टीम के मेंबर से रिक्वेस्ट है कि वो आप सभी को पीछे जितने भी हमारे डेलीगेट्स खड़े हैं उनको आप बिठाने की कृपा करें। फिर वो उसकी तरफ कोई नहीं देखेगा। ये है असली पॉइंट टू बी नोटेड है, लाइव है, कोई बात नहीं। चलिए तो शुरू करते हैं। लीवर ट्रांसप्लांट हमारा विषय रहेगा पोस्ट लंच में, पहला जो टॉपिक है, और उसको प्रेजेंट करने आ रहे हैं एज ए मॉडरेटर मिस उर्वशी। आप नर्सिंग ऑफिसर हैं एमसीएच ब्लॉक में, और जैसा कि पता लगा कि आपके डेडिकेशन को हम सलाम करते हैं, सल्यूट करते हैं कि आप नाइट ड्यूटी के बाद में भी इस कॉन्फ्रेंस से लगातार जुड़े हुए हैं। और पहली मिनट से एज ए पैनलिस्ट हमारे साथ है डॉक्टर विघ्नेश, आप जे सर्जरी से हैं एम्स दिल्ली से ही, और सुनैना जी इसमें पैनलिस्ट में रहेंगी डॉक्टर विघ्नेश के साथ में, और मदन लाल जी नर्सिंग ऑफिसर मेन ओटी से। सुनैना जी आप प्लीज पैनलिस्ट में ना। मदन, उर्वशी जी प्लीज आप, ओवर टू यू। वो कर देगा वहाँ से। हाँ ये हो गया ना, ये देखो आ गया ना। एक बार स्लाइड को ले लेंगे मेन स्क्रीन पे, आ गया ये वाला, ये।
Good afternoon, everyone. It is truly an honor to be here today to share my experience on a subject that lies at very heart of modern surgical care, liver transplantation. As many of us know, a liver transplant is one of the most complex surgeries performed in the operating theatre. It requires not only the surgical excellence, but also seamless teamwork, coordination, and above all, meticulous nursing care. Our role as OT nurses is not simply about assisting with instruments. It extends far beyond to anticipating the surgeon's need, maintaining a sterile environment, ensuring specialized sets are ready, coordinating multiple teams, and safeguarding the patient at every critical step. In my talk today, we will walk through the journey of liver transplantation from donor preparation and organ retrieval to recipient surgery, vascular and biliary anastomosis, and finally the crucial nursing responsibility that determine patient outcomes. Along the way, I will highlight practical OT management tips, share instrument setups, and show short surgical videos that demonstrate the key steps of transplantation. Most importantly, we will focus on how nursing vigilance and teamwork can prevent complications and contribute to successful graft survival. So let us begin the journey together, looking at liver transplantation not just as a surgery, but as a true example of interdisciplinary teamwork, where nursing is the backbone of the success. Liver transplantation is a life-saving procedure for patients with end-stage liver diseases or acute liver failure. It involves removing the diseased liver and replacing it with a healthy one. The success of this operation depends on not only on the surgeon's skill, but also on the meticulous vascular and biliary anastomosis and strong perioperative support. Here, nurses play a pivotal role in ensuring safety, asepsis, and coordinated management throughout the procedure. The indications for liver transplantation can be divided into four main groups. First, chronic liver diseases like cirrhosis due to alcohol, viral hepatitis, and NASH remain the most common cause worldwide. Secondly, acute liver failure, often caused by fulminant viral hepatitis or drug-induced damage such as paracetamol toxicity, can progress rapidly and requires urgent transplantation. Third, malignancies, mainly hepatocellular carcinoma within Milan criteria, are strong indications. In carefully selected cases, even cholangiocarcinoma is considered. Finally, metabolic and pediatric disorders like Wilson's disease or congenital enzymes defects are important indications in children. For nurses, it is important to understand these conditions because the perioperative need and complications differ depending on the underlying disease. Now, on this slide, we explore the main surgical techniques used in liver transplantation. The first one is orthotopic whole liver transplantation. That is a conventional type of liver transplantation. In this type, the entire donor liver is implanted in the recipient's anatomical position, necessitating 5 precise anastomoses: portal vein, hepatic artery, infra and superior suprahepatic IVC, and biliary tract. Second one is piggyback technique. This variation allows the recipient's IVC to be preserved. Reduce. Sir. The next one is piggyback technique. This variation allows the recipient's IVC to be preserved, reducing intraoperative bleeding and improving hemodynamic stability by performing a single suprahepatic IVC anastomosis. Third one is living donor right lobe transplantation, particularly useful when cadaveric grafts are in shortage. A healthy donor's right lobe is transplanted, requiring reconnection of crucial vascular structures and the bile ducts. This technique demands meticulous preoperative planning and involves risks for both donor and recipient. Fourth one is split liver transplantation, a clever strategy to maximize scarce donor resources. The liver is split into grafts for pediatric and adult recipients, each with customized anastomosis suitable for their anatomical needs. Understanding these techniques is essential for nurses managing the perioperative phase, since each method carries unique procedural, monitoring, and complications profile. Now, this slide is the transplantation procedure for the patient and for the donor. For the patient, when the liver failure patient comes, the patient evaluation is done. If it is suitable, then psychiatric review, independent doctor review, medical and social review. Then transplant ethics committee happens, and then transplantations happen. For the donor identification is being done, surgical and donor evaluation is done, then the process is similar as the patient. Now we will discuss cadaveric liver transplantation or DDLT. Cadaveric donor liver transplantation or DDLT involves retrieval of whole liver from a brain dead donor following consent from the family. The advantages are the entire organ is available for implantation and there is no donor morbidity. However, challenges include donor scarcity, dependency on family decision making, and the need for rapid retrieval with cold preservation. For nurses, preparation is critical. We must ensure the donor OT is ready with all required instruments, double autoclaved sets, perfusion solutions arranged, and aseptic practices followed. We also coordinate with the retrieval team, ensuring a smooth and timely transfer of the organ. In cadaveric liver transplantation, OT management starts at the moment we get information about a donor. We must prepare the OT with strict asepsis and anticipate a long complex procedure. All instruments must be double autoclaved, including the liver transplant donor set, perfusion basin, cut down set, and microvascular set. An ice crusher and perfusion solution like custodial or UW must be arranged before retrieval begins. Energy sources like monopolar, bipolar, and harmonic scalpel are essential. Nurses must ensure all tubings, drains, clips, and hemostatic agents are available. Most importantly, roles must be assigned. One scrub nurse dedicated to retrieval, another to perfusion setup, and a circulating nurse ensuring continuous supply. Attention to detail in preparation directly affects graft's viability and patient outcomes. Now in next few slides, there are pictures of the sets that we use in our OT. This is a LTP donor set. This contains all the basic laparotomy surgical instruments. The next one in the right is the cut down sets. It contains all the fine instruments. The right one is the ice that we use for the perfusion setup. This is the picture of an ice crusher. And this is a video of using the ice crusher. Next, the energy sources like monopolar, bipolar. In the right, this is the custodial solution that we use for the perfusion. This is the donor bag kits that we require, organ bags, energy sources that we have already discussed, hemostatic agents and general items for general surgery. This slide gives a detailed view of the instrument tables arranged for cadaveric donor retrieval. The main working table holds all primary instruments for retrieval. The second table is kept for remaining donor sets and backup instruments. The third table is designated for the ice crusher, where ice is prepared for cooling the preservation of the retrieved organ. This is a video demonstration of the setup. As OT nurses, it is our responsibility to maintain this structure setup so that the surgical team has immediate access to the instruments without any delay. The organization of tables directly impacts efficiency and sterile workflow during retrieval. After retrieval, the donor liver undergoes bench surgery, also called perfusion and benching. The purpose is to check the organ's integrity, repair small vascular or biliary injuries, flush it with the preservation solution, and prepare it for implantation. Nurses must ensure the benching set and the perfusion setup are ready in advance, including cannulas, fine sutures, and perfusion solutions. The organ is flushed with custodial or UW solution while kept on ice to minimize ischemic injury. We also document the cold ischemia time carefully, as this directly influences graft survival. During this setup, our role is to support the surgical team with precise instrument handling and strict asepsis. These are the picture of the sets that we use in benching setup. We have a benching basin. This contains hammer, mosquitoes, needle holder, fine scissors, vascular forceps, metallic cannulas, and dilators. In the OT, we prepare a 3-table setup for perfusion and benching. First table is the working instrument needed for benching, such as vascular forceps, needle holders, fine scissors, cannulas, and dilators. Second table is the perfusion setup, basins with the liver placed on ice, perfusion solution hanged, and metallic cannulas connected for flushing the organ. Third table is ice crusher station. Fresh ice is continuously prepared here to maintain the organ hypothermia and cold stomach protection. As nurses, we must clearly label and arrange these tables to avoid confusion. Since timing and sterility are critical, the perfusion must be done smoothly and quickly, and any delay in preparing the ice or perfusion lines can compromise graft viability. This is the picture of our OT, where the surgeons are doing the perfusion. You can see the main table, working table, the solution is hanged along, and the backup table in the side. This is the video demonstration of perfusion. Now, next is the living donor liver transplantation. It is a procedure where a healthy individual donates a portion of their liver. Typically, the right lobe is donated for adults and the left lateral segment for children. The advantages include the ability to plan the surgery electively, reduced waiting time, and better graft function due to minimal cold ischemia time. However, there are significant challenges, most importantly the risk to a healthy donor and the technical complexity of smaller vessel anastomosis. For nurses, this is logistically demanding. 2 OTs must run simultaneously, one for the donor hepatectomy and another for the recipient implantations, along with a benching setup. Specialized instruments like CUSA and microvascular sets must be arranged. Proper coordination between the 2 teams and vigilant instrument management are vital for a smooth surgery. In living donor liver transplantation, OT management is logistically more complex than cadaveric cases because 2 major surgeries are performed simultaneously. One OT is dedicated to the donor hepatectomy, while the other OT handles the recipient implantation, with a benching station in between. Donor OT preparation, it is similar to a major hepatectomy case. Laparotomy and vascular sets must be double autoclave and sterile linen ensured. Special instruments like CUSA and microvascular sets are essential. For the recipient OT in liver transplantation, preparation is extensive. Key equipment includes energy sources like diathermy, harmonic, and ligashore, along with the infusion systems and syringe pumps. Patient safety is a priority. Warming devices, bear hugger, DVT pump, and pressure gel pads must all be arranged. Instruments are specialized. The recipient set, the Thomson retractor set for wide exposure, vascular and microvascular sets for delicate anastomosis, and miscellaneous items like chittle forceps, cut down sets, and suture packs. General consumable are same. This is the view of a Thomson retractor set that we use in our OT. This is the recipient vascular sets with all the clamps and micro bulldogs that we use. This is the microvascular sets. This particular slide shows the recipient OT table setup. The Mayo stand holds instruments that are used most frequently and must be at hand. The main working table carries the complete recipient set. A separate vascular and microvascular table is kept exclusively for delicate anastomosis instruments. This ensures sterility and avoids mix-up. The Thomson retractor set is arranged on its own table for easy access and wide abdominal exposure is required. A single basin stand is used for perfusion, irrigation, and flushing during the procedure. For nurses, the key responsibilities here is organization and anticipation. Well-arranged table minimizes surgical time and helps the surgeon focus during critical stages like vascular and biliary anastomosis. Now the liver transplantation operation. The pre-incision. Once the recipient is brought to the OT table and prepared under anesthesia, the patient is placed in supine position and draped. The operation begins with the incision, most commonly a Mercedes incision, bilateral subcostal with midline extension. Alternatives include the hockey stick or J incision, particularly in pediatric. You can see this in the picture in the right. The abdomen is explored to rule out contraindications such as peritoneal seeding or infections. Next, the diseased liver is mobilized by dissecting the attachments. Surgeons then carefully isolate key structures, the inferior vena cava above, behind, and below the liver, the portal vein, common bile duct, and the hepatic artery. Finally, the native liver is removed by transecting these structures. For nurses, the crucial responsibilities during this phase include maintaining suction, ensuring availability of vascular clamps, slings, and hemostatic agents, and assisting in efficient instrument handling. This is the animated demonstration of LTP.
एक बार इसका वॉइस चेक करेंगे पीछे से साउंड
Next step is the swing in the new liver. Implantation of the new liver begins with the restoration of blood flow. First, the venous anastomosis are performed. The inferior vena cava is connected either in the conventional technique where the donors suprahepatic and infrahepatic IVC replace the recipients, or in the piggyback technique where the donor's suprahepatic IVC is sewn to the recipient's hepatic vein cuff, preserving the native IVC. This is a video demonstration. प्लीज वॉइस ऑन कर दीजिए. Now next is the portal vein anastomosis. This is an end-to-end re-established venous inflow. This is the movement of reperfusion when graft color and turgor improve. In this, we majorly use 4O and 5O monofilament sutures. This restores venous inflow and immediate graft perfusion. This is the video demonstration. Now the second is the hepatic artery anastomosis, is performed under a microscope with fine sutures such as 7O, 8O and mostly 9O proline. This is the most delicate step. Any thrombosis here can lead to graft failure. The next one is the biliary anastomosis. The commonest approach is a duct-to-duct connection, which maintains the natural sphincter of Oddi function. If the bile duct is diseased or too short, RYHJ is performed. The bile duct heals slowly, and non-absorbable sutures can act as a medius of bile leak, strictures or stones. Mostly we use absorbable sutures like PDS, such as 5O, 6O, and 4O PDS for larger ducts and 6O for pediatric cases. Now, this table summarizes the key anastomosis performed during the liver transplantation and the suture material typically used. As OT nurses, our role is to make sure the correct sutures are opened and ready at the right stage. Misplacement or delay can critically affect the graft survival. Anastomosis like inferior vena cava, we use the 4O and 5O proline. For portal vein, we use 4O, 5O proline, non-absorbable. For hepatic artery, we use 7O, 8O, and 9O proline. For biliary duct anastomosis, we use 5O, 6O PDS. After vascular and biliary anastomosis are complete, the focus shifts to hemostasis and closure. The surgeon inspects all vascular anastomosis and applies hemostatic agents where necessary. Nurses must anticipate and pass these agents quickly, whether it's gel form, Surgicel, or fibrin glue. TEG monitoring guides correction of coagulopathy with FFP, platelets, and cryoprecipitate. Next, the biliary anastomosis is checked for leaks and drains are provisioned close to the site for early detection. Finally, the abdominal drains are placed and the abdominal wall is closed in layers. Throughout this stage, nurses must ensure accurate instrument and sponge counts, prepare drains and suction systems, and document reperfusion time and total blood loss. The final intraoperative phase is critical in ensuring the graft is secure, hemostasis is adequate, and the patient is stable before shifting to ICU. Now these are some real pictures of healthy liver. This is the artery and portal vein. This is the recipient's explanted liver. Donor resected right lobe of liver in the case of LDLT. Resected liver after implanted to the recipient. This is a cadaveric liver during at the perfusion table. This is a cadaveric liver after reimplantation. Now we'll discuss the responsibility of scrub nurse. The scrub nurse is a vital part of the transplant team. Before surgery, the scrub nurse reviews the anatomy and procedure, prepares sterile instrument tables, and ensures all specialized sets like vascular and microvascular instruments are present. During surgery, the scrub nurse assists with gowning, draping, anticipates the surgeon's need, and passes instruments promptly. Because transplant involves delicate microsurgery, handling of the vascular instruments requires special precision. The scrub nurse also maintains continuous aseptic technique and documents essential counts of sponges, needles, and instruments at every critical stage. Finally, tracking irrigation volumes is vital for estimating blood loss. In short, the scrub nurse is the backbone of sterile surgical workflow in liver transplantation. This is my picture during a liver transplantation. Now, we'll discuss the responsibilities of a circulatory nurse. The circulatory nurse ensures smooth coordination in the OT during a liver transplant. Preoperatively, they confirm patient's identity, consent, and blood product availability, and ensures WHO surgical safety checklist compliance with sign-in, time-out, and sign-out. Intraoperatively, they provide sterile supplies, maintain communication between the scrub team and anesthesia, and monitor patient's position, pressure areas, and warming devices. They also play a key role in arranging the blood products and managing rapid infusion when required. Before the patient is shifted to ICU, the circulatory nurse ensures complete documentation of fluids, transfusions, and blood loss. They also double-check that all instruments and sponges are accounted for, and coordinate the safe transfer of the patient with anesthesia and ICU teams. Thus, the circulatory nurse provides a safety net for the entire perioperative process. As we come to the end of this session, I would like to leave you with the one key message. The success of a liver transplant does not rest in the surgeon's hand alone. It is equally dependent on the precision, preparedness, and vigilance of the nursing team. Every instrument we prepare, every checklist we complete, every step of a sepsis we maintain, all of it directly contributes to the safety of our patient and survival of the graft. Our role as OT nurses is not just to assist, but to anticipate, to coordinate, and to lead in maintaining the highest standards of care. I truly believe that with continuous learning, teamwork, and dedication, we can ensure that our patient not only survive a transplant, but also return to a healthy, fulfilling life. Thank you all for your attention and for being the backbone of preoperative care.
Thank you, Urvashi ji. In continuation with this topic, we have a special faculty, Dr. Shilpa ma'am. आप पीडियाट्रिक सर्जन है एम्स में ही और अभी लीवर ट्रांसप्लांट में आपकी एक्सपर्टीज़ होने जा रही है जैसा कि सूचना मिली, तो आप मतलब इसमें क्या ऐड ऑन करेंगे मैम? ओवर टू यू.
So good afternoon everybody. First of all, I'd like to congratulate you all for taking part in this conference. It's going to be a good learning experience for you, and do interact with each other and share your experiences, what goes on in your hospital and what goes on in the other hospitals. So I am Dr. Shilpa. I am basically a pediatric surgeon, and over the last 19 months I'm working at ILBS hospital to undergo liver and kidney transplant too, both. And I'm there for another 5 months. After that, I plan to come back here and start the liver transplant program in children, and also robust that in the adults as well, because children and adults are related. Now the children are up to 18 years. So as soon as the child becomes 18 years, they are donating their liver to their parents, okay? And parents are also giving part of their liver to their children. So till now, you thought that the donor and the recipient is just a mother-father relationship, or maybe a sister-brother relationship. Can you think of more? It's going to be interactive. I don't have any slides to present. I'll just take 5 minutes. It will be interactive. Have you thought of other relations in India which will be offering to give their part of their liver? Friends are not acceptable as per law. Spouse, okay, spouse are giving. Yes, what else? Grandparents, yes. Last week we had a grandmother, she was 52, give to a child. In-laws are giving, yes. So the father-in-law is giving to the daughter-in-law. The daughter-in-law is giving to the father-in-law. the mamas are giving, the fufas are giving, the nieces are giving to their mamas and mossas, and you know, so these are also going on. So vision is going to get horizoned in India. And how can they give that? Suppose I ask you, can you please give a liver, part of your liver, to somebody in your husband's family or your future somebody's family? What would you think of? First of all, counseling, your safety. So the team should be good enough that you know that for whom I'm giving the liver, that patient is going to survive, and I myself also will survive. So liver transplant program begins with fitness. Those people who are counseling also have to be fit. You know, how is weight related to the liver donor and recipient? Any idea? Answer karo, tabhi aage badhenge. How is the weight of an individual related to the liver transplant program? अगर कोई obese आ जाए और आप उनको वो कहें I'm ready to give the liver, मेरा blood group is same, मेरा liver ले लो. Okay, fatty liver number 1, very good. Metabolic liver disease हो जाता है. और consumption of alcohol and all those things are also there. What else? और सोचो. Hypertension diseases तो छोड़ो, सिर्फ I'm talking about obesity, weight gain. So the liver, they're going to give half of it. They will be left with only half of the liver to take care of the whole body. They will not survive. Okay, so first, most important thing in counseling is weight loss kariye, and they have programs to do that. They can make somebody lose weight 15 to 20 to 30 kg within 2-3 months. And similarly on the recipient side, if previously he had ascites, big liver, whatever, and another liver comes in, that liver is not a full liver, it's only half of a liver. So he also has to reduce weight. So when you are monitoring, you have to tell them, you know, you have to give your liver, so you have to reduce your weight. You have to take a liver, so you have to exercise. Muscles are very important. When there is liver disease, sarcopenia occurs. So here all your nursing role comes into play. And the whole team has to speak in one language. Even if you are new to that system, you don't have to say, I don't know kya hoga. Most likely bach jate hain, है ना? शायद 10% में कुछ प्रॉब्लम हो. The moment you go on the negative side, nobody is going to, कोई आएगा ही नहीं हॉस्पिटल में. So ILBS is a positive hospital in that way. I have not heard anybody saying कि नहीं liver transplant मत कराओ, you know, and even in the OPD everywhere. So then हम दे सकते हैं liver. Open रहो, because you know this is science and you know that the results are good, and to have good nursing care and everything, we all have to work as a team. Not only the nurses, there should be programs for the technicians as well. The people who are handling the machines, the orderlies as well. So you see orderlies going under the table looking at the urine bag. 2 drop urine aa gaya, 5 drop urine aa gaya. So that's the kind of system. And you don't have to look up ki koi circulating nurse hai ki nahi, abhi us OT mein hai. No excuses, you're there. So you have to see the trolley and the things which are in place. Kuch niche gir gaya, to somebody has to be there to pick it up. You know? So when you talk about children, sabse important kya hai children ke liye? Temperature, excellent. Huh? So the OT temperature, सबसे पहले. Then the baby temperature. Then you have warmers. कितने warmer लगाते हैं बच्चों को? बेर अगर 1 लगाएंगे, 2 लगाएंगे, तो adults को भी, है ना? So वहाँ पे 2 भी लगा देते हैं, depending on the temperature. So अगर temperature बढ़ जाता है, फिर 1 कम कर दो, है ना? फिर बढ़ गया तो बंद भी कर देते हैं, ये नहीं कि warmer चल रहा है तो चलता रहा. Somebody has to monitor all that. Okay, blood group क्या है? Everything is written. So there are people to note down the timings of everything, charts हैं. Everything has to be done like a harmony. Okay, you have a team, you know आपको क्या करना है. आपने एक important चीज़ नहीं बताई अपने presentation में. It was a good presentation. पर operative cholangiogram, है ना? तो gallbladder को काट के cholangiogram करते हैं कि उसका ductal anatomy क्या है ना? कितना लिवर निकल सकता है कि नहीं. और वो सबको देखना है, नॉट ओनली डॉक्टर्स ड्यूटी. वहाँ कोई एक्सरे होता है तो सब लोग पहुँच जाते हैं, 15 लोग देख रहे हैं एक्सरे में 2 डक्ट है, 3 डक्ट है, क्या है ना? सो ये एनाटमी पढ़नी है. डोंट थिंक इट्स नॉट पार्ट ऑफ माई टीम. एंड द नर्सेज हैव टू हैव ईगल्स आई. Okay, so you have to see and learn, and it goes in your brain. कुछ बोलना नहीं है, कुछ नहीं, understand करो. एक चीज़ चाहिए, एक अगर लगाया तो next is also ready. So you are working like this, like this, like this. पीछे से कुछ और, okay? So you have to become. Everybody cannot do that, है ना? Multitasking करना पड़ता है. So everybody cannot do that. So you have to see मैं इस काम के लिए बनी भी हूँ कि नहीं, है ना? Stress free होके, अपने passionate होके ही कर सकते हैं ऐसा काम. Everybody has to be together and to sink in. And anesthesia side पे भी similarly, they also need all the help. Benching में you have to keep even the vein flons. Hepatic artery का कितना diameter होता है? कितना क्या जाएगा उसके अंदर? कौन सा cannula जाएगा? किस size का? 1 mm, okay, so 22 venflon, 20 venflon, sometimes even 26 venflon when we do pediatric. इतना छोटा, sometimes even no venflon goes. बताओ हवा में hepatic artery है. So you have to take care of all those things. And we are working in a government hospital, so they are new residents. You have to make sure that you do not touch things which are not needed. थोड़ा सा पकड़ लिया तो बंद हो जाएगी ना hepatic artery जब 1 mm ही है. So just keep everything under control. Don't think we are not, it's a big team. You're equally part of the team to say yes, no, go ahead, stop, or you need a break, you know. And breaks भी होती हैं बीच में. Sometimes the liver is too big, so we have to wait कि edema कम हो जाए. We'll wait for 1 hour, no problem, break time, announced. ये नहीं कि जल्दबाजी है, बहुत ख़त्म करना है, फटाफट घर भागना है, ऐसा नहीं. ख़त्म करते ही 11 बजे भी दूसरा पेशेंट आ सकता है ना. So you have to remain geared up for that. और कोई questions हैं आप लोगों के मन में तो you can ask. In a good center, 90-95%. इंडिया में इतने हो ही नहीं रहे ना. इन होल इंडिया सबके एवरेज निकालोगे तो इट विल नॉट बी सो गुड बिकॉज पीपल आर लर्निंग न्यू सेंटर्स में. इफ दे डू 3 एंड तीनों चले गए तो दे स्टॉप इट फॉर एवर. सो महाराष्ट्र में देयर वाज अ सेंटर विच दे जस्ट स्टार्टेड 3 करे इन अ रो एंड दे ऑल डाइड. दे स्टॉप्ड इट, है ना. वी कांट टेक रिस्क लाइक दैट. एंड नाउ डेज चिल्ड्रन आर हैविंग हेपेटाइटिस ए. इट्स नॉट ओनली बिलियरी एट्रिजिया. बच्चे बाहर खाना खाते हैं, स्कूल के कैंप में कहीं जाते हैं, किसी ने कुछ खिला दिया और लिवर ख़राब. Within hours their parents have to come and give the liver. कहीं फादर कहीं और काम कर रहे हैं कुछ और, and they have to be ready for it. 7-8 साल का बच्चा बहुत प्रेशियस होता है ना. और वो I never knew before I went there कि hepatitis A भी इतना dangerous हो जाता है. Usually we thought jaundice है, ठीक है, it will be okay in a few days, but that's the one of the most common causes now. 1 per month तो हो ही रहा है. यहाँ पे भी आते होंगे पर, है ना. And referrals come from all over the country for that. और कोई questions? So get yourself vaccinated. January 2026. Here, yeah. MCH and here also. वही तो मैं बता रही हूँ. Wherever we get the adequate facilities, it is not only that. The post-op care is also important. So the ICU will be there. So in the ICU, it will not be a big ICU. It will be 2-bedded ICU. The nurse has to be there watching. And you have to motivate. जिसने liver दिया उसको next day सबसे पहले आप ही दिख रही हो ना, है ना. तो उसको जूस पिलाना है, उनका ध्यान रखना है, उसको फिजियोथेरेपी करानी है ना. वो भी प्यार से. सो पेशेंट्स आर वेरी मतलब क्वाइट, कोई शोर नहीं मचाएगा. उनको बाहर निकालना है. बच्चे इतने प्यारे होते हैं जब वो ठीक हो जाते हैं. यू सी देम वॉकिंग, रनिंग, फिर लगता है अरे वाह ये तो बिल्कुल इसका ज़िंदगी बदल गया. इट वॉज अ डार्क चाइल्ड विद एन एसाइटिक लिवर, येलो आइज, एंड सडनली दैट चाइल्ड इज सिंगिंग सॉन्ग्स एंड रनिंग फ्रॉम हेयर टू देयर, है ना. सो इट गिव्स लॉट ऑफ हैप्पीनेस. एंड द पीडियाट्रिक लिवर वो बंद नहीं होता लिवर, तो उसमें थोड़ा सा बैग लगाना पड़ता है ना. फिर वो उसका ध्यान रखना पड़ता है, कभी इन्फेक्शन नहीं होना चाहिए उसमें. वो 2-3 दिन बाद फिर बंद करते हैं पूरा. हेपेटिक आर्टरी करी, सबने इतनी मेहनत करी, फिर वो कलर डॉपलर वाले आए, उनको दिख नहीं रहा फ्लो, है ना. तो दोबारा करना पड़ेगा, नो प्रॉब्लम, टिल यू गेट एडिक्वेट फ्लो. एंड ईच एंड एवरीथिंग ये कब हो सकता है? जब सब खुश हों ये काम करते वक्त. ये नहीं कि गुस्सा चढ़ा हुआ है या दिमाग कहीं और है. अगर घर में कुछ प्रॉब्लम है तो टेक हेल्प, चेंज, कम बैक. एंड ऑल देयर फोन्स आर विद समबडी एल्स. अपना फ़ोन अपने पास रखना ही नहीं, ताकि कोई टेंशन ही नहीं हो, है ना. एंड स्ट्रीमलाइंड, पता है 2 घंटे बाद कोई आ ही जाएगा रिलीव करने. फॉर द डॉक्टर्स, फॉर द एनेस्थेटिस्ट, फॉर एवरीबडी. एंड यू हैव टू बी स्ट्रॉन्ग. ये नहीं खाली पेट आ गए बेहोश हो गए ठीक है. एंड वेटिंग, कई बार वेट करना पड़ता है 2-3 घंटे. पेशेंट ठीक नहीं हुआ, अभी फीवर है. नॉट कि जल्दी जल्दी ले लो, लेना तो आज लो नहीं तो कल लो, नहीं. सो वी आर वेटिंग कि वो पेशेंट का फीवर उतर जाए, देन वी विल टेक इट टू द ओटी, है ना. एनी अदर क्वेश्चंस? हार्मोनिक है, सक्शन का बताओ. तुम सक्शन का बता सकती हो? बड़ा सक्शन रखना है, छोटा सक्शन रखना है? फॉर एडल्ट ऑल्सो? हाँ, तो यू हैव टू कीप 2 सक्शंस फॉर बोथ प्लेसेस, है ना. बड़ा भी छोटा भी. सो बीच बीच में वो चेंज भी होगा. और जब वो छोटा सक्शन होगा वो ब्लॉक भी होगा. या सो वो ब्लॉक भी होगा, तो बीच बीच में उसको फ्लश करके उल्टा करके ब्लड भी निकालना है. बिकॉज वो क्लॉट रह जाएगा तो डेलिकेट पार्ट आप लिवर काट रहे हो, सक्शन ही नहीं हुआ तो कैसे कॉटरी लगेगा? कॉटरी चलेगा ही नहीं, है ना. और कोई क्वेश्चंस? गॉल ब्लैडर तो निकल गया, गॉल ब्लैडर को नहीं करना कुछ, है ना. सो पोर्टल वेन 2 में डिवाइड होता है. सो अगर राइट लिवर ले रहे हैं तो यहाँ पे एक छेद रह जाएगा, उस छेद को बंद करेंगे. सिमिलरली डक्ट्स का यहाँ पे छेद रह जाएगा, वो छेद को बंद करेंगे. और पोर्टल ट्रैक्ट्स होते हैं वो लीक ना करें, उनको बंद करेंगे. वेसल्स तो पहले ही आपने आराम आराम से बंद कर ली. जो बड़ी वेसल है उसको फिर आप वो करेंगे, वो मिडिल हिपैटिक वेन को इधर ही छोड़ेंगे, इधर नया बनाएंगे विद द गॉटेक्स पैच. हाँ, donors will not have gallbladder if they have given part of the liver. If they have given for a child, then they will have, because वो left laterally लिया है उसमें तो, है ना. इसलिए अपने गॉल ब्लैडर्स भी बचा के रखे हैं. स्टोन्स नहीं होने चाहिए, खाना अच्छा खाइए, फास्टिंग मत करिए. फास्टिंग से गॉल स्टोन्स होते हैं, पता है कि नहीं?
पता नहीं.
नहीं पता ना. देखो, एज अ being in the medical field, you should know that. So if you fast for a long time, at least drink water. Let the gallbladder function. नहीं तो वो पड़ा है वहाँ पे, बाइल थिक हो गया, स्टोन्स ही बनेंगे और क्या होगा. स्पेशली नॉर्थ में जहाँ पे हमारे हार्ड वाटर है ना. और बना तो टाइम से पकड़ लो तो UDCA खाओ, पिघल जाएगा स्टोन. एक्सरसाइज करो. सबसे बड़ी प्रॉब्लम हमारे देश की ये है. जितना खाना ज़रूरी है उतने एक्सरसाइज ज़रूरी है. 1 hour डेली, है ना. यू डू दैट. सो अगर OT में रहना है आपको 10-10 घंटे, तो गर्दन, कंधे, कमर, टांगे सब जाएंगी, है ना. सो बीच बीच में जब ब्रेक्स मिलती हैं, एक्सरसाइज. नोबडी स्टॉपिंग यू, है ना. And then you have these tools at different levels for different people with different heights. And Thomson retractor, ये नहीं कि retractor लगा दिया हो गया काम. वो बच्चे के अकॉर्डिंग होना चाहिए. एक्सरे मशीन आएगी, वो वहाँ पे फिट होनी चाहिए. ये नहीं कि वो अटक गई बीच में, है ना. कैथेटर सब ढंग से लगे होने चाहिए, नहीं कि बंद हो गए. जितनी भी लाइंस गई हैं सब ठीक से टेप होनी चाहिए. यू आर नॉट गोइंग टू डू दैट. सो द OT टेक्नीशियंस आर डूइंग दैट, है ना. दे शुड बी, उनका भी एक अलग से चलता है सिस्टम, एंड दे हैव टू रिमेन अपडेटेड. तो वो एक दूसरे को पढ़ाना होता है कि देखो ये नया आया, ये वाला पैड ठीक लगेगा, रुक जा मैं तेरे को बताता हूँ, ये वाला ठीक लगेगा, है ना. ये नहीं कि तू कर ले मैं उधर कर रहा हूँ. 1 person नहीं. Whenever you have 2 people, you communicate and you learn, है ना. Yeah, be a team. Type of needle holder. Each suture will have a different type of needle holder and a forceps. और कोई questions for any other surgeries?
हम कितना % लीवर निकाल के मतलब रेसिपिएंट को देते हैं? 50, just 50%.
50 is rough idea. So you take the weight of the liver. वो liver weight लेते हैं, recipient का कितना है. So average 0.8 उसको मिलना चाहिए, 0.8 ratio में मिलना चाहिए. So right और left का दोनों calculations होता है. तो किसी का लेफ्ट छोटा, हर एक इंसान अलग से, किसी का लेफ्ट छोटा है, किसी का राइट बड़ा है ना. तो उसके हिसाब से कौन सा सूट कर रहा है वो डिसाइड करते हैं प्री ऑपरेटिवली. बट द डिसीजन में चेंज ऑन टेबल एंड आफ्टर द कोलेंजियो. इसलिए दैट इज द डिसीजन. पहले खोल के रखते हैं, यानी कि दूसरी साइड स्टार्ट हो गया. डोनर साइड में खोल के रखेंगे, लिवर चेक होगा, लिवर ठीक है भी नहीं, कोई और ट्यूमर तो नहीं है, कुछ और तो नहीं है पेट में जो पिकअप नहीं हुआ. फिर उधर यस हो जाएगी कि हाँ लिवर ठीक है ना. फिर उधर रेसिपिएंट स्टार्ट हो जाएगा. फिर इधर कोलेंजियो करने के बाद, जब गॉलब्लैडर हटेगा, कोलेंजियो करने के बाद हमने राइट प्लान किया था इसका क्या है, ये एनाटमी, ये जाएगा, तो इसका उतना मोटा है भी कि नहीं, AP डायमीटर अलग से दिखता है ना, थिकनेस, इसका लेफ्ट चल जाएगा उसके लिए, चलो ठीक है. सो हम लेफ्ट ले लेंगे.
Another thing is, if it is in pediatric, there is no adequate flow next day. Then again we need to
again no flow means go to the theater. Next day तक भी वेट नहीं करना.
Okay.
Every 1 घंटा 2 घंटे में देखना है फ्लो ठीक है कि नहीं है, सबसे इम्पोर्टेंट. हेपेटिक आर्टरी पोर्टल वेन, है ना. सो यू हैव टू बी वेरी केयरफुल एट दैट टाइम. अगर उस टाइम भी लग रहा है ठीक नहीं तो उस टाइम भी काट के करेंगे दोबारा. एंड वो बताए ना 1 mm. ओके. एंड उसमें लगेगा 80 सूचर, वो भी 8-10 लगेंगे.
मतलब क्लॉट निकल आएगी क्या मैम उसी में? मतलब उसी में क्लॉट बन गया तो उसमें वो निकल,
क्लॉट बनेगा तो खोलेंगे, क्लॉट निकालेंगे, थोड़ा सा फ्रेश करके फिर से करेंगे.
थैंक यू.
ठीक है. एंड यूरिन आउटपुट आना चाहिए. और जब लिवर हटा और नया लगा, उसको भी ठंडा, जो लेके आए हैं वो भी ठंडा बर्फ में रहेगा. जब तक एनास्टोमोसिस नहीं होगा वो ठंडा बर्फ में रहेगा. ओके. सो यू हैव गॉस पीसेस इन आइस. ये आपने बहुत छोटे बाउल दिखाए, बाउल्स ऑफ दिस बिग, जैसे आटा गूंथते हैं ना. हाँ, तो बिग बेसन्स. हाँ, तो वो भी खुशी से करना कि मेरा काम आज आइस क्रश करने का. आवाज़ आती है. एंड द सिस्टर उस देयर शी शुड केयर फॉर के आइस स्टार्ट कर दो, है ना. एंड ईच टाइमिंग हैज़ टू बी नोटेड. और सब खुशी खुशी करना. अच्छा, गुड. ठीक है. टेक केयर. थैंक यू.
बैठिए. थैंक यू सो मच मैम. आपने बहुत कुछ चीज़ें हमें बताई हैं. और आपने बताया मैम किडनी ट्रांसप्लांट भी आप वहाँ पे अभी शुरू करेंगे एम्स में, मतलब बच्चों के लिए. तो मेरा प्रश्न मैम, अगर आप यहाँ बैठ जाएंगे तो हम मतलब यहीं से सवाल जवाब हमारे यहीं से हो जाएंगे, थोड़े से अच्छा भी लगेगा आपको भी, सभी को. तो मैम बच्चों में किडनी ट्रांसप्लांट मतलब रीनल ट्रांसप्लांट और लीवर ट्रांसप्लांट, इन दोनों में आप क्या मेजर डिफरेंस देखते हैं? मतलब
बहुत जल्दी लाइफ में पता लग जाती है, जैसे बिलियरी एट्रीजिया हो और एक वायरल हेपेटाइटिस। दूसरे मेटाबॉलिक डिजीजेज हैं। मेटाबॉलिक डिजीज में भी तभी एडवाइस होगा अगर उसकी आगे की आयु अच्छी है, अगर उसका दिमाग अच्छा है और कोई उस मेटाबॉलिज्म के कारण उसको कोई प्रॉब्लम नहीं है तो अर्ली एज में होगा। और वो लिवर लंबा चलता है, 20, 30, 40 साल शायद ज़िंदगी भर भी चल जाए, है ना। किडनी में ये फ़र्क है कि किडनी ट्रांसप्लांट की लाइफ 10-15 साल है, तो हम किडनी डिजीज़ को लंबा तक कोशिश करते हैं कि जब तक उसकी खुद की किडनी है उतना वो खींच ले एंड देन उसको ट्रांसप्लांट हो। जैसे किसी की सिंगल किडनी है, उसमें कम फंक्शन है, धीरे धीरे उसको कोई प्रॉब्लम है, जैसे पोस्टीरियर वेल में दोनों किडनीज खराब हैं, तो जितना वो चल सकता है उतना चल जाए, फिर किडनी ट्रांसप्लांट हो। और एक ओपन माइंड के साथ हो कि शायद 10-15 साल बाद रिपीट करना पड़े। लोगों के 3-3, 4-4 बार भी किडनी ट्रांसप्लांट हो चुके हैं, यू नो, आफ्टर 10-15 ईयर्स चेंज। सो इफ देयर इज फैसिलिटी इज ऑल पॉसिबल। एंड जैसे विल्म्स ट्यूमर आपने देखा है, बायलैटरल विल्म्स ट्यूमर हो तो दोनों किडनी गई, हम लोग एक निकालते हैं, एक में से आधा निकाल देते हैं। आगे जाकर उस बच्चे का क्या होता है, आफ्टर 1 ईयर कीमोथेरेपी भी चली, साइड इफेक्ट्स हुए, 0 किडनीज, है ना। सो ऐसे बच्चों के लिए आप किडनी पूरी बाहर निकालो, जितना ट्यूमर है उसको निकालो, वापस जोड़ दो, ऑटो ट्रांसप्लांटेशन। सो दिस विल रियली हेल्प एंड इट्स गोइंग ऑन इन द वर्ल्ड। मतलब 45 ईयर्स से चल रहा है, हमने अभी तक शुरू ही नहीं करा, सोचा भी नहीं।
क्या इंडिया में आप जैसे सर्जन और भी हैं जो लीवर और किडनी दोनों को एक साथ करने जा रहे हैं?
हाँ हैं, एक हैं। और
क्या हमारे एम्स में?
साउथ में नहीं, एम्स में भी नहीं है।
तो एक बार मैडम के लिए,
एम्स में किडनी ट्रांसप्लांट तो हो रहा है
मैम, 5 महीने के बाद ऑफिशियली होगी ना।
डॉक्टर प्रांजल मोदी।
तो एक बार जोरदार तालियां मैम के लिए।
हाँ जी,
डॉक्टर विग्नेश
प्रांजल मोदी दोनों कर रहे हैं।
जी जी।
हाँ,
तो
और नारायणा हृदयालय में हो रहा है जहाँ पे लिवर किडनी दोनों करते हैं एडल्ट टीम में।
डॉक्टर विग्नेश, आपने बहुत सारे लिवर ट्रांसप्लांट में ऑब्वियसली असिस्ट किया होगा, आप पोस्ट ऑप मैनेजमेंट भी आप देखते होंगे, तो बेसिकली क्या उसमें अलग से ऐसा स्पेशलाइजेशन चाहिए नर्सेज के अंदर जो आप देखते हैं कि उनमें ये चीज़ तो अलग से होनी चाहिए?
नहीं, द मेन चीज़ जो लिवर ट्रांसप्लांट में है वही है, द पेशेंट्स आर इम्यूनो कॉम्प्रोमाइज्ड। तो मेन चीज़ जो है हमारा, वील हैव टू बी वेरी मच फॉलोइंग द ये सबसे हम रिवर्स बैरियर नर्सिंग बोलते हैं, तो वील हैव टू फॉलो दैट ताकि इन्फेक्शंस ना हो जाए। एंड एज मैम वाज टेलिंग एंड एज इवन सिस्टर वाज टेलिंग आउट, तो इनिशियल 2-3 डेज जो है हम पेशेंट वेंटिलेटर में रहते हैं, फिर उसके बाद एक्सट्यूबेट करते हैं, तो वो पूरा बेड साइड रह के 24 आवर्स वो नर्सिंग केयर चाहिए होगा। एंड उसके बाद फर्स्ट वीक 2 वीक्स के लिए न्यूट्रिशन बिकम्स वेरी वेरी इंपॉर्टेंट फॉर द लिवर टू ग्रो, पर्टिकुलरली इन अ केस ऑफ LDLT वेयर जो लिवर रीजनरेट होना है फास्ट, तो लिवर रीजनरेट होगा तभी वो लिवर फेलियर वगैरह का सिम्टम्स नहीं आएगा। तो न्यूट्रिशन अगेन बिकम्स अ वेरी इंपॉर्टेंट पार्ट पोस्ट ऑप में।
जी, D6 से हमारे पास यहाँ बहुत सारे बच्चे होंगे, आई थिंक कैंडिडेट डेलीगेट्स में। D6 से आप एक बार मैम प्लीज आप खड़े होंगे, आप थोड़ा सा बताएंगे लिवर ट्रांसप्लांट में जब आप पोस्ट ऑप में पेशेंट देखते हैं तो आपके पास क्या, एक विपल्स का एक केस है, दूसरा लिवर ट्रांसप्लांट, कितना चैलेंजिंग है दोनों को अगर कंपेयर करें, और दोनों में क्या डिफरेंस है इन शॉर्ट अगर आप बताएंगे?
चैलेंजिंग तो बहुत है सर, क्योंकि विपल्स भी मेजर सर्जरी है, लेकिन जो लिवर ट्रांसप्लांट है मेनली उसमें आइसोलेशन लाइक बाकी पेशेंट से तो अलग ही रखते हैं ऑब्वियसली, एसेप्सिस बहुत मेंटेन करना पड़ता है। एंड स्टार्टिंग में तो लाइक 24 आवर्स लाइक आवरली मॉनिटरिंग चलता है पेशेंट का, RBS चार्टिंग हो गया, ऑफ हार्ट रेट, BP, और अगर पेशेंट कुछ एक्स्ट्रा इवेंट्स अगर इंट्रा ऑप में रहे हैं तो और कॉशियसली मॉनिटर करना पड़ता है। अगर पेशेंट आइनोट्रोप्स में है तो मतलब यही देखना पड़ता है शुगर्स कितने आ रहे हैं पेशेंट के, या BP, यूरिन आउटपुट कैसा है पेशेंट का। तो और हम जैसे प्लान होता है अर्ली एक्सट्यूबेशन करने का, तो वी इनकरेज द पेशेंट ऑल्सो, अगर पेशेंट OT से स्टेबल आया है तो वी इनकरेज फॉर अर्ली एम्बुलेशन एंड वी असेस द पेशेंट इन अर्ली एम्बुलेशन एंड रेस्पिरेटरी एक्सरसाइजेस, और उसका न्यूट्रिशन भी जल्दी स्टार्ट किया जाता है। तो बाकी सर्जरी से लिवर ट्रांसप्लांटेशन का पोस्ट ऑप केयर ऑब्वियसली बहुत चैलेंजिंग रहता है एंड बहुत विजिलेंट रहना पड़ता है उसके लिए। बिल्कुल जैसे कहते हैं ना कि अर्ली असेसमेंट हमारा जो है वो बहुत ही अलर्ट होना चाहिए ना उसको, कि हाँ अभी मतलब वाइटल्स बिगड़ रहे हैं, अभी आई शुड इन्फॉर्म, ये कोई कॉम्प्लिकेशन फर्दर हो सकता है। तो दैट इज द मेन पॉइंट।
आपने बहुत अच्छे से कवर किया, एक बार तालियां। आप नाम भी बता दीजिए सभी को।
श्रद्धा।
तो आपने बिल्कुल श्रद्धा से जवाब दिया है। तो मेरा सवाल सुनैना जी और मदन जी से है कि आपको ऐसा कोई पार्ट जो आपको लग रहा हो कि अभी गैप है उसको फिल करना है। मुझे लगता नहीं है, ये जितना बड़ा विषय है उतना हमने बहुत, आई थिंक 40-50 मिनट्स हो भी गए इसके ऊपर डिस्कशन कर, फिर भी कुछ रह गया हो तो।
ओटी के पॉइंट ऑफ व्यू से मैं बताना चाहूँगा, जब भी हमारे को सर्जन के द्वारा इन्फॉर्मेशन मिलती है कि अभी हमारा लीवर ट्रांसप्लांट पोस्टेड है, हमारी एक डेडिकेटेड लीवर ट्रांसप्लांट की टीम है, उसको इन्फॉर्म किया जाता है। उसमें से 3 टीमें बनती है, एक डोनर साइड जाएगी, एक रिसिपिएंट साइड जाएगी और एक बेंचिंग के लिए रहेगी। तो जो डोनर साइड जाएगी और ट्रॉमा सेंटर मोस्टली हमारा टीम जाती है, उसके साथ काफ़ी हमारे जो डोनर के बैग्स हैं वो लेके, डोनर के सेट हैं वो लेके, और जो उसके लीवर कैरी करने वाले बॉक्स हैं वो बॉक्स लेके उधर जाते हैं और वो लेके वापस आते हैं। और इधर साइमल्टेनियसली इधर हमारा जो रिसिपिएंट साइड है वो रेडी करना होता है। उससे पहले ओटी को पूरा अच्छे से फॉगिंग करके, क्लीनिंग डस्टिंग अच्छे से करके और सारे सेट्स को डबल ऑटोक्लेव करके, अगर वो पॉसिबल नहीं है तो हम सारा डिस्पोजेबल सेट्स यूज़ करते हैं। उसके लिए जो ड्रेप्स है सारा डिस्पोजेबल यूज़ करेंगे, और अगर वैसे भी पॉजिटिव वायरल मार्कर किसी का पॉजिटिव है तो भी हम डिस्पोजेबल सारे यूज़ करते हैं।
तो मेरे सेकंड लास्ट क्वेश्चन है सुनैना मैम से। मैम, हमने विपल्स में भी हमने कंपेयर करवाया, मतलब एक व्यू लिया कि कितने नीडल यूज़ होती हैं, कितने इंस्ट्रूमेंट्स यूज़ होते हैं। तो एक बार जो नॉन ओटी स्टाफ है, मतलब मेरे जैसे जो आईसीयू में या वार्ड में रहे, तो एक बार जस्ट बता दीजिए कि कितना कॉम्प्लिकेटेड होता है उसको मैनेज करना, कि कितने सूचर्स और कितने इंस्ट्रूमेंट खुलते हैं, सिर्फ इतना सा।
कॉम्प्लिकेटेड तो बहुत ही है ये, मतलब वैसे देखा जाए वो कहने को है कि 1 दिन की सर्जरी है, बट इसमें हमारे 2-3 दिन चले जाते हैं
लगातार।
आज इवनिंग से इन्फॉर्मेशन शुरू हो जाती है, हमारी टीम्स का वर्क शुरू हो जाता है, इवनिंग टीम, नाइट टीम, सब उसकी प्रिपरेशन में जाएंगे। नॉट द नर्सिस हु इज़ असिस्टिंग, बट जो प्रिपेयर करते हैं ओटी का पूरा सेटअप करना, सेट्स भेजना और ओटी रेडी करना, फ्यूमिगेट करना, तभी वो ओटी आपकी एक सबसे इम्पॉर्टेंट है कि सेप्सिस में ना जाए, पेशेंट को इन्फेक्शन ना हो। उसके लिए हमें प्रॉपर ओटी पूरी रेडी चाहिए, मतलब डिसइंफेक्शन प्रॉपरली चाहिए, तभी हम पेशेंट लेते हैं। तो वो बाय द इवनिंग स्टार्ट हो जाता है जैसे ही हमारे पास इन्फॉर्मेशन आती है।
मैं आपसे नंबर्स पूछ रहा था थोड़े से।
हाँ, मैं बता रही हूँ, वहीं आ रही हूँ मैं। फिर उसके बाद जब सर्जरी स्टार्ट होती है तो पूरा जो सेटअप है, नंबर ऑफ सेट्स हैं, वो 10 से ज़्यादा नंबर ऑफ सेट्स हैं जो खुलते हैं, और उसमें एक सेट में 100+ इंस्ट्रूमेंट हो सकते हैं, उनकी सबकी काउंटिंग, और 100+ ही आप सूचर्स एंड नीडल्स लगा लीजिए, फाइन सूचर्स। उसमें से मतलब 80 और 10-0, नॉट 10-0, 70-80 मतलब लास्ट छोटा सूचर है उसमें, और बाकी जो सारे सूचर्स मिला के विद एनास्मोसिस एंड ऑल 100+ सूचर्स, निडल्स एंड समटाइम्स 100+ स्पंजेस सोक्ड इन ब्लड, तो वो सब काउंट करना और उतना इंस्ट्रूमेंट, निडल सब प्रॉपर काउंट करना, वो एक चैलेंजिंग जॉब रहता है उस टाइम पे।
जी, थैंक यू। मैम, आपसे मेरा एक आखिरी प्रश्न है, चूँकि नर्सेज इसमें बहुत सारे एमसीएस से भी हैं, तो सबके मन में जरूर आएगा आपके जाने के बाद कि आपने शायद पूछा नहीं मैम से, आपका मैम नर्सेज को लेके क्या प्लान है, क्योंकि इतनी ज़्यादा कॉम्प्लिकेशन है, कॉम्प्लेक्सिटी है, कि उनको आप कैसे ट्रेन करेंगे जब आप एमसीएच में जाएंगे, या अपने साथ आप कुछ महीने उनको साथ रखेंगे अलग से ट्रेनिंग के लिए?
सबसे इम्पोर्टेंट बात है पैशन होना चाहिए। जैसे कुकिंग किसी को पसंद है, किसी को नहीं, किसी को सिर्फ पेट भरने लायक फटाफट काट के बना लिया, कोई अपनी इंग्रेडिएंट्स अच्छी तरह सजाएगा, फिर एक एक करके डालेगा, प्लानिंग करेगा। तो जो लोग डेडिकेटेड हैं, पेशेंस है, और दे नो कि हाँ ये हमारा पैशन है एंड वी विल डू इट, सो दे विल बी taken out, whoever voluntary, for everybody it's open at the moment, so give your names, we will be taking you there. I've already spoken to director sir, we'll be taking you there and then see the system, and they will also mentor us from there. So aajkal online is everything is possible, so even when we start we can have people watching us, हाँ ये लगा दिया, वो लगा दिया, so everything should go, and बहुत खर्चा होता है, ऐसे नहीं है कि बिना खर्चे के हो जाएगा। So ICU में if somebody is going to see a patient, every time a new gown, so you can't use that same gown to the next patient, so be careful कि मुझे जाना है, मुझे ये काम करना है, ये नहीं कि एक करके आके वापस आके दूसरा दोबारा नया गाउन लेना पड़ेगा। So each and everything has to be done very carefully, noted down, nothing has to be hidden, कोई गलती हो जाए तो भी माननी है, honest रहना है, because it's a team work, and the nurses should be involved in the OT and post-op also and pre-op also, तभी वो लाइजन बनता है।
जी जी।
ये नहीं कि मैं OT की नर्स हूँ, मैं ICU में नहीं जाऊँगी, आप ओटी की नर्स हो, आपने आईसीयू में जाके देखा तो आपको कितनी खुशी मिलेगी ना, थोड़ी घंटे उधर काम कर लोगे तो वो पेशेंट आपके साथ बन जाएगा, यू नो कि हाँ ये अच्छा निकला, मैं अब नेक्स्ट टाइम ये भी करूँगी, या फिर अपनी गलतियाँ भी सामने आएंगी कि ये देखो कॉटरी रह गई थी, थोड़ा सा बर्न हो गया, एक छाला पड़ गया यहाँ पे, है ना। तो छोटी छोटी चीज़ें हैं, डीवीटी पंप भी लगाना है, वो सब भी छोटी छोटी चीज़ें भी, और जो नहीं आता वो सीखना है, कोई नई चीज़ आई है तो आस्क एंड लर्न अबाउट इट.
Liver transplantation is not a surgery in short, it is a
teamwork.
rebirth.
Yeah,
It is a
yeah.
rebirth.
Rebirth, definitely.
Thank you so much, ma'am.
Thank you.
मैम के सम्मान में मैं रिक्वेस्ट करूंगा नरगिस मैम को एक टोकन ऑफ एप्रिशिएशन दे के आप सम्मानित करें मैम को, और हमारे पैनलिस्ट भी आप ज्वाइन करें मैम को सम्मानित करने के लिए। एक बार जोरदार तालियां। हमारा जो अगला टॉपिक रहेगा वो हाइडेटेड सिस्ट रहेगा, जो सोनिका जी एज ए मॉडरेटर रहेंगी उसमें, और हमारे पैनल में रहेंगे डॉक्टर कार्तिक, प्रियंका जी और रमनदीप जी। आपसे रिक्वेस्ट है कि आप रेडी रहें। जी मैम, आप बिल्कुल, आप मैम हमें बताएं, हम आइडेंटिफाई करेंगे जो भी है हाईली पैशनेट मोटिवेशनल। सो अगले टॉपिक के लिए हमारे बीच में जो आ रहे हैं हाइडेटेड सिस्ट। एक आपने नाम सुना होगा रक्त बीज, कभी पुराने सीरियल में एक आता होगा रक्त बीज। तो हाइडेटेड सिस्ट पे जब हम पढ़ने जाते हैं तो आई थिंक कुछ वैसी सी फील आती है कि अगर ये पंक्चर हो गई तो जहां जहां उस प्लेज होगा वहां वहां नई सिस्ट आ जाएगी। तो इसी को जानने के लिए हमारे को बताने के लिए सोनिका जी है। आप प्लीज, आप सोनिका जी आप प्लीज आप आगे आइए। और पैनलिस्ट में हमारे साथ डॉक्टर कार्तिक, प्रियंका राजपूत जी और रमनदीप जी। प्रियंका जी सीनियर नर्सिंग ऑफिसर है सर्जरी एमसीएच ओटी में, और रमनदीप है आप नर्सिंग ऑफिसर मेन ओटी एम्स में, मेदांता में। ओके सॉरी, मेरे पास इंफॉर्मेशन गलत थी, मेदांता।
Good afternoon everyone. Myself Sonika. I am working as a nursing officer in surgery block OT. Today I am going to teach hydatid cyst of liver. Okay. So hydatid word has come from Greek language meaning liver full of water, and worldwide 1 million people are living with this disease at one time. There are 4 species of it's spread from Echinococcus species, and it has main 4 species: Echinococcus granulosus, multiocularis and oligathus, and 4 species is Echinococcus vogeli. There are 2 hosts in this disease. One is intermediate and second is definitive. Mainly definitive host is dog, wolf and cat in all species, and intermediate host is sheep, goat or human being. And the location of cyst in case of granulosus is visceral, mainly liver and lungs, while in the case of Echinococcus oligathus it is primarily muscles. Now coming to the life cycle of Echinococcus granulosus, firstly it will be in the definitive host like dog, so it will be present in the small intestine. Through the feces it will go outside and taken by the intermediate host, that may be goat, sheep or human being, and these embryonated eggs in feces are hatched and they will be penetrating the intestinal wall, and from the intestine these will be migrating to the liver or lungs. So there will be formation of hydatid cyst in the lung and liver. From there protoscolex are the released from the cyst, and these are the infected, and they from there scolex attaches to the intestine, and this cycle will be continued. Now coming to the structural component of hydatid cyst, there is germinal epithelium and laminated membrane. Laminated membrane is 1 to 2 mm thick. Now the hydatid cyst fluid, it is colorless, odorless, and it has antigenic properties, and there are protoscolysis on microscopy. Now liver is affected in 67% of the cases, lung in 25% cases, and other organs. Single organ penetration is there in 85 to 90% of cases, And small and uncomplicated cysts are maximum time asymptomatic, while when the size of cyst is increased more than the 5 centimeter, there may be discomfort or dull pain is noted. Now coming to the complications of hepatic hydatid cyst, it can lead to compression of the adjacent tissues, secondary infection, and the cyst can rupture into biliary tract, bronchial tree, peritoneum, and other cavities. Now coming to the management. First strategy is wait and watch. When there is calcified cyst walls, in that case, as the nutrition is stopped from outside, so these are not harmful. So wait and watch strategies used. Second is drug therapy. So drug therapy is used as primary curative management during before peri-interventional sterilization and in cases of recurrent and refractory disease. So drug of choice is albendazole. So 10 to 15 mg per kg per day it is given, and maximum dose is 400 mg. Albendazole is given after fatty meal to increase the absorption, and total duration is 1 to 3 months uninterrupted. Adverse effect of albendazole are neutropenia, proteinuria, mild hepatotoxicity, and GI disturbances, transient alopecia, and teratogenicity in early pregnancy. So as there is there will be requirement of HB and LFT monitoring in these cases. If albendazole is not given in some conditions, then mebendazole is the drug of choice, and 40 to 50 mg per kg dose is given in 3 divided doses. Now next is PAIR, that is puncture aspiration, injection, and re-aspiration. This is done by the radiologist. Percutaneous puncture of cyst is done under image guidance. So there will be 18 to 22 gram cholangiography needle will be used. First there will be puncture is done, and the fluid is aspirated 3/4, and that will be sent to the laboratory. And after that there will be injection of the specific scolicidal substance will be done in the cavity, and then re-aspiration of that is done. So aspiration of at least 30% to 50% of volume, and for bile staining and dipstick test. And in microscopy, scolex viability is seen. As you can see here, in microscopy, live motile will be seen as like that, while that is seen like this. And re-aspiration of fluid is done after 15 to 20 minutes, depending on which scolicidal agent is given. There are various scolicidal agents are there. Least time is needed in the case of silver nitrate. Silver nitrate, while the most commonly used is 10% betadine. 10% betadine is inserted in that cavity for 10 minutes so that it works over there, and that it is then it is re-aspirated from over there. Next, coming to the surgery. Surgery is indicated in the large liver cyst which has multiple daughter cyst, or if there is any single liver cyst that has chances of rupture, or infected cyst. When fourth condition is when cyst is exerting pressures on the surrounding vital organs. It is contraindicated when there is difficulty to access the cyst, there are extremes of age, or severe concomitant disease. Now coming to the surgical techniques, it can either be conservative or radical. In conservative, partial cystectomy or deroofing can be done. In radical, total pericystectomy or liver resection can be done. And open laparoscopic or robotic techniques are used depending on the patient conditions. Now coming to the pericystectomy, here we can see that when total cystectomy is done, if all the 3 layers of echinococcal cyst, that is that we have learned earlier, advential, laminated, or germinal layer are removed, that is called total cystectomy. In subtotal cystectomy, laminated and germinal layer are removed. In hepatectomy, that affected lobe is removed. Now, when the cyst is aspirated or the surgery is ongoing, it is very necessary to prevent the spillage. This is the key message of this whole presentation. That is, these scoliocidal agents, most commonly used is betadine. So betadine soaked mops and gauze pieces are used to isolate the cavity, so that if 1% chances there is spillage, so that should be complications should be prevented. In case of if it is going through laparoscopic method, use of Pelani value hydrated system is done. Now coming to the nursing management. So in pre-operative, basic vital signs like heart rate, BP, respiratory rate and temperature are monitored. Laboratory tests like patient is taking drugs, so liver function test or HB is checked. For anaphylaxis management, pre-medication is done, like steroids and antihistamines are given. Now coming to the nursing role in laparoscopic deroofing. So this is the basic trolley that is needed. Here the laparoscopic instrument used. There will be 10 mm suction is used for doing the suctioning of the cyst. And there is special port that is used. Pelani value hydrated system is used. So here you can see that with the port, there is a suction channel is attached. So when the puncture of cyst is done, so through this suction channel to prevent the spillage, that fluid is suction is done. Now here is the video. Here they are removing the attachment of hydrated cyst using harmonic. Now they are putting betadine soaked tail gauze surrounding the cyst. Now they have punctured and aspirating the cyst fluid. Now they will be putting 10% betadine again over here for 10 to 20 minutes. Then they will be again aspirating. Now they will take out tail gauze. And a drain is placed in the cyst cavity, depending upon the size of cyst cavity. Now coming to the open deroofing, except the basic trolley, the main instrument here we use is our own cone suction. So you can see over here is this is a cone with this suction attached over here. So what it is done, this cone is placed over the hydrated cyst, and then cyst will be punctured. So when the suction is already attached over this point. When cyst is punctured, so the fluid is sucked through this and the spillage is prevented. Now coming to the infection prevention, so which we have to wear PPE in case of the open deroofing, and in case we should avoid the direct contact to the cyst, and the instrument are washed with 1% hypochlorite for dipped in 1% hypochlorite for 20 minutes, and proper waste discard is also important. Now, the nurse's role in prevention of in spread in a community. So the dog is one of the host is there, so dog deworming is very necessary, and one should prevent dogs from eating infected sheep, and wash their hands with soap and water frequently, especially before preparing food and after handling the dogs. So the conclusion, liver hydatid cyst is a prevalent zoonotic disease in India. Pre-op diagnosis is very important. Albendazole has a role in peri-interventional sterilization and recurrent disease, and surgery is modality of choice. Nurses plays very vital role in all phases. If you have any doubt, you can ask.
I think you have done it very well. One thing I wanted to ask, I'll not ask you, I'll ask the audience. She has mentioned about the Palanivellu trocar. Does anybody know who is Dr. Palanivellu? Any idea? Do you know? Huh? Obviously, he has invented it. So Dr. Palanivellu is a GA surgeon in Tamil Nadu, and he has given a lot to GA surgical. He's the first person to do laparoscopic Whipples in the world. He has devised the position we do esophagectomy these days. Kailash does now, a prone position. Dr. Palanivellu has devised it. This is the third thing that he has devised, and he has also devised one colonic surgery. I forgot the name. So it's a big shot actually.
And just a comment, it's not easy to do it laparoscopically because the suction gets stuck. You have to keep doing it again and again, take it out, empty it, repeat it to maybe 20 big ones,
10 mm section.
10 mm suction wide and repeat. The moment you know it gets blocked, you empty it and get it down again. Thank you.
किसी के कोई प्रश्न आपके मन में कुछ आ रहा हो तो? मैंने पहले भी बोला था कि दो ही चीजों में नहीं आता है, एक तो कुछ समझ नहीं आता, दूसरा या तो सब कुछ समझ आ गया हो. मैम आप पूछेंगे तो ज्यादा ठीक लगेगा.
एल्बेंडाजोल है ना, हाइडेटेड सिस्ट की सर्जरी के पहले आइडियली 1 महीना एल्बेंडाजोल दे देनी चाहिए. कभी कभार उससे पूरी गायब भी हो जाती है 3 मंथ्स में, अगर लंग की हो, नहीं हुई तो एटलीस्ट 1 मंथ, ताकि इन्फेक्शन फैले नहीं. एंड व्हाट अबाउट एनाफाइलैक्सिस? हाइडेटेड सिस्ट फ्लूइड कैन लीड टू एनाफाइलैक्सिस. सब कुछ अच्छा हुआ, नाइस क्लीन सर्जरी, पेशेंट डाइड आफ्टर 6 hours. Okay, it can even occur till the next day. So post-op patients, you have to see them very well. Tachycardia ho raha ho, adrenaline de do, and during surgery, you have to give a shot of corticosteroid so that there is no problem. That's why you have to take care very carefully. It should not be spilled out. Thank you.
हमारे साथ 2 पैनलिस्ट और हैं. प्रियंका जी, आप कुछ इसमें ऐड करना चाहेंगे?
Actually, Sonika has mentioned everything. I don't think she has left anything. She has covered everything.
तो जी थैंक यू. रमन, अभी पता लगा आप मेदांता से हैं. क्या मेदांता में इससे कुछ अलग किया जाता है?
Obviously, the procedure is same.
जी.
Practices are similar somehow everywhere, but the thing that we mainly focus in hydatid cysts is protecting the operating field, because that is necessary. There are 2 main aspects of that. Firstly, as we explained, she has already explained in the PPTs that it is antigenic. The solution, that product that is in the cyst, it is antigenic. Firstly, that if spillage of that occur, it can leads to antigenic reaction and anaphylactic reaction that could lead to more problem for the patient. And the second thing, it may also lead to secondary hydatid cyst. That could, if we try to suction all the cysts, but somehow some remnants will be there. That may lead to secondary hydatid cyst. And if we talk about, she has mostly covered about liver hydatid cyst. If we talk about lung hydatid cyst, and if it will break, then if hydatid cyst break in the lungs, then that may leads to asphyxia or bronchospasm will be there, and it may leads to pulmonary stricture somehow if the hydatid cyst is in multiple places. Thank you.
सो एज ए फ्लोर नर्स प्रियंका जी, आप एक बार, मैं वापस आपके पास आऊँगा, स्पिलिज वाले सिचुएशन में कहीं कुछ हो जाए तो एज ए फ्लोर नर्स फिर आपका क्या रोल रहता है उसमें? एनेस्थेटिस्ट होते हैं क्योंकि सर्जन अपना काम करते रहेंगे, क्या वहाँ पे कुछ एनेस्थेटिस्ट भी कुछ अपना रोल प्ले करते हैं इस सिचुएशन में?
हम रुक जाते हैं जब भी होता है, हम काम नहीं करते रहते, हमें एनेस्थीसिया वाले रोक देते हैं।
क्योंकि मैं बाहर का हूँ तो मुझे थोड़ा सा पता होना चाहिए कि ऐसा कुछ होता है अंदर का सीन।
We have to coordinate with anesthesia team for that particular stage. If they need any kind of help, we are always available there, because this is a very serious situation. It could lead to anaphylaxis, and it is a serious problem. So we all are aware about it. So we already take all the precautions needed for this. That is why we are using salicylic agent, that is 10% betadine. That is the solution of choice in our hospital. We are practicing it. As you see, we use tail gauze or sponge. In open surgery, we use betadine soaked sponges. In laparoscopic and robotic surgery, we use betadine soaked tail gauzes. We surround it with this, and then we are also putting 10% betadine in cavity, and then giving the time for the salicylic agent to work, to kill protocolysis. So we are already taking all the precautions so that it doesn't happen, but still in case it happens, then I think the main role the role of anesthetist is crucial at that time.
Thank you.
It's very important to keep all the drugs prepared, and
like
corticosteroids, adrenaline and bronchodilators. In an event of
As you mentioned,
anaphylaxia, they'll keep on asking the circulating sister, please give this, please give this. It is better to give it to them beforehand.
Okay, thank you so much, sir. हमारे साथ ऑर्थो ओटी से और मैं देख रहा हूँ एनसी ओटी से काफ़ी लोग हैं. कोई हाथ हैंड रेज करेगा जो है ऑर्थो ओटी से? 5-6 नाम थे हमारे पास.
सारे चले गए शायद.
एनसी, अच्छा ऑर्थो. मैम, जैसे सर ने बताया कि सर्जन्स रुक जाते हैं और एनेस्थेटिस्ट हैं वो अपना काम शुरू करते हैं, ऐसे ऑर्थोटी में भी कई सिचुएशन आती हैं आपके हिसाब से कि जहाँ पे सर्जन्स रुक जाते हैं और एनेस्थेटिस्ट हैं वो अपना काम करना शुरू कर देते हैं और फ्लोर नर्स को भी काफ़ी एंगेज कर देते हैं? ऐसी कोई सिचुएशन आपके सामने कभी आई हो?
ट्यूमर ब्लीडिंग ज़्यादा होता है तब सर्जन को रुकना पड़ता है और एनेस्थेटिस्ट काम शुरू होता है.
जी, इसके अलावा कुछ और मैम आप ऐड ऑन करना चाहें?
नहीं, इसके अलावा तो कुछ और नहीं है. और सर्जन के पॉइंट ऑफ व्यू है ना, सर्जन इस
तो मतलब ब्लीडिंग का कोई भी मामला हो, चाहे वो ऑर्थो का हो चाहे वो तो उसमें सर्जन रुक जाते हैं. सर्जन को करनी पड़ेगी.
सुना है ऑर्थो वाले जब हड्डी जोड़ रहे होते हैं, पेशेंट को सीपीआर भी चल रहा बोलते एक पेच लगा दो. एक पेच.
नहीं, ऐसे तो नहीं होता क्योंकि
ऐसे नहीं होता.
No,
वो तो वैसे
it's not possible because I have 30 years of experience in orthopedic.
वैसे मजाक.
No, it was a joke. It was a joke.
उसको सीरियसली नहीं ले रहा. सो अभी हमारे बीच में शायद ऑर्थोटी के काफ़ी और भी बच्चे आ गए हैं, तो इन्हीं से पूछ लेते हैं. ऑर्थोटी से अभी ज्वाइन किया आई थिंक, तो चलो इनसे नेक्स्ट सेशन में कुछ और बात करेंगे. थैंक यू सो मच तीनों पैनलिस्ट को. अभी हम नेक्स्ट हमारे टॉपिक की तरफ जी. ओके, कोलोरेक्टल. हाँ, कोलोरेक्टल ही. अच्छा, हेपेटेक्टोमी हम बाद में कर रहे हैं. ठीक है. कोलोरेक्टल कैंसर विद लीवर मेटास्टेसिस एंड स्टोमा केयर, ये आज का मतलब हमारा नेक्स्ट जो सेशन इस पे रहेगा. और इसके लिए हमारे बीच में है स्पीकर में डॉक्टर अश्वंत और मिस्टर गोपी. आप इंटर ऑपरेटिव नर्सिंग मैनेजमेंट बताएंगे कोलोरेक्टल सर्जरी में, और डॉक्टर प्रिया व्यास ओके, डॉक्टर प्रिया व्यास भी आ गई हैं. सो आप तीनों का बहुत बहुत स्वागत है. आप प्लीज़ टेक योर सीट्स. हाँ वो करेंगे. डॉक्टर यशवंत, सो आप पहले स्टेप्स ऑफ सर्जरी के स्टेप्स आप क्लियर करेंगे, देन इंट्रा ऑप के लिए गोपी.
So good afternoon everybody. This will be a short session. I'll be talking on the steps of surgery that is done for colorectal cancer with liver metastasis. Liver metastasis happens because any bowel is going to have its venous return to the liver. So that is why in bowel malignancies you often tend to see metastasis that happens to the liver. So there is a changing concept that isolated liver mets is currently slowly becoming a localized kind of disease. Instead of thinking it as a metastasis, we are treating it as a local disease, and that is where this combined resection of colon and liver has come into play. Basic evaluation is to rule out distant metastasis. We first need to see that the patient does not have any further metastasis apart from the one in the liver, and check if the primary disease and the liver metastasis is resectable. Give the patient one course of neoadjuvant chemotherapy, and if the patient does not progress on that, then we plan for surgical resection. So basically we need to resect the primary disease and also resect the disease in the liver. Once the resection is done, you are going to do a reconstruction of the bowel depending upon the type of resection, and you may add a stoma to the procedure depending upon the risk assessment intraoperatively regarding the risk of leak. So there are multiple types of colon resection. The broad classification is a right colonic resection and a left colonic resection. Right colonic resection is the one that is displayed here. The first one is a basic right hemicolectomy, whereas the second one is a right extended hemicolectomy. This right hemicolectomy is done for malignancies of the cecum and ascending colon, whereas right extended is done when the malignancy is in the hepatic flexure or in the very proximal transverse colon. When it comes to left-sided resections, it is done for malignancies of the splenic flexure. We do a left extended hemicolectomy or a sigmoid resection. So this is a formal left hemicolectomy, and this is a sigmoid. Just the sigmoid is being resected whenever the malignancy resides at the sigmoid colon. Basic steps of the surgery include first, like in any malignancy, you check for peritoneal metastasis. Once you rule out peritoneal metastasis, the initial step in either a right or a left hemicolectomy is to do a opening of the white line of Toll. So this is the embryonical plane, which is generally avascular. If you are in the right plane, the colon just lifts off the retroperitoneum and this plane is bloodless. So this is the first step. Once the colon is lifted off, you get a view of the retroperitoneum, in which you will be able to identify the ureter. Looping of the ureter is an optional step. Not all surgeons prefer this. The main thing is to preserve the ureter and ensure that it is not injured when you are lifting the colon. Sometimes the ureter gets lifted off along with the colon during this part, and one needs to be vigilant before dividing the vessels that the ureter is not in the specimen. So that is why some people prefer looping the ureter and keeping it separately before you divide the vessels. The next part is to ligate the vessels. So this is why the surgery of right hemicolectomy or left hemicolectomy is done in the way it is done. What I am trying to say is, if the malignancy is there in the cecum, the malignancy basically spreads across the lymph nodes which are supplying the malignancy. So this is we need to ligate the ileocolic vessel at the base and also the right colic vessel at the base. Once you are done, the right colon is not going to have any further blood supply. So this part has to come out. So this forms the basis of all types of hemicolectomy. Similarly, in right extended, you are going to take down the middle colic. So that supply is gone. So accordingly, you will have to take the right colon, which is not being perfused right now. So similarly, this is transverse colon resection. This is extended right resection. This is a left hemicolectomy, and this is a sigmoid resection, like I have described before. Once you have once you have ligated the vessel, you will have to transect the bowel. So if it is going to be a simple right or a transverse or a left hemicolectomy, the transection is simple. You just use an NTLC stapler or an echelon for that matter, and then you divide it. Whereas the difficulty arises when you're doing resections of the pelvis. So if the malignancy resides in the upper rectum, or if it is going to be in the mid or lower rectum, you're going to divide the rectum much lower. So the pelvis is a very close space in which your routine NTLC won't have access. In laparoscopy, we are out of options. We have to use a straight stapler, so we end up using an echelon, which has a articulating angle. So we'll be able to navigate this stapler into the pelvis, but this again is going to need multiple fires. So multiple fires of echelon will help us divide the rectum within the pelvis in the narrow space, whereas when it is open, we have the option of using a contour stapler. The main purpose is to introduce the contour stapler into the pelvic cavity and then divide it. So it helps in dividing the colon in a closed space. The next part is to perform reconstruction. So again, this is another distinction between the right and left hemicolectomies. When the right hemicolectomy is done, the leftover bowel is an ileum and a colon. So the anastomosis is going to be an ileocolic anastomosis. Whereas in left sided resections, you are left with two colonic ends, and the anastomosis is going to be a colocolic anastomosis. When the division is much lower in the rectum, the third type of anastomosis that you will be doing is a colorectal anastomosis. So the main difference between these three is the leak rate. Small bowel is generally supplied with very good blood supply. So when an anastomosis is having a good blood supply, the rate of leak is much lesser. So ileocolic anastomosis has the lower leak rate as compared to a colocolic anastomosis, whereas it is even more higher when it comes to a colorectal anastomosis. This forms a basis for us to decide on doing a stoma after the procedure. So this is an ileocolic anastomosis between the ileum and colon. This is a colocolic anastomosis following a left hemicolectomy. And when the anastomosis is low, we use a circular stapler to perform a colorectal anastomosis, which has the highest leak rate among these. So when such an anastomosis in a really rundown patient, we expect the leak rate to be high. We don't want this thing to leak into the pelvis and cause sepsis. So what we do a diversion stoma. Diversion stoma in the form of diversion ileostomy. This is brought out through the rectus, approximately 2 centimeter lower and lateral to the umbilicus. So once the liver part is completed, of course this diversion stoma has to be done just before closure after the liver resection. I have just put it here for completion's sake. Liver resection will be decided depending upon the site where the lesion is. So if all of the lesions are there in the right side and there are multiple lesions, we are going to do a right hepatectomy. If it is there on the left side, then the surgery is left hepatectomy. But the good thing about colorectal metastasis is you don't have to do such a morbid or a major hepatectomy to take out all the metastasis. Even a 1 centimeter margin or even a lesser margin such that you are able to get a negative margin is sufficient enough for a colorectal metastasis, because it has good tumor biology. So most of the times whenever there are isolated mets or small mets, we try to do a wedge resection in these cases. So that will help in reducing the morbidity of the surgery. Apart from resection, there are also other techniques that are employed in colorectal metastasis, like radiofrequency ablation and cryoablation. Radiofrequency ablation is basically nothing but cautery with a different type of tip. We access the lesion under ultrasound guidance. This may be done intraoperatively or may be done postoperatively also. We navigate the tip into the tumor and then we give radiofrequency energy that ablates the tumor. Similarly, cryoprobes are also available, which bring down the temperature to negative minus 10 to minus 20 degrees, which again ablates the tumor. Similarly, the other technique that is available is percutaneous ethanol injections. So these are the ablation techniques that are available, which helps in ablating liver metastasis. The types of approach may be varied, like you can do both together. You may first do the liver and then do the colonic surgery in the second sitting. That gives us a better sterile field. Or you might opt to do the liver surgery first, followed by the colonic surgery. That depends upon the patient factors and as well as surgeon preference. Thank you.
Mr. Gopi, please.
Good evening, all. I won't take much time because Dr. Ashwin sir already explained about the surgery step. I will directly go to the intraoperative. We all know colorectal cancer. Basically we all know everything about colorectal because we are all working in OT. Can anyone tell what is colorectal cancer and the risk factor? Basic things, but we are seeing. Not fairly, so we will forget. So just refine. Someone tell what is colorectal cancer and the risk factor. Can anyone tell about from the audience? Yes, very good. This is one of the most common cause for the colorectal cancer. So low fiber diet, and then obesity, and then previous history, and then alcohol consumption. These are the common risk factor for the colorectal cancer, and then polyp also. This is that is the most common cause. And then signs and symptoms and all we know everyone. So I will skip. And diagnosis. In diagnosis we will see the one basic test is fecal occult blood test, and then CT, and then MRI to check for the extensity, which are the organs involved before the surgery, and based on that we will plan for the surgery. And then sigmoidoscopy, colonoscopy also. This is the available treatment for the colorectal cancer: radiation, chemotherapy, targeted therapy. There's the surgery, open surgery, laparoscopic surgery. These are the 3 surgery approaches we can take in to tackle the colorectal cancer. These are all Sir has explained, so I am skipping this everything. So main concern is intraoperative thing. Once we receive the patient in the OT table, we before starting surgery we will check for the consent, and then ID band and the WHO checklist, and then the WHO checklist will check for the all the timing procedure like antibiotic, and then risk for bleeding and intubation, difficult intubation. We will to check all these things, and then we'll take, because colorectal cancer surgeries take longer time, more than 2-3 hours. So we'll tackle for the temperature. We should maintain the normothermy also. And then before incision, we have to give the antibiotic also. And then for the longer surgery, we always have the sequential compression for the DVT prophylaxis also. We should follow those things. And the intraoperative position, mainly the LAR, APR. What is APR? Can anyone tell? What is APR? Abdominal perineal resection. Okay. And then for this we will use the lithotomy position. Okay. This is the lithotomy position. And then for the hemicolectomy, we'll use the supine position. Okay, supine. Some cases we use the supine with the leg apart position also we'll use. And the mainly energy sources, the intraoperative before the patients will see the diagnosis. Based on that, we will arrange for the energy sources and stapling devices. It depends upon the surgeon. Basically, main thing monopolar cautery will put every cases, and then ligashore, and then harmonic scalpel. These are the comparative ligashore and harmonic scalpel. They have some advantages. So based on the surgeon, and the cost also will differ. So it's based on the surgeon preference. And then stapling devices, echelon, 45 mm also available, and 60 mm also available. Mostly 60 mm will be used to anastomosis for the colon, large intestines. And then cartridges is also available based on the thickness, the blue, white, green. Mostly blue will be using for the anastomosis. And then linear NTLC stapler also available. Nowadays we are using echelon powered because these are some advantages over the NTLC. And then circular stapler. In circular stapler, which are the cases we will use the CDH circular stapler? What are the cases we will use circular stapler? Sigma resection, yes. That's the LAR, APR we will use for the circular. There is the circular stapler available in 3 sizes, 29 and 31, 33. And then contour also will use in some cases. These are the images. This is a trolley with a basic laparotomy trolley with special retractors with GI stapler. And then sutures like silk, vicryl, proline to suture the wheel for the circular stapler. And then PDS, loop nylon for the skin closure, sheath closure. The retractors, Journeys, Arrington, Bladder, these are the common retractors. We all know everything because we are in OT, so I don't go in depth. The main concern is the special requirements, because this is the surgery we need some special equipments because we are handling the perineum and the abdomen also. So use the surgeon tray to use the perineal resection time. We'll use the surgeon tray with some instruments we'll give to the another tray we'll use for the thing, and then surgeon chair and the long artery tube and wound protector. Wound protector will use to prevent the spillage and prevent the infection when taking the specimen out through the abdominal incision. And then sizer, proctoscope, and then GA stapler, NTLC, couch, and circular stapler. These are the staplers, and then clamps. These are the special things we should be ensured these things are available before the surgery. That's my concern. And then the hemolock and LT to ligate the vessels. This is the LT and hemolock. This is the circulars. CDH 29 and 31, 33. This is the 33. The special thing while using the CDH, circular stapler, this is the distal part called avil. We'll use the sigma end part of the colon. We'll suture it through the proline, number 2 proline. After suturing, this will look like this. And then after suturing, it will put it into the abdomen through perineum. The circular cartridge will inserted, and then it will be connected through manually, and then it will be fired. After firing, it will be will get the donut in the will the proximal and distal, which will be checked for the continuity. The special consideration, because it's the long surgery, we are placing the patient should be all the pressure points should be adequately supported to avoid the injury. And then for using the perineum, we should use the, don't mix the instrument which are used in the perineum because it will get the infection. And then donut will check for the proximal and distal completion. And then sponge, tile gas, needle, instrument count should be correctly checked. And then sterility, because we are using stapling, this bowel thing, maybe it will get spillage and get the contamination. So we should be concerned about don't spill it to the instrument. And then specimen handling, double gloving, because double gloving will helps to prevent the infection. And then drain. These are the things in intraoperatively we'll do in colorectal surgery. Thank you. Any doubt?
Thank you, Gopi. Thank you so much, Gopi और डॉक्टर यशवंत. अभी कुछ टेबल लगाना. कल हमने जैसे कि बताया था प्री लंच सेशन में कि कल भी वापस हाफ डे चलेगा सेशन. जिसको भी ज्वाइन करना है वो आप नरगिस मैम या मदन को आप इन्फॉर्म करेंगे सो दैट आगे की प्रोसेस शुरू हो जाए. उसमें सर्टिफिकेट कैसे ऐड ऑन होगा एंड ऑल वो सारी प्रोसेस वो देखेंगे. तो नरगिस मैम और मदन का नंबर आप सभी के पास होगा तो आप उनसे कांटेक्ट कर सकते हैं. ठीक है, अदरवाइज़ आप बता सकते हैं तो आप तक आएंगे और वो नाम नोट वगैरह करके देन आगे के अरेंजमेंट के लिए प्रोसीड करेंगे. थैंक यू.
Good afternoon, everyone. Myself, Dr. Priya, and I'm going to talk about the peristomal skin complications and their management. So, in last 2 sessions, we did see how the colorectal surgeries are being done and what are the intraoperative things that we need to be aware of. Now, I'll be in brief talking about the practical aspect of it, what the stoma nurses and the ET nurses or the nurses who are managing the patients post-surgery in the wards or after a few weeks, what all complications they see, and how advanced technology products can manage in mitigating as well as preventing those complications. So my whole session will start with prevention and it will end at prevention only, because what we see as a nurses, what is the most important accountability for us after colorectal surgery is that patient should not undergo any resurgery. So I have seen many ETs, many stoma nurses who are working whole and soul as in charge of stoma care clinic and managing the complication, not letting patient go for revision of surgery. So how they are doing this, what all complications they see, we'll try to concise all in this brief session. So if I talk about the risk factors for these complications, we all know either it can be local or it can be systemic. If I talk about systemic, comorbidities, diabetes, hypertension, age, infections, these all are the problems or the challenges patient can have. Not every patient, like what the data say, I'll talk about that almost more than 75% patient after stoma surgery will come back to the hospital for some or other peristomal or stomal skin complication. But now, because with the environment what we are in, we have the advanced products, we just try to correlate these clinical challenges with the products what we have, and then we can see how we can best manage our patients. Now, I said that we'll start with prevention and let's talk about those things only. Now, first thing, this is MASD, moisture-associated skin damage. Now, what happens in this kind of patient is, what will come out in a patient with colo or ileostomy from that stoma? Anybody? Fecal matter, very right. And urostomy will have urine in it. So when fecal matter or urine is coming out from that stoma on the peristomal skin, it will cause irritation. Constant leakage will be there. Now, because of this constant leakage, patient will have peristomal skin complications. So any complications you see here, definitely at the end it will be correlated with the excessive moisture and the leakage. That's the most important culprit we have when we talk about the ostomy management. So now here you all see this is MASD, moisture associated skin damage. Now, if I say patient has got MASD, anybody quickly can tell me what MASD will cause to your patient. If a patient with ostomy surgery has come up with this, constant leakage is coming out, so patient will complain of what all? Irritation, yes, definitely. And imagine these patients have to wear the pouching system. Now, this pouching system, I'll take this practical and clinical together so that we have more understanding on this. So this is basically consists of the pouching system. Patient has to wear this. This is the bare minimum when I'm talking about most important products. So this is the skin barrier and this is the bag. Patient has to wear this. This has the adhesive. This will go on patient's skin and stoma will come out from this. This will be attached here. So imagine this has to be stick to the patient's abdominal wall. So patient will face, yes, as you have rightly said, inflammation, erosion of skin, itching, budding, pain. And this is not just pain, it's excruciating pain. And this is happening within days and few weeks of the surgery. And increased pouch changing. What happens? Why are we very much bothered about this when patient has all these? What is the burden it is causing on the healthcare professionals? Anybody. If patient comes to you with ostomy surgery with this picture. So this is excessive burden on healthcare professionals. You have to invest more time in, the time which you can spend in, yes, definitely. The time you can spend in managing and educating those patients, you have to keep on changing the pouches because of leakage, it will keep on coming, and again, this will be burden on everybody. Increased and more time consuming pouch changes and less educational time. What do we do when we have a patient with MASD? What management options we should be looking at when we see any patient coming up with this? Any problem, solution is, first we have to look after the cause of it. You keep changing the pouches, you keep using the advanced technology products, it's not going to help unless you address the challenge. And with MASD, most important challenge was the leakage. So you need to make sure there is no leakage for the patient. We do have technologies which are known as seizure-free technologies or the moldable technologies, which just hug the stoma, there is no gap, there is no leak, right? That's the phrase what we have seen which is out there in the market. There should not be any gap between the skin barrier and the stoma. Make sure there is no gap, there is no leak, there is no peristomal skin complication. So as I said, these are the products which are there to help our patients to prevent the peristomal skin complication as well as mitigate the effect if patient has already got this. So first is pinpoint cause of leakage has to be addressed. Review procedures to ensure proper sizing of skin barriers, because sometimes what happens now, when I talk about the skin barriers, so I'm taking the practical also here. So this is a skin barrier which I said moldable one, right? But we have seen other, second type of skin barrier is the cut to fit, which we use normally, right? So if I say this is the skin barrier, patient or HCP, healthcare professionals, have to cut this barrier before they apply this on the patient's skin. Now, what happens when we cut this? There is human factor to it. We can have irregular cut. Yes, it will have edges, and those edges will be sharp. And then always we are being advised that cut the barrier 1 to 2 mm more than the size of the stoma. Why do we say this? Anybody from the surgical wards? You have always been advised to cut the skin barrier, keep 1 to 2 mm, gap there. Yes, it has to be larger. Why do we say that?
Because it will stick to the bowel.
Correct. Otherwise, it will strangulate the stoma. Whatever is coming out, surgeon has created done the surgery. Now stoma is there. If you cut this in such a way that it is just at the margin, because of the peristalsis movement, which is continuously happening in the patient's gut, the size of stoma will increase, decrease, and there will be gap, the edges will be sharp, there will be bleeding, and day one surgery patient will say, nurse, please see this is bleeding. And we all will be worried, why is it bleeding, what happened, is the surgery went wrong? Always remember, last thing what a surgeon would want is that patient is coming back for resurgery, and we should be acknowledged and skilled enough to manage all the complications so that patient is not going for resurgery. Keeping in view, we have a lot of technologies with us today. So this was all about the cut to fit. So what we can do is we can advise them moldable. So cut to fit, this is a seizure-free technology wherein no cutting is required. Just roll mold and apply this. This will hug the stoma just like an elastic. How we stretch the elastic, it will come back because of the elasticity what it has the feature, and this also will come back. So that's how we can do this. Use of accessories, again there are a lot of accessories which are going to help, stoma adhesive powders, paste, which help in absorption of excessive moisture and then providing a patient a surface which is free of all the exposures. Now, let's talk about some next complications. So everywhere we talk about, see, the accessories, we say there are few accessories, but they have power to manage all the complications and mitigate the complications. So which complication? Anybody from here? It's a post-lunch session. I think this will help us taking away the sleep. Anybody?
What was the question?
Which peristomal skin complication this picture is depicting? Rashes looks like, correct. What else? Anybody? Bullseye, anybody?
Longer sticking.
Yeah, that's because of that abrasion what it can cause. Okay, so this is candidiasis. Now what happens, why patient usually gets candidiasis? Because of the constant moist environment. We see water clogging also at our places, at roadsides, anywhere. It will have all green fungus because water is being clogged there for a longer time, and whenever patient has got constant leakage on the skin, if the skin is very, very moist or wet, this will happen because Candida is everywhere in the environment. It will catch patient's peristomal skin. It will have the infection. This is known as the candidiasis. Now, for this candidiasis, now this has happened. Again, I won't go into this. Patient and HCP will be troubling. What do we do when we see a patient with a candidiasis? We are sitting at the stoma clinic managing these patients. First thing, what we need to do is, for any candidiasis, we use antifungal powder because we know that's a fungal infection. Patient has to use these powders. So this will be antifungal powder. If it's mild, if it's moderate, patient will be on antifungal drugs. If it's higher, maybe doctor can advise them IV drugs. So that's how the management of candidiasis can happen. But We talk about prevention, and then what can help patient better is that seizure free the wafer. So if with that wafer, patient will have less leakages, no leakages I would say, and then patient will not come in this condition. So we just see the condition and we go back and at our hindsight, we try to see if we could have advised patient this accessory or this product, patient would not have end up in this complication, right? So that's how this all goes for. Now this is allergic contact dermatitis. This can happen to any patient, right? Because ostomy is a surgery which is new for patient, and then after surgery when patient is applying the skin barrier, that's also which is made up of hydrocolloids. Though these hydrocolloids are plant derivative, but we never know which patient can be sensitized, can have reaction with this. So patient might come up, or this is something which is immediately can happen. You apply this wafer and patient can call up for this kind of infection. I mean, this kind of reaction you can see there. Now, again, the same thing what happens to the HCP. How do we manage this? For any kind of dermatitis, what we do? We suggest them, anybody. It's I think very, very commonest thing we see in the hospitals and the emergencies. Patient coming with severe anaphylactic reactions. We give them, yes, and give them steroids. Right? So remove the irritant, as she has rightly said. Whatever the irritant is, try to see, remove it, use lesser and lesser accessories, because we do not know at that moment which accessory is causing patients what. Right? Application of steroid cream followed by stoma adhesive powder, brush off the excess followed by application of Ascenta skin barrier. Okay, when we talk about Ascenta skin barrier, I want to make one important point here. Skin barriers are there, we see that, right? And when we talk about the challenges, what role skin barriers play in managing those challenges or the complications? So when we say any skin barrier, this advise always that apply the skin barrier around the stoma on the peristomal skin before applying the ostomy pouching system. What does it do? I'll show you with a small practical demonstration what the skin barrier does. So I have got these two filter paper. One is plain filter paper and one where I already, to respect everybody's time, I have applied already the skin barrier on it few minutes before. Now what do? I'll just pour this water. Imagine this is effluent which is coming out from the stoma and this is peristomal skin, and I'll just keep it there. Skin barrier just after surgery as a healthcare professional to support their recovery, patient would not have faced that complication what they come up with, because this gives the patient again a layer which prevent the effluent to come in direct contact with the peristomal skin. So I hope with this small practical you know now what's the role of skin barrier in management of these kind of complications in patients. Let's talk about this. This is a very, very common complication which you will see, that's hyperplasia or pseudoverrucous lesions. What happens? Because of constant leakages or constant water or effluent which is coming out, the skin around the stoma, which is known as the peristomal skin, which will show you a wart-like structure like we see because of the excessive epithelialization there. That's human reaction that will happen if you see this. Now, if I have this kind of patient, I will have to make a lot of efforts to make sure that what stoma I can give to the patient, because I have to cut according to the wart also, like wart has to be incorporated in this hole. And then patient will again have leakages, because this will not assure the exact fitting of the pouching system to the stoma. And this is happening again because of leakages. Now I keep on talking about leakage, and I started saying leakage more than 75% is the only culprit for causing all the peristomal skin complications. So we talk about anything, we need to suggest anything to our patients, we have to make sure that we are trying to address leakage problem at the most. Because once leakage is being called for by us, there will not be MASD, there will not be any candidiasis, there will not be any other infection which can happen. Okay. Let's talk about this. Again, a very common. Patient will, I think, day 1, 2, 3, any day you will see this is mucocutaneous separation. Anybody from this name, how do you suggest what the mucocutaneous separation would be? What we call it like mucocutaneous separation means? Yes, because surgeon has created a stoma and they suture this stoma back on the abdominal wall. Now, the name itself is suggesting mucocutaneous, means there is a separation where the surgeon has created these sutures. Now, the abdominal wall and this stoma is now, we say like, you know, they are getting dehiscensed. Like wound dehiscence we see in the advanced wound care. So again, this is also getting dehiscensed because of the tension on the sutures. Sutures are losing up and there is a gap. The practical gap we can see here, which is there between the stoma and this. Now what happens continuously, stoma, the effluent what comes out of the stoma comes continuously or in between, how this is? Is it a voluntary or involuntary act, what happens there? Anybody? Involuntary, right? Because once stoma, patient has no control over urination or defecation. Continuously this will come out and this will directly go into the space which is there, again cause infection, again make the wound very, very dirty. What's the first thing we should be doing about when we see this kind of patients? You can read if with your convenience what's the etiology, how it would be. We'll talk about the management part. We need to make sure that we address the wound which is there. Addressing the wound is important. You cannot apply this pouching system to this unless you deal with the wound area. So you have to fill this wound cavity with advanced dressings like hydrofiber dressings. What they do, they absorb whatever the moisture is there. Again, you make sure that you are applying a film, a deodorant dressing or any film which gives you a good backing so that this can stick to this area. Unless you make sure this wound is being addressed, if you apply this, what will happen? If you're not taking care of the wound and you directly just apply this, what will happen to this pouching system? This will come off because patient has got very dirty wound and which is exuding. So this will come off and patient will again have to buy one, again out of pocket expenditure. So we sitting at the clinics really need to identify these small things which are going to be a bigger complication for patients. Advise them accordingly. Okay, use this barrier, use this remover, use this scissor free or the high-tech moldable devices what you can. Okay, I think we already talked about the management of this. Okay, folliculitis. Why will folliculitis happen to a patient with this stoma? What happens? Anybody? Folliculitis means infection of hair follicles. Infection of hair follicles can happen because the area is constantly wet. Again leakage, again culprit is leakage and patient is using, imagine cut to fit barrier. So there will be gap, there will be space, even though what all efforts you put in, leakage will be, unless you advise them, okay, see, this is something which is moldable, this will hug the stoma, there will not be leakage. That's part 2 which we need to be aware of. So this is folliculitis. What should be done, what should be advised to the patient when they are discharging? To make sure that they should not come up with this. We advise them to shave the area around. So if there is no follicles, there won't be any leakages. Also, if you see patient has come up with this folliculitis, advise them. Okay, now patient with folliculitis, you apply this adhesive, this skin wafer which is very, very strong and adhesive. If patient is trying to take off after 3 to 5 days, what will happen with a patient who has folliculitis? Patient will have very, damage to the skin. So what we advise them is adhesive remover. So that's the adhesive remover which we advise our patients so that even though if they get any complication, they should not be in pain. Management is very, very important for us to understand, right? And these patients many a times are palliative patient also. And what is most important responsibility for healthcare professional is give them a peaceful life, right? Make sure that they should not have any pain because that's the last thing I think we do for the palliative patients. So if I just give you an example, this is Dynaplast. Okay, I won't be able to, okay. Now just apply this and then just take it off. This will come off like very smoothly. right? So that's how it should be. Because time is limited, I'm just going little faster. Let us know if there is anything. So folliculitis, other than what medicines we will be giving, this is something which we should know how to help our patients. Raising this, using the razor is important, using the adhesive remover is important, using a barrier which goes with their stoma is really very, very important for us to understand there. Okay, this is again skin trauma. This can happen to any patient. If patient is just after surgery started walking, they can just hit any area, anything happens. Or this also abrasion this removal of the skin barrier very quickly can also cause the adhesion or these kind of rashes to the patients. So advising them adhesive remover is very, very important for us at this point. Pressure injury. Why pressure injury will happen in patients with stoma? Anybody? Yes, because of continuous pressure what these appliances are giving the patient. Also, will you say this, that always when a surgeon creates a stoma, that stoma is always a perfect stoma? No. Many a times it's not. It's not in even surgeon's hand to create a perfect stoma, given the fact the intraoperative challenges we just saw. There are a lot of intraoperative challenges which are beyond human control, and there is many chances that stoma is not nicely protruding how it should be. Many a time it is flat or it is retracted inside the skin. So what we advise for those patients to use the convex skin barriers. Now this skin barriers are always convex also. It has got some convexity to it. Once you use this, you have seen a patient who has got flat or a retracted stoma, you apply this convex barrier, little application, and this will come up. Stoma will come up and it will protrude a little, support the patient and help them. Pressure injuries, this can happen because of this constant use of this thing. So if at all you see, first management would be that you need to make sure that whatever is causing the pressure has to be removed. Moist wound healing dressing under skin barrier. So how we deal with the pressure wound or the pressure ulcer, this has to be managed that way, and also make sure that this wound is managed with the advanced wound care dressings first before applying these pouches or supporting them with any accessory. Last, I think, complication from my side, uric acid crystal deposition. This is a very, very practical thing, and I have learned this, what is written in the last paragraph, from one of very renowned ET nurse, Miss Neelam Lal, who was, I think, ex-DNS here as well in Aiims years before. What she was telling me, that what she used to do was, uric acid crystals will be very, very common in patients with the urostomy. If a patient is urostomy, you will see this kind of alkaline crystation around patient's skin area. What you do is, you take, whenever you are advising patient to change the pouching system, you advise them to use the vinegar, 30 to 50% concentration, put gauzes inside and ask patient to keep these vinegar dipped gauzes over these areas for 20 to 30 minutes. So this crusting will come off very nicely, smoothly. So this is something we need to be aware of so that we can also manage these patients practically in the clinics. So this is all about this. Okay, I won't talk about because time is limited. Any other question from your side before I show you, I think 5 to 10 minutes, or I think I have 5 more minutes to how to apply these, how to do this. Any question, please feel free to ask. Please, Amir, come here. Okay, so we did talk about a lot of things. Am I audible? It's not
Hello, hello.
Anybody would want to volunteer for 5-10 minutes also can come and see how you need to do when you are doing for the patients.
हाँ, प्रकाश है हमारे बीच में. प्रकाश
please Prakash come.
आओ प्रकाश जाकर जल्दी आओ वॉलंटियर. और विप्लव भी है, उसको भी लो. नहीं तो लोकेश को बुलाएंगे.
Yeah. Because I think
नहीं वो जान
Caesar?
बुलाए कि थोड़ा ज्ञान हो.
नहीं है तो मोल्डेबल खोल दो. सीधा है, कोई बात नहीं, मोल्डेबल. Okay, so now I think I'll talk about because my session started with patient's benefit, I'll talk about the most important product, what you see in the market which is available and which is in the environment is the moldable. Now with moldable what we do is we don't need to use scissor. This gives mental peace to the patients. You just need to roll, mold and hold and then apply this. Now I won't do, my friend I think he'll do it. Okay, now before applying this moldable skin barrier, we need to use the stoma adhesive powder because we are very, very sure that this is going to, patient will have leakages, something or other will happen and patient will end up with these problems. So always advise patients to use the stoma adhesive skin barrier. Now, who knows the crusting method of applying stoma adhesive skin barrier along with stoma adhesive powder along with skin barrier? Anybody? Crusting method of applying these two. That's not industry formula what I'm asking. I'm asking a clinical thing, clinical definition of crusting method. Anybody? Which I learned from one of a very senior ET nurse only. Okay, so what the crusting method is, skin barrier, please give me. Yes, so what happens is whenever you have a patient and you are sitting in the stoma clinic and you need to apply this ostomy pouching to the patients, what are the steps? First, always ask patient to sit comfortably, relax, take off the pouching system using the barrier spray. Always remember, no matter what happens, if you are going to take off this skin barrier from patient's abdomen, patient has any peristomal skin complication or not have, you need to apply this adhesive remover for sure. That's the only thing, because once you apply this, wait for 20 to 30 seconds, this will come off as on its own, this whole pouching system, and patient won't even realize that you touched his very, very sensitive area of body, right? So that's the adhesive remover's power that you need to do. Second, with all aseptic precautions, whatever is being taught to us in our clinical setup, because every hospital has their own SOPs how to dress the patient, use those. Clean the peristomal skin area and the stoma thoroughly, nicely. Then do the crusting method. Now crusting method is again an ideal international method which is being accepted by all the ETs in the world. You need to apply stoma adhesive powder on the peristomal area, wait for a few seconds, dust off excessive powder whatever is there, apply the skin barrier on this complete area. Wait for 20-30 seconds. You have made sure first layer of protection is there. Now once first layer is this, again repeat the same thing. After 30 seconds, apply this powder again on this area, wait for 20-30 seconds, dust off excessive powder, and then apply this skin barrier again on patient's peristomal skin area. You have created second layer which is going to give patient a layer which is going to give protection to patients from the effluents. Same thing, do it third time. Definitely, now things which I just say looks easier than, it's easier than done. So we need to do this, make sure that you are applying the crusting method before you apply these two. And then comes the basic pouching system. How do you do this? If you have a cut to fit barrier, patient has to cut it, following all the steps which we'll teach you in following ISP sessions. So they have to cut and then apply. But if they have moldable, you don't need to do anything. You don't need to use scissor, you don't need to use ostomy ruler or the scale, you don't need to have any other accessories with you. And once your patient is on the moldable or this scissor-free technology skin barrier, trust me, I have seen patients, they will not require all these accessories. No. Patient will just use it, roll it, mold it, hold it, apply it, and then apply the bag and they are good to go. Eventually, if you are advising them from day one, they will not have lot of accessories requirement, which is mandatory when we talk about the cut to fit barriers. So that's again, we are helping patients economically as well. It's not about we sitting there and advising, okay, use this Convatec person has come, now use this, another person has come, now use this. You need to see all the points what are important for patients before advising them, so that you should know all these things, right? So now you just show everybody how you just did it and just apply it. He's not using scissors, he's not doing anything, and then he'll just remove it and apply it. Amir, can you help? There is a release paper, we just need to take that off and then apply this. So this is again saving nurses time, education time. A lot of steps you need to show them. You don't need to show them. You don't need to tell them कि इसे cut करो. No matter how perfect you are, human factor plays their role and it will be irregular. Patient will have effluent and definitely patient will come back with some or other peristomal complication which we just saw, right? No need directly. Just apply this. Yes, so as I said, this is moldable. Unless it is indicated, a patient is obese or you see there are a lot of skin folds are there, do not use this. If patient has got a lot of skin folds, you need to level up the area. What will happen if patient is very, very obese, has come to you and you have not used this stoma adhesive paste and you have applied, if you do not use this paste and you just apply the pouching system, what will happen to an obese patient? Anybody, bullseye question. This will tell you the importance of using this this paste. Why we should be using. A very fatty obese patient has come. If you do not use this, what will happen? Patient jab tak leta hua hai, all fine. Once patient gets up, skin folds appears and this will instantly come off. Again, whatever it cost is gone, and again you will ask patient to go and buy. So that's the important. Here, I just wanted this to take a session saying clinical and practical together. I didn't make it 20 minutes this and 10 minutes this, so that we all understand. Clinically, I see this. If I do this, patient will not face this. So that's important take-home messages we should be learning on. So if patients apply this, if you help patient applying this paste on the folds or wherever the gap is for leveling the area, this is no glue, it's not glue, it has no adhesive to it, it's only helping patients to level up the area. So once this is being leveled up, you apply this as it is, this will stick definitely. Even though patient is getting up, sleeping, you have made sure to address those levels, this will help, right? So I think, thank you so much. So this was how, now, sorry? Okay, yes, please, if you wish to. Now this is again a very irregular stoma. Now second challenge what I have seen practically in my this thing also, always patient has irregular stoma. So when we use these moldable or scissor-less wafers, they can take up any shape. Any irregular shape can be adapted by these moldable wafers, unlike cut to fit wafers. Cut to fit ko aapne jaise kaat diya, now I cannot do anything. This is cut to fit which Amir has already cut to make sure that we get the right message. Now see the edges, these are sharp. So again one step increase for patients. Whenever you advise patient to use cut to fit, you always advise them to please do this. Remember, so that you make sure that the whatever edges, sharp edges are there, they are being blunt. Again one step, yes. So a lot of steps are there when I talk about the cut to fit, and hardly 1 or 2 steps when we talk about the moldable. So this is cut to fit, so this is how you apply. But once I have applied this to any shape, 57, 45, 70 mm, 100 mm, this is not going to change, right? But, and if I use this now, I mean, you all are there, I cannot show you this. So once you apply this moldable, irregular stoma is also being taken care of. So that's again the practical challenges which we see in the clinics or the OPDs. Once we know the answers, we can help our patients. Okay, I think that's all. One last thing is the belt. When will patient use these belts? What is the use of using these accessories? Anybody? Why will you advise and when will you advise your patient to use a belt? Sorry? During sports. Oh yeah, so this will give the added security to patients who really feel, who keep on feeling कि यार ये निकल आएगा. Sister आप कुछ भी बोलो ये निकल आएगा मुझे ऐसे लग रहा है. You give them a belt for the added security and they will be more confident. So what I have understood in this last 2-3 years since I am working with this, providing mental peace to your patient is very important for you, whatever it takes. Because if you are helping them in getting that mental peace, so they will be more confident taking forward their life with the ostomies. Otherwise, living with ostomy is very difficult. As you and me are talking here, it's not that easy once we see those patients, because they have already gone through hell, and now how we can help them adapting this new normal is on us, how we can help them and what all we can provide them. Again, second indication for this is when patient has got retracted stomas, very, very common, flush stomas. You are applying this convex skin barrier for sure, but then if you apply this as well, then patient will have added security as well as added protrusion of stoma. So with that protrusion, with this belt and convex barrier, patient will again be more confident about their ostomy pouching system. So I think with all these, I tried and I took 5 minutes over this time, but I think I tried to make sure that you get the complications and you get the solutions, preventive as well as mitigating the complications, both aspects. So thank you so much from my side. Thanks for your patient listening.
Thank you, Dr. Priya.
Yeah, so that was the barrier spray. I am keeping it here only. This water which comes through, and this is something which is still floating. That's the magical product, what we know, what we should be knowing of. Thank you so much. Thanks for your listening. Yeah.
Thank you, Dr. Priya, Mr. Gopi, and Dr. Ashwant. मैडम का जो आए हैं जिनको कराना है अपने पेपर लिख दो, मैं बोल दूंगा या लिख दो. So let's move to our next topic, hepatectomy. I would invite Mr. Navneet Pawar as a moderator. He is a nursing officer in main OT. In panelist, we have Dr. Vignesh with us, Ms. Sunaina ma'am, and Mr. Sunu, nursing officer, main OT Aiims. Please. पैनलिस्ट में है डॉक्टर विघ्नेश आ गए हैं, मिस सुनैना मैडम और सनूप NCA, Dr. Karthik. Okay, so Dr. Karthik would be joining us in place of Dr. Kailash. So we have two special guests with us from our nursing fraternity. ANS Pragya ma'am, please आप आइए. आपके सम्मान के लिए मैं हमारे बीच में मेदांता से रमन है. आप मेदांता, हाँ मेदांता से एक जने आइए. बाहर से और कौन है दूसरे इंस्टीट्यूट से? रमन एक बार आप आइए. रमन, हाँ. और एम्स से बाहर से कोई है अभी फिलहाल? कौन है? BPS? एम्स नहीं, वो एम्स का ही पार्ट है.
आप अपने फ्रेंड को भी बुलाओ.
हाँ, एक बार फ्रेंड को बुला लो, मैडम का सम्मान कराएंगे उसी से, है ना? रमन आइए. ए टोकन ऑफ आएगा, एक एक करके आएगा. फोटो हम आप तक देंगे मैम. आओ. इसी कड़ी में हमारे साथ में पुष्पलता मैडम भी हैं. आप NCA में हैं, ANS. आपका भी बहुत बहुत स्वागत है. आपके सम्मान के लिए मैं रिक्वेस्ट करूंगा प्रियंका जी से और दयानंद जी से कि आप मैडम के सम्मान के लिए एक बार आगे आएं. बहुत ही सुंदर सा मेडल, ओलंपिक टाइप. हाँ, मतलब फील आ रही है ओलंपिक जैसी. So, Navneet, bye. Over to you.
पुष्पा दीदी को दे रहे हैं अभी 5 मिनट. पुष्पा को दे जा रहा है ना.
देखिए, ये हमारा सेकंड लास्ट सेशन है. इसके बाद में हमारा एक बहुत ही ज़्यादा इम्पोर्टेंट सेशन है, वो सभी को अटेंड करना है. इमेजिंग और स्टेपलर.
आ जाना, बात करके पीछे बैठेंगे आराम से. अरे जरा देर के लिए आ जाना. मैंने
जितने भी लास्ट सीट्स पे बैठे हो आप आगे आ सकते हैं, थोड़ा सा अच्छी विजिबिलिटी हो जाएगी. प्लीज कम फॉरवर्ड, जल्दी से आ जाइए. लोकेशन टीम पीछे जल्दी से आ जाइए आगे. नहीं आगे अभी तो है. अभी अटेंडेंस भी बाकी है लास्ट वाली, जिससे 6 से 8 क्रेडिट आर हो जाएंगे. जल्दी से आप आगे आ जाइए. चलिए
किसने खींची है? जिसको पकड़ा रखा था. इसको पकड़ा रखा था कैमरा मैंने. मैं इस मामले में अरे ये बहुत दिन से ये मेरे पीछे पड़ी हुई थी लड़की पे.
Am I audible?
बहुत दिन से.
हाँ लास्ट में
मेदांता से.
चलिए सब लोग रेडी हैं? ठीक है. सो दिस इज आवर सेकंड लास्ट टॉपिक.
मैं उसको देखी ना, वो अच्छा था. वो उसको पकड़ा दिया और फिर पकड़.
इसके बाद लास्ट टॉपिक इन डिस्कशन एंड सेकंड लास्ट टॉपिक आज का, और इसके बाद जस्ट इमेजिंग होगी और इसके अलावा कुछ भी नहीं होगा. फाइनली यू आर फ्री. ठीक है. सो जस्ट फील फ्री एंड फील रिलैक्स राइट नाउ. फाइन.
बात जाना है.
एंड माय टॉपिक और मेरे टारगेट होंगे लास्ट के बैठे हुए लोग, क्योंकि दिस विल बी अ डिस्कशन सेशन. ठीक है. मैं केवल पढ़ूंगा नहीं, आई विल बी आस्किंग ईच एंड एवरीथिंग and randomly I'll be asking from here, so be ready for that. And my first target will be Miss Nisha. I don't know, randomly I told some name. Oh, yeah. So I have her mail ID also. ठीक है. So good evening everyone, myself Navneet Pawar. Good evening all dignitaries and good evening all panelists. Special thanks to Dr. Karthik. We were missed a lot. So today what we are going to discuss is hepatectomy and liver cancer. So mainly we will be focusing on liver cancer and hepatectomy. I will not take you so much time. I will be wrapping very so our topic will be first हम बात करेंगे liver की anatomy में and hepatectomy, liver cancer, their indications and their risk factors, pre-operative techniques, intraoperative, post-operative and all nursing interventions. So अब मैं आपसे पूछूंगा साथ साथ में and I will be talking in bilingual so it will not get some boring session. So fine. Anatomy अभी तक आप morning से देखते आ रहे हो. Now tell me, liver को 2 पार्ट में डिवाइड करता है. Which part? What? Yeah, obviously that this it's here, no? What is it? Yes, fine. So this is the visceral view of original and real liver. Today this is our important diagram. Can you see it? Yeah. So this is called Cunard or Cunard classification. Actually, liver is divided into 8 segments. Segment 1, 2, 3, 4A, 4B, and like that, and so on up to till 8. So we have to, today this is our important section. Here, why it is important? Because in liver cancer, there is a liver cancer which is called hepatocellular carcinoma, which is the most common cancer of liver. And 75% of liver cancer is this one, hepatocellular carcinoma, and which is found here. Which segment? 8. Last one, that madam?
8.
Yeah, yes ma'am. I was talking about you. Which section? Section 8, yes. हाँ, अब सब लोगों का ध्यान आ गया यहाँ, है ना? Yes, अब नींद भी उड़ गई होगी थोड़ा बहुत. Yes, this is what I wanted. So now indications of hepatectomy. What are the indications? The main indication of hepatectomy is liver cancer. And the second one is metastatic liver, like cancer from any other part, example from breast or lungs or any other part which has come to the liver. And another one is benign tumor. This is not so much dangerous, but it could be an indication. And another one is traumatic liver, like some gunshot or stab wound. And one is donor, and that we have already discussed our topic, liver transplantation, right? So what is liver cancer? Anybody from audience? Obviously, any abnormal growth in liver is called liver cancer, correct? And especially a malignant one. What is the most common type of liver cancer? Yeah, you have seen, and I've already mentioned that, right? So hepatocellular carcinoma is the most common type what? Liver cancer. And what is the percentage of it, Mr. Mahesh ji? Yes. How much? 75. So randomly I'll be taking some names. है ना? अब तो नींद तो उड़ी ही होगी. Hopefully. Okay, can you see it? This is the healthy liver, and the another one side is a cancerous liver or tumor liver. Now, classification of liver cancer. Liver cancer are classified into two parts. One is called primary, and the another one is secondary cancer. Primary is that liver cancer which is generated from that part, that is from liver. And the second is that we were talking like a cancer which came from any other part, like from breast, from lungs. That is called secondary. And which is the most common primary liver cancer? Yes, not HCC. Please, full name. Hepatocellular carcinoma. Yeah, exactly. Correct. And there are other carcinomas like bile. This is the bile duct carcinoma and hepatoblastoma. Hepatoblastoma carcinoma is the most commonly seen in children, especially in infants. Okay. Next, here is a summary. If you want to see, you can read it once. I have tried to mention the age as well. Done? Chaliye. Onwards, risk factors. What are the risk factors of liver cancer? Yeah, what is the most common cause of any liver cancer is chronic hepatitis, and especially B and C. And the second one cause is cirrhosis. And what is the most common cause of cirrhosis? Alcohol. Obviously, you must be knowing these guys. Yes, right? Your friend, your known, some uncle, auntie, है ना? कुछ होते हैं ऐसे लोग, खूब शराब पी के क्या हो जाते हैं? Yes. Deepak sir is very much excited. Nice. ठीक है. Aflatoxin exposes. What? Anybody knows this word?
Can I please correct you here?
Yes, sir.
So now the most common cause of cirrhosis is not alcohol; it is non-alcoholic fatty liver disease, which is metabolic liver disease. NAFLD. Yeah,
this is
most common cause of cirrhosis is also NAFLD.
Yes.
Not chronic hepatitis. Not chronic hepatitis.
Yeah, I forgot to mention that alcoholic and non-alcoholic liver.
Alcohol also causes metabolic diseases.
Yes.
Not that alcohol cannot cause it, but alcohol also causes it. The lifestyle. See, if you see a person who is drinking, you think that okay, he is the culprit because उसका cancer liver खराब हो गया. But आप ये नहीं देख रहे, और भी इतने सारे लोग हैं जो जिनको metabolic disorders है, hypertriglyceridemia है और metabolic derangements है, उनको भी liver cancer हो रहा है और CLD हो रहा है, तो उनको भी transplant का जरूरत पड़ रहा है.
Yes, thank you. Anybody knows this word? Aflatoxin. Yes, sorry ma'am? Yeah, you are right. See, aflatoxin is a toxin which is naturally generated from, especially from like, so we consume some foods. Some foods like we are taking corns, right? So corns will contain some fungus, and fungus will lead to these type of aflatoxins, and these exposure may also harm liver. Okay? So some metabolic disorders, and here your friend, and this is the traumatic liver. I have taken this picture from one of my friend, and he sent me this picture, and he told that his a patient came with this liver, and he told that his wife did this, a gift. What is it? A stab wound. Can you see it? Yeah. So now moving ahead, hepatectomy. बहुत सारे अब थोड़ा सा सीरियस हो गए हैं. चलिए ठीक है. Now hepatectomy. What is hepatectomy? Anybody from audience? Yeah, surgical removal of liver. How much liver? Partial removal or complete removal? Partial as well as complete. Both are called hepatectomy. If we are removing partial liver, that is called partial. And if we are removing it, then complete, total. And if you are removing surrounding structures as well, then yes, radical. And what else? Yes, extended, exactly. Now, types of hepatectomy. Hepatectomy can be divided into two parts, especially major hepatectomy and minor hepatectomy. Here, it's written 3 or more segments. Now tell me how many segments are there? Wow, wonderful. And which segments contains the most common cancer? Wow, and which one is? Wow, a big clap for you. Yes, where? Here, here or here? Yes, it's here. It means 8th one. So, if we are removing any 1 or 2, then it will come under which one? Minor or major? Minor, obviously. And if removing more than 3, that is will come under major. Yeah, any. Now, according to anatomically, like if surgeon, our favorite surgeon is Dr. Karthik is here. So, if suppose our Dr. Karthik is removing according to anatomy of the liver, then it is called anatomical resection. And if he is cutting anyway, whatever he wants to cut, then it is called, yeah, that's very simple, correct? Now if you are removing left liver, what is called? And right निकाल दिया तो बहुत बढ़िया, और liver को बढ़ा दिया, gallbladder भी निकाल दिया तो, you know, you are very intelligent. So here, हाँ, सुबह से पढ़ रहे हैं, फिर भी उनको ध्यान नहीं था. कुछ लोग बात कर रहे थे, लेकिन अब नहीं कर रहे हैं, क्योंकि मेरे पास क्या है? क्वेश्चन लिस्ट है इनकी. ओके, ठीक है. नाउ मेजर एंड माइनर hepatectomy, we have told about it, right? We have talked. See, this is a partial hepatectomy. Can you see it? Okay, anatomically. Anybody, ये क्या चीज है, कोई बताएगा? सूटोपैक्स, पर है क्या? सूटोपैक तो उसका नाम है, सिल्क है. Yes, exactly. These are silk. Anybody can tell me whether it's absorbable or non-absorbable? Non-absorbable. लेकिन ये भी थोड़ा बहुत क्या हो जाते हैं, इसलिए तो नाइलॉन्स आए हैं. ठीक है, चलिए. लेकिन अगर हमें कोई चीज ब्लड वेसल, कोई ब्लीडिंग हो रही है ब्लड वेसल, फॉर टू लाइगेट दैट वी हैव टू यूज दिस वन. ओके, यस, यस. Now, if we are removing according to the location, then it is called according to location. If we are removing right liver, then it is called. If we are removing left liver, and if suppose we are removing some segments, then it will be according to that name, like segment 1, segment 2, section 1, section 3. Yes, yeah, exactly, ma'am. Then you got it? Yeah. Next thing, other classification like complete and partial. We have already talked about it. Now, open versus laparoscopic and robotic. Mansi already covered this topic, right? देखा था आप लोगों ने? तो कौन सा हम लोग रोबोट यूज कर रहे हैं यहाँ? डिवांची तो सबको पता है, उसके अलावा है? है? हमारी ओटी में एक नया है, और ओटी के सारे लोग हैं, कितने? मिंत्रा. वेरी नाइस. बस ठीक है, आई गॉट इट नाउ. मिंत्रा से मंगाया है. यस, दिस इज एन एग्जाम्पल ऑफ पार्शियल हेपेटेक्टमी. सो लेट्स कम टू द सम प्री-ऑपरेटिव और पेरी-ऑपरेटिव टेक्निक्स एंड मैनेजमेंट्स. अभी तक आपने सुबह से यही पढ़ते आ रहे हो कि क्या क्या करते हैं प्री-ऑपरेटिव में. तो क्या क्या करते हैं प्री-ऑपरेटिव में? मैं ये नहीं पढ़ूंगा, आप लोग बताओगे मुझे. सबसे पहले WHO चेकलिस्ट करोगे, पेशेंट आइडेंटिफाई करोगे. यस, व्हाट वी आर गोइंग टू डू? यस, असेसमेंट एंड आइडेंटिफाई द पेशेंट. एंड एस नरेश मैम ऑलरेडी टोल्ड अबाउट हेमा मैम, है ना, कि पैरासीटामोल का क्या चल रहा था उनका, कि पेशेंट एलर्जिक था, और पेशेंट हम लोगों ने क्या कर दिया, फिर देखा, और उसको पैरासीटामोल चलने वाला था, और हमने देखा. क्या बात समझ में आया? तो ये हमने क्या करना है, एसेस करना है. और एवरीथिंग वी हैव टू सी, वी हैव टू चेक इन्फॉर्म कंसेंट, वी हैव टू टेक, वी हैव टू सी वेदर ब्लड इज अरेंज और नॉट अरेंज. करेक्ट? OT preparation, this is our job or not? Obviously. WHO checklist and diagnostic evaluation. We'll talk about something about diagnostic evaluation. What diagnostic evaluation? And from blood test to liver test, from USG to MRI, everything we can go for it. Okay? And there is a word called FLR. This might be new for you today. What is it? Future liver remnant. What is it? क्या है ये? जो हेल्दी लिवर पार्ट होगा उसको निकाल देंगे. देखो, जो लिवर में, ये समझिए, आई विल बी स्पीकिंग इन हिंदी नाउ. जो लिवर में क्या होगा, हम पार्ट छोड़ देते हैं लिवर के लिए. मान लीजिए मैंने 10% निकाल दिया, कितना परसेंट छोड़ दिया? 90%. जो 90% हेल्दी पार्ट पेशेंट में छोड़ा, दैट इज कॉल्ड फ्यूचर लिवर रेमिनेंट. ये कितना होना चाहिए एटलीस्ट पेशेंट में? मोर देन 25%, 20 to 25%. लेकिन यूजली इट शुड बी अ गुड कंटेंट. किसको बोलते हैं? जब ये 35 to 40% होता है. ठीक है, ये ऐसा क्यों छोड़ा जाता है बताइए? वाई? सोचो. लिवर क्या करेगा? यस मैम, रीजनरेट. लिवर विल रीजनरेट. इफ लिवर विल रीजनरेट, ठीक है, तो रीजनरेट करने के लिए कुछ तो चाहिए ना. ठीक है, तब तक कौन काम करेगा? FLR. गॉट इट? सो दिस इज द वेरी इंपॉर्टेंट कॉन्सेप्ट यू शुड कीप इन माइंड. व्हाट इज इट? फ्यूचर लिवर रेमिनेंट. नेक्स्ट थिंग, ये इन्वेस्टिगेशन में भी हम डिसाइड, सर्जन्स विल डिसाइड कि हम कितना इसको रखेंगे, कि कितना हमें निकालना है, कितना रखना है. ये सर्जन डिसाइड करते हैं, कि दे विल डिसाइड. नेक्स्ट, प्री ऑपरेटिव नर्सिंग केयर. अब ये आप लोगों ने हम बात कर ही रहे हैं. प्री ऑपरेटिव में हम क्या क्या करते हैं? जैसे सर्जरी, पेशेंट को समझाना है, पेशेंट को एंग्शियस नहीं होना चाहिए, पेशेंट के बारे में पूरी डिटेल पता करनी है, पेशेंट कोई ड्रग तो नहीं ले रहा है, पेशेंट के कोई पुरानी सर्जरी तो नहीं हुई है, पेशेंट ने कोई ऑर्नामेंट, सबसे इंपॉर्टेंट चीज, ऑर्नामेंट्स तो नहीं पहना है, क्योंकि ऑर्नामेंट पहनने से क्या होगा? इन्फेक्शन नहीं. यस, इलेक्ट्रिक करंट है ना, क्योंकि हम इन लिवर सर्जरी, यू हैव सीन राइट, वी आर यूजिंग आर्गन, वी आर यूजिंग क्यूसा, वी आर यूजिंग लॉट ऑफ थिंग्स, करेक्ट, जिसकी वजह से क्या होने के चांसेस हैं? यस, सर्जरी बोन होने के चांसेस है. दैट्स व्हाई वी विल नॉट यूज दिस थिंग, करेक्ट. सो दिस थिंग वी हैव. चलिए, नाउ अब इंपॉर्टेंट पार्ट वो है इंट्रा ऑपरेटिव नर्सिंग रूल एंड इंट्रा ऑपरेटिव प्रोसीजर विल गो टुगेदर ओनली. बताइए, इंट्रा ऑपरेटिव में नर्सिंग का सबसे इंपॉर्टेंट काम क्या होता है? देयर विल बी 2 नर्स, वन विल बी इन फ्लोर एंड वन विल बी इन स्क्रब. सो व्हाट इज द मेन फंक्शन ऑफ स्क्रब नर्स? टू असिस्ट. असिस्ट ऐसे ही थोड़ी कि निकाला सीजर और पकड़ा दिया, लो नहीं, सेटअप. फर्स्ट सेटअप करना है, हमें देखना है, इंस्ट्रूमेंट को रेडी रखना है, वी हैव टू गिव प्रॉपर. ठीक है, यस, ठीक है, यस मैम, एग्जैक्टली. एग्जैक्टली. सो वी हैव टू प्रिपेयर आवर माइंड फ्रॉम द फर्स्ट स्टार्टिंग पॉइंट टू लास्ट पॉइंट. एवरी स्टेप हमें पता होना चाहिए कि नेक्स्ट स्टेप क्या चल रहा है. इवन डॉक्टर कार्तिक, एक बात बताता हूं मैं आपको, जब वो बाइपोलर करते हैं तो उनको चाहिए कि छोटा स्लाइन कैसा चाहिए? ड्रॉप बाय ड्रॉप. बट आई नो, मुझे कब पता चला? जब मैं सर्जरी कर रहा था तब नहीं, जब इन्होंने किसको डांटा? अपने असिस्टेंट को. उन्होंने कहा हाँ, नेक्स्ट टाइम से जब मैंने ऐसे डाला, एंड ही वाज इम्प्रेस्ड. आस्क हिम, इज इट ट्रू? यस, यस, ओके, यस. सो यू शुड कीप दिस थिंग इन माइंड ऑल्सो, करेक्ट. फिर आगे की कहानी, इंट्रा ऑपरेटिव प्रिपरेशन. ये सब ये जो चीजें हैं, ओवर एचिंग प्रिंसिपल्स, ये सर्जन्स करते हैं. ये सब देखा जाता है कि कितना विजुअल फ्लूइड छोड़ना है, कौन सा रिट्रैक्टर रखना है. रिट्रैक्टर रखने का काम हमारा है. सो कोई बताएगा कौन सा रिट्रैक्टर अभी तक सबसे ज्यादा इमेज देखी है आपने? तो हमसे लास्ट में मैडम बाल बना रही हो, आप बताएं. हाँ, शैली है तो हाँ बताओ क्या? यस, वही जो मैंने पूछा. क्या? यस, थॉमसन रिट्रैक्टर सबसे ज्यादा यूज होता है लिवर सर्जरी में. क्या बात सही है? नाइस. नेक्स्ट थिंग, ये है, ये कौन सा रिट्रैक्टर है? पक्का? एक इमेज, ठीक, अभी आएगा. सो व्हाट आर द प्री रिक्विजिट्स? इंस्ट्रूमेंट्स, मशीन्स, सूचर्स, हर वो चीज जो सर्जरी में चाहिए ही चाहिए. मशीन्स है ना, एनर्जी सोर्सेस, हेमोस्टैटिक एजेंट्स, ये सब हमें चाहिए. ये क्या है? नाम बताओ ट्रॉली का. बहुत अच्छा है. ट्रॉली कौन सी वाली? इंस्ट्रूमेंट ट्रॉली. और नाम क्या है इंस्ट्रूमेंट ट्रॉली का? है नहीं, कोई बता दो मुझे आज. इधर वाले बताएंगे हमें. हाँ बताइए. एक मैडम बात कर रही थी कि ये तो मुझे आता है कोई या वो दे रही थी, वही बताएंगे. दिख नहीं रही मुझे पर. हाँ चली गई वो, उनका 6 आवर्स कट गए. नेक्स्ट, मेयो स्टैंड है ना, ये तो देखा ही आपने. ये मेयो स्टैंड में हमने क्या क्या रखा हुआ है? रिट्रैक्टर्स, ठीक है, और सक्शन, हमें पूरा एनर्जी सोर्स के लिए सब कुछ चाहिए, ठीक है। ये हमारी ट्रॉली है और हमेशा अपनी ट्रॉली को ऐसे प्रिपेयर करें, कैसा कि रेडी रहे पहला, क्योंकि सर्जन आपको फर्स्ट स्टेप फर्स्ट, ठीक है। आई हैव लर्न दिस थिंग फ्रॉम नरगिस मैम कि पहले से रेडी रखो। और हमारे दयानंद सर ने हमेशा बोला कि कभी भी जैसे जल्दी जल्दी होती है ना आपको, तो पहले स्पंज काउंट करके रख दो 5, फिर अपना काम बाद में कर लेना। मैं दैट वाज द वेरी हेल्पफुल। और कई बार होता है, ठीक है, और सर लोग आ जाते हैं कई बार जल्दी 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 हो, एंड बोला जल्दी जल्दी, मैंने सर 5 गिना दो, पहले गिना दिए, रख दिए अलग से, और हमने क्या किया, जल्दी जल्दी उसका काम करवा दिया और फिर बाद में इंसिजन कर दिया। क्या बात समझ में आया? ठीक है। ये देखो, आज का मेन चीज यही होना चाहिए कि हम एज अ नर्सिंग अपने प्रोफेशन के लेवल को कैसे आगे लेके जाए, करेक्ट? ठीक है। व्हाट इज इट? रोशार्ड? नो, क्या है ये? थॉमसन की रोशार्ड है ये? यस, दिस इज, ये वाला रोशार्ड है लेकिन ये वाला थॉमसन है, ठीक है। यस, एंड व्हाट इज इट? कोई ब्लेड देख के बता सकता है? ये थॉमसन है, ठीक है। एंड व्हाट इज इट? क्यूसा। व्हाट इज द फंक्शन ऑफ क्यूसा? ये ऑलरेडी पढ़ चुके हैं आप, बताओ क्यूसा का फंक्शन क्या है? चलो मैं नाम बताऊं, नवीन कौन है? मैं नहीं हूं, ईशा सैनी, सब भाग गए। नाइस, ये तरीका सही है, ठीक है। सो क्यूसा का काम क्या होता है? क्यूसा बहुत ही क्या होता है, ये एस्पिरेटर होता है जो अल्ट्रासोनिक प्रिंसिपल में काम करता है, ठीक है। ये क्या करता है, लिवर के टिश्यू को काटेगा, ठीक है। लिवर, नॉट जस्ट लिवर टिश्यू, इन जब हम न्यूरो सर्जरी में थे तो न्यूरो सर्जरी में बहुत ज्यादा यूज होता है, ठीक है। जैसे कि ट्यूमर्स को निकालने के लिए, जो ऐसा कोई भी एनाटॉमिकल स्ट्रक्चर जहां हाई वेस्कुलराइजेशन हो, वहां पे हम क्यूसा का इस्तेमाल करते हैं। क्या बात समझ में आया? ठीक है। सो दिस इज कॉल्ड क्यूसा एंड दिस इज द आर्गन मशीन। ये आपको ये दिख रहा है कुछ? 1 सेकेंड, ये दिख रहा है कुछ? ये क्या चीज है? ये आग जलती हुई दिख रही है, आर्गन है ये, आर्गन का प्लाज्मा है ये, ठीक है। ये इसको बोलते हैं आर्गन प्लाज्मा कोगुलेशन, एपीसी, ठीक है। ये बहुत इंपॉर्टेंट चीज होती है। क्यूसा आ गया। सूचर्स, अभी तक आपने मॉर्निंग से सूचर्स ही पढ़ते जा रहे हो, ठीक है। कितने टाइप के सूचर्स होते हैं? अब ये मत बोलना एब्जॉर्बेबल, नॉन एब्जॉर्बेबल, देयर आर वेरियस टाइप ऑफ सूचर्स। एब्जॉर्बेबल, नॉन एब्जॉर्बेबल तो 2 मेन कॉन्सेप्ट है, ठीक है। ऐसे बहुत सारे हैं। क्या बात समझ में आया? ठीक है। नाउ अब सूचर्स जो हम यूज करते हैं, देयर आर, जैसे सब लोगों ने बताया, हेपेटेक्टमी में हम लोग सूचर यूज करते हैं। जैसे सूचर यूज कर लिया, एब्जॉर्बेबल भी कर लिया है, नॉन एब्जॉर्बेबल भी किया है, एंड वी आर यूजिंग प्रोलीन 4O, प्रोलीन 5O, 6O। For 6O we will be having micro needle holder which is known as Castro, yeah, ठीक है, ऐसे। Now what is it? Vascular clamp. What is the function of vascular clamp? Clamp करना, nice. Vascular clamp का function है clamp करना। Yes, vascular clamp होता है clamp the artery, blood vessel, ठीक है। जो ब्लड वेसल क्या होने वाली है, तो ब्लीडिंग करेगी या कर रही है, उसको क्या करने के लिए? क्लैम्प करने के लिए, ठीक है। नेक्स्ट, दिस इज हीमोस्टैटिक एजेंट्स। हीमोस्टैटिक एजेंट मोस्टली जो होते हैं ये सेलुलोज से बने हुए होते हैं, ठीक है। मोस्टली हीमोस्टैटिक एजेंट डिफरेंट टाइप के होते हैं। जैसे आपने ये जो दिख रहा है, ये टिपिकल क्या है हमारे पास? यस, फिब्रिलार। जब आप फिब्रिलार देखोगे, फिब्रिलार होता है एक सर्जिसेल होता है। ऐसे ही बहुत सारी क्या क्या चीजें होती है, स्नो वगैरह है ना, इंटरसीड। इंटरसीड क्या ये सेम है? यस, इंटरसीड इज नॉट अ हीमोस्टैटिक एजेंट, याद रखना, दिस थिंग इज वेरी इंपॉर्टेंट, ठीक है। नेक्स्ट थिंग, सर्जिकल टेक्निक जो हमने बात करी है, ये बताइए, ये कौन बताएगा? प्रिंजल मैनुअल, ये पता कौन से में किसने बताया था? ये उर्वशी मैडम आई थी, उन्होंने उस अपनी स्लाइड में लिखा था ये, बट नोबडी नोटिस्ड, राइट? नेक्स्ट, कैन यू सी इट? ये वाला, ठीक है। दिस इज एन एग्जाम्पल ऑफ बुलडॉग क्लैम्प। हियर ये आपके ब्लीडिंग होने वाली जो आर्टरी है उसको क्या कर रखा है? क्लैम्प कर रखा है, ठीक है। ये क्या है हमारा? ये भी हम लोग जो सबसे पहला सेशन हुआ था, ये क्या था हमारा? लेप्रोस्कोपिक एंड रोबोटिक। मुझे बोला गया था कि आपका पहला सेशन होगा, लेकिन मेरा पहले की जगह कौन सा सेशन हो गया है? लास्ट में। इसलिए मैंने सोचा जब मैं यहां तक रुक गया हूं तो तुम सबको भी क्या करूंगा? रोकूंगा, इसलिए आप यहां बैठे हुए हो, ठीक है, चलिए, दिस इज अ रोबोटिक प्रोसीजर. तो आपका टाइम ज़्यादा ना लेते हुए कॉम्प्लिकेशन की ओर चलते हैं और विल ट्राई टू फिनिश इट नाउ. So complication, what could be the complications? Bleeding, bile leak, liver failure, infections, pulmonary complications. This is the most important thing, post-operative care. Post-operative care आप OT में नहीं करते हो, mostly कहाँ पे किया जाता है? हाँ, कुछ जब रिकवरी टाइम के लिए पेशेंट रिकवरी एरिया में रहता है, उस टाइम पे किसी जगह हमारा OT की स्टाफ रहता है, किसी जगह में अलग से स्टाफ अवेलेबल होता है. ठीक है, चलिए. So this is the final, and can you guess who are they? Obviously, us. ठीक है, yes. ये तब की फोटो है, ये हमारा आखिरी एक साथ में क्या था, कैडेवर पेशेंट का ट्रॉमा सेंटर में, ये लिवर ट्रांसप्लांट की हो रही. वो अर्ली मॉर्निंग में गए थे, ये टाइमिंग इसमें शायद गलत डाली है, 4:30 बजे की थी. ठीक है, सो एट द एंड मैं यही चाहूंगा आपसे, प्लीज इस लाइन को पढ़े, जोर से पढ़े. यस, समझ में आया? ठीक है, आई होप आपको समझ में आया हो. थैंक यू सो मच. क्योंकि अब मैं नहीं मेरे पास स्लाइड बहुत ज्यादा थी, लेकिन मैंने उसको बैठ के क्या किए, छोटी की. क्यों? क्योंकि तुम्हारी शक्ल देख के क्या आ गई मुझे, तो आ गई है ना. ठीक है, नाउ आई विल हैंड ओवर टू आवर पैनलिस्ट. थैंक यू.
Very well presented, Navneet.
नवनीत ने बहुत ही अच्छा,
I loved it.
बहुत ही बढ़िया था. तो इसी में मैं ऐड करूंगा कि सर्जरी सेव्स लाइव्स, और नर्सेज क्या करती हैं, सस्टेन्स देम. एग्री? इसी को मैं कंटिन्यू करते हुए, तो डॉक्टर कार्तिक कुछ आप बोल रहे थे कुछ.
कि काफ़ी इंटरेक्टिव सेशन था नवनीत, एंड आई to be very frank, I never expected that we'll be talking about portal vein embolization and FLR. It is really good to see that you know all these stuffs, and I feel you being you have a teacher's attitude, you know, and you just kept the mahal going on.
तो नवनीत एक्चुअली टीचर ही है, नर्स, मतलब नर्सिंग ऑफिसर के साथ साथ में. तो कौन सा अपना चैनल है? नर्सिंग स्टूडियो. नर्सिंग स्टूडियो, तो वहाँ पे जाइए.
His teacher is also my friend, and he is also my friend. His teacher is also my friend.
अच्छा, तो इसके चैनल पे आप जाइए, उसको सब्सक्राइब कीजिए, लाइक कीजिए, वो बेल आइकन में दोबारा के प्रेस कीजिए. नर्सिंग स्टूडियो. सो बहुत अच्छी टीचिंग करता है, और उसका हमने देखा, उसका रिफ्लेक्शन आज सामने दिखा अभी. मैडम आप सुनैना जी कुछ इसमें गैप फिल करेंगे?
वैसे तो इसने सब कवर कर दिया है, और पहले मुझे लग रहा था फर्स्ट सेशन था इनका, बट लास्ट हो गया. बट इट्स गुड इनका लास्ट हो गया, तो इतना इंटरेक्टिव हो गया, अदरवाइज अब तक लास्ट सेशन में सब सो चुके होते. तो वैसे तो सब कवर है. बाकी हेपेटेक्टमी मेजर सर्जरी है, एज वी डिस्कस्ड. मतलब लीवर ट्रांसप्लांट में भी पहले हेपेटेक्टमी ही होता है पेशेंट का, तो ऑल प्रिपरेशन सेम ही है, विपल्स का, हेपेटेक्टमी का, जितनी भी मेजर सर्जरीज हैं. OT में जब पेशेंट आता है तो जो जो चीज़ें ध्यान रखनी है वो सब ने कवर कर ही दी हैं. WHO कंसेंट, OT प्रिपरेशन, सेट, सूचर्स, और काउंट, ब्लीडिंग के लिए हीमोस्टैटिक एजेंट्स. तो आई थिंक नथिंग लेफ्ट. एनर्जी सोर्सेज हमें चेक करने हैं. लास्ट का जो पेशेंट जब हम शिफ्ट करते हैं, उसमें 1-2 पॉइंट है कि कोटरी बर्न हम OT में ही चेक करते हैं, कि इतने ड्यूरिंग आवर्स, लॉन्ग आवर्स हो जाते हैं, पेशेंट को अर्थ प्लेट लगा हुआ है, वो अर्थ प्लेट मिसप्लेस हुई है बीच में, या कुछ और इशू हुआ है, तो वो हम लास्ट में अर्थ प्लेट जब हटाते हैं तो सर्जन और हम साथ में मिलके चेक करते हैं कि पेशेंट को कोई कोटरी बर्न नहीं है बिफोर शिफ्टिंग, एंड वी जस्ट नोट डाउन इट इन आवर रिपोर्ट बुक. सो दैट इज कम्स अंडर साइन आउट, दैट इज इन दैट चेकलिस्ट. WHO ना साइन आउट वाले
जो फ्रंट में लगा होता है,
लास्ट में बिल्कुल है, उसमें हमारा काउंट
आजकल फ्रंट में लगा रहे हैं.
हाँ, उसमें हमारा काउंट आता है, और ये इंस्ट्रूमेंट काउंट, स्पंज काउंट, निडल काउंट, सारे काउंट्स आते हैं. और पेशेंट को शिफ्ट करना पूरा चेक करके कि कोई बर्न नहीं है, पेशेंट का स्पेसिमेन हमारा सिक्योर हो गया है, वो हम हिस्टोपैथ के लिए भेज रहे हैं, और ये सब चीज़ें उसके अंदर हम करके फिर फाइनली पेशेंट को हम ICU या रिस्पेक्टिव वार्ड जहाँ भी जाना है उधर ट्रांसफ़र हो जाता है. तो दैट इज कम्स अंडर साइन आउट.
जी सनूप जी, आप कुछ ऐड ऑन करना चाहेंगे इसमें?
ऑल पॉइंट्स
ये वाला
एनीवे इट वाज ए गुड प्रेजेंटेशन। बाकी तो सब आपको पता है क्या इन्होंने क्या डिस्कस किया था अभी। तो एक चीज़ पूछना चाहूँगा कि अभी नवनीत ने बोला था कि डॉक्टर कार्तिक वाज लाइक टू वो बाइपोलर यूज़ करते हुए चाहिए कि उनको ड्रॉप बाय ड्रॉप डालना चाहिए था। इन्हीं से पूछो वही सलेन क्यों नहीं यू कैन गेट दैट कि वही सलेन क्यों यूज़ करना है, मतलब सलेन क्यों बाइपोलर क्लीन करना है, क्या प्लान क्या है, बाइपोलर फोर्सेप्स क्लीन करना है क्या है वही, बट सलेन क्यों बीच बीच में डालना चाहिए, वो भी ड्रॉप डालना चाहिए, ज़्यादा क्यों नहीं डाल सकता, बट वही सलेन यूजिंग।
I think the people who have assisted me can answer this question.
At least.
All the GI people can answer this. Because I keep
See.
on asking to my assistants and then
Exactly.
this, nursing officers also listen to it.
Yeah, it's a nice part. One
This
more
is his
thing.
favorite question, I guess. Whenever any junior will come, he'll be asking his junior, क्यों डालते हैं बदा? और पूरा 1 घंटा मजा आ जाता है ये सुनने में क्यों डालते हैं। तो इसका अच्छा एक्सप्लेन भी यही करते हैं, लेकिन उससे पहले आप कोशिश करें कि क्यों डालते हैं, कि बाइपोलर में सलाइन क्यों डाला जा रहा है। जब हम कोगुलेट कर रहे हैं उस टाइम पे व्हाई वी आर पुटिंग सलाइन।
And one more thing, not only in GA surgery, for every surgery, where is bioflower using and why we are putting saline?
हमारे ऑर्थो से एक मैडम थी सीनियर, तो आई थिंक वो उसके ऊपर कुछ आंसर कर पाए। ऑर्थोटी से आई थिंक चली गई।
आपका तो पॉइंट सही है।
तो ऑर्थोटी से अभी बहुत सारे होंगे, आई थिंक विप्लव एंड टीम चली गई या है
कुछ भी पॉइंट आप जानते हो उसके बारे में, क्यों आप लोगों ने कभी भी यूज किया होगा सलाइन डालते हुए हो?
ओके
हाँ, मतलब जल्दी आंसर ही बताओ या तो फिर।
तो आई थिंक डॉक्टर कार्तिक अपने टॉपिक में जल्दी क्लियर करेंगे और आपका ही लास्ट टॉपिक है, ठीक है? तो थैंक यू सुनैना मैम और सुनुप जी, है ना? सो
I think the senior most sister can
वो ही
tell.
करेंगे ना।
आप ही बताइए, आप बताइए।
मैम अब एक बार खड़ा होकर सबको बताओगे ना? हाँ, ये आपके पीछे ही है।
Excess to avoid excess burning. Number 2 is the tissue will, when the tissue will remain wet and the forceps will not चिपकोफाई, and अगर वो चिपक के यूं खोलेंगे तो extra tissue कट जाएगा and there will be aeration and the bleeding will occur even more.
That sister said in second point that it not sticks together when we use it. There's a lot of charring. So to prevent that, we put water. But why drop by drop? Why not you can just put a lot of water? It will hamper your vision. And you won't be able to do it. And as you rightly said, you may over injure or
And then
cut it
again
less.
the vessel mouth will open and it again jerk से आप forceps खोलोगे तो वो खुल जाएगा।
जी, मैंने बीच में किया हुआ है 2 महीने, तो मुझे ये कुछ याद आ रहा है। चलिए ठीक है, थैंक यू सो मच। अभी हम अपने लास्ट सेशन की तरफ मूव करते हैं। टाइम ऑलरेडी आई थिंक 6 बज चुके हैं। तो डॉक्टर कार्तिक, ओवर टू यू। आप बेसिक ऑफ इमेजिंग आप बताएंगे। हमारे साथ क्या जोंटी जी हैं जॉनसन एंड जॉनसन से जुड़े? आई थिंक वो नहीं है, तो स्टेपलर वाला पार्ट हम कंप्लीटली खत्म। ओके, तो ये हमारा मतलब फॉर्मली ये लास्ट टॉपिक ही होगा। 2 टॉपिक हमने हटा दिए, नहीं कैंसिल, और रोबोट वाला भी हटा दिया।
ऑडियो वीडियो विजुअल वाले भैया प्लीज एक बार आगे।
चलिए, जब तक की स्लाइड ओपन हुए हम थोड़ा सा एक डिस्कशन कर लेते हैं इसी को ऊपर ही। हम में से कितने लोग हैं जो डेली एक्सरेज देखते हैं हाथ में, मतलब या हॉस्पिटल की सेटिंग में? आज एक्सरे फिल्म हमारी आंखों के सामने से आई। कितने लोग? हाथ खड़ा करिए प्लीज, रेज योर हैंड। कितने लोग हैं जो सीटी स्कैन और एमआरआई की फिल्म ऐसे निकलती है उनके सामने से वो देखते हैं? पढ़ना नहीं है, मतलब सिर्फ लगी रहती है। हम में से कितने लोग हैं जो पढ़ने की कोशिश करते हैं, उसको रीड करने की कोशिश करते हैं? बहुत बढ़िया। और कितने हैं जो पढ़ पाते हैं? और वहीं पे एक जूनियर रेजिडेंट है, सीनियर बनता है, सीनियर के बाद फैकल्टी बनता है, वो हमें बताता है, लेकिन हम अपनी दृष्टि वहां तक, अपना विजन है वो वहां तक क्लियर नहीं करने की कोशिश करते। रीजन उसका बहुत सारे हैं कि हमें वैसा माहौल नहीं दिया, हमें वैसे टीचर्स नहीं मिले, देयर आर सो मेनी रीजंस। तो हम उस चीज के ऊपर नहीं जाएंगे, बट हमारे पास अपॉर्चुनिटी है कि वहां से हम, यहाँ से हम कुछ एक ऐसा एक दृष्टि जिसको बोलते हैं हासिल करें, एक ऐसा एक विजन लेके जाए, ऐसा एक गूढ़ ज्ञान लेके जाए कि शायद जो अभी तक हमने नहीं किया वो हम शुरू करें। तो इसी के साथ हमारे लास्ट सेशन की हम शुरुआत करते हैं। तो डॉक्टर साहब प्लीज।
मेरा हो रहा है, आ नहीं रहा है। स्विच करेगा, आप स्टार्ट करो। हाँ, पॉइंटर चाहिए होगा। कैसे स्टार्ट होगा? दिस इज hello everyone. So we'll move on to the last session of this topic, understanding abdominal CT scans. Previously this topic was given to me, but now they've probably changed it to basics of imaging. But I prepared this understanding abdominal CT scans only. Should be a guide for nurses. So let's keep the session going. So we start with the blessings of Mahadev. Like Mahadev, who holds the poison in his throat, offers the world Nargis sister. Nargis sister. Nargis sister, please. Yet offers the world the cool flow of Ganga. We, as a medical professionals too, should absorb the stress, pain, and sufferings of patients and give them comfort and healing and hope. True strength is not in fighting, but serving silently. So let's come to the purpose of this session. I mean, why this session has been kept. It is to basically enhance your understanding of the imagings that we do. What I feel is that due to the scarcity of doctors in periphery and all those places, a lot of quacks are coming up. And I feel, especially the people, the nursing officers at Aiims, they should be trained and they should act as a bridge between nurses and doctors. This is my personal thinking. So because of that only, I think your skills should be enhanced. Why it matters to nurses? A solid grasp of CT imaging can help you in diagnosing diseases, can help you picking up the complications early. And we'll be covering the fundamentals of CT scan, how it is acquired, what all are phases. And as Navneet, I'll also keep it interactive. And I have a quiz in the end. And whomsoever will answer, I'll give a chocolate to everybody. Whomsoever will answer. So what is a CT scan? So CT scan is basically hundreds of X-rays that we click in a single go. We have an X-ray beam which rotates around the patient while the patient is kept supine inside that console. And after taking hundreds of imaging in axial section, we create a multi-dimensional view, which is also known as multi-planar reconstruction, MPR. Now, how do we see X-rays? How do we see CT scans? Images, they show tissue density that we measure in Hounsfield units. Hounsfield units. So it can be hyperdense, it can be isodense. Hyper means zyada, iso means barabar, hypo means kam, right? So hyperdense structures like bone, calcium, blood, that will be seen. Isodense means soft tissue structures which will be similar to the surrounding structures. For example, muscle. We have Hounsfield unit of plus 40 to plus 60. And hypodense, that is dark, like air, fat, you can all see here. And in the images also you can see this part, this is air, minus 1000. This black, air. Hypodense. This is omentum, peritoneum, all that thing. This is isodense, right? So As I said previously, we take multiple X-rays and then we convert it to a 3D image, which is known as CT scan. A single CT scan captures hundreds of individual X-rays projections, which are then reconstructed by powerful computers into precise cross-sectional imaging. And these days we have so good CTs that we can do sections of less than 1 mm. So we can pick up lesions whose size is less than 1 mm as well. So how is a abdominal CT scan acquired? As I said previously, patient positioning, patient would be lying supine. As you can see in the image, this young lady is lying down on the console. And after that, the couch moves inside that machine, and there's a X-ray beamer which rotates around the patient. And it hardly takes around 2 minutes or 1 minute to acquire it. And then we have some contrast agents. I'll be talking about it in later slides. But broadly speaking, we have two types of contrast. Either it is enteral or it is parenteral. Enteral, as you can understand, via GIT, which can be oral, nasogastric, rectal, right? And the other thing is parenteral, that is IV. And then we do MPR, as I said, multi-planar reconstructions. We reconstruct the images of X-rays into axial section, coronal section, and sagittal section. We'll be talking about it. So the timing is key. Each phase that I'll be talking about in next few minutes would have a specific duration that, okay, now you give IV contrast. After this much of seconds, you acquire this phase, and then this phase, and then this phase. So timing is the key. If you miss that timing, you won't acquire the CT scan in that particular time frame, and you might miss the lesion. And I'll come to that in one of my few last slides. So each phase of CT imaging is precisely timed to capture contrast enhancement in different vascular and tissue compartments. And understanding the blood flow and contrast distribution is very important. In one of the sessions in pancreas, Ms. Komal talked about pancreatic protocol CT scan, where she mentioned 3 phases, if you remember. Can anybody name those 3 phases? Though one of the phases was wrong, I thought I'll correct it in my session. Can anybody name all those 3 sessions? The names that she took. So everybody was sleeping, it seems. So she named early arterial phase, pancreatic parenchymal phase, and portal venous phase. The early arterial phase is not a part of pancreatic protocol CT scan. It is a part of triple phase CT scan. We'll be coming to it later. So pancreatic protocol CT scan has pancreatic parenchymal phase and portal venous phase. Yes, these 2 phases that we take. That's how we know. For example, if you have to study the anatomy of liver, any lesion in liver, so you have to see in the portal venous phase. Why? Can anybody tell me the blood supply of liver? Anyone from the audience? Portal vein. Portal vein supplies 80% of the blood to liver. Hepatic artery supplies 20%. So obviously, the blood is getting more supply from the portal vein. So if you have to study vascular relations of liver, you'll be studying in portal venous phase and not in arterial phase, right? Just like that, any other thing, for example, pancreas. Pancreas has blood supply from artery only. That is why you acquire phases in artery if you have to see any lesion in pancreas. So this is very important. And different organs exhibit unique enhancement patterns guiding this diagnosis of specific conditions. So now, coming on to the phases of abdominal CT scan. The use of IV contrast allows for dynamic imaging where scans are required at specific time points. And these time points you see non-contrast. We don't give any contrast, we just take a plain CT scan. Why do we take non-contrast? Because in case there is some abnormality which was there previously and we cannot pick it up and we cannot distinguish it from the arterial phase or maybe portal venous phase, we can very well go back to the non-contrast phase and see whether it was present there or not. That's how we differentiate whether it is actually enhancing or it was there in the non-contrast phase as well. I have examples, don't worry. Arterial phase, we take the contrast, we take the imaging acquisition in 20 to 30 seconds after giving the contrast. Venous phase 60 to 70 seconds and delayed phase 5 to 10 minutes. Now this arterial phase has further division into early arterial and late arterial. Early arterial is done at 15 seconds and late arterial is done as 25 seconds. Early arterial is mainly for CT angio. You must have heard patient is bleeding. Let's get CT angio. only vessels are highlighted in that. Only vessels you can see, no organs. However, in the late arterial phase, you can see other organs which are supplied by the arteries, right? Then the venous phase and the delayed phase. So why we need a non-contrast phase? It is very crucial for baseline abdominal CT examination. Here you see three things mainly, A, B, C, air, blood, calcification. You three things you have to see. Even a non-contrast imaging can tell you whether your patient is bleeding or not. Mind it, even a non-contrast CT scan can tell you whether the patient is bleeding or not. How? Blood will be hyperdense. Its HU would be somewhere more than 300 plus me. And then obviously air you can see. Can you see this black part? So that's not air, that's fat. Why I'm telling this is fat? ये abdominal wall है. ये abdominal wall है, ठीक है? This is the abdominal wall here. So one more thing that we'll talk about it. How do you, why I'm saying that this is non-contrast phase? Somebody can question it, this is arterial phase. Somebody can question it is venous phase. Somebody can say it is delayed or equilibrium phase. So let's see. Can you see this structure? This is aorta, right? Just besides this structure, this is IVC. This, right? एक पेपर दोगे प्लीज, मैं थोड़ा एक्सप्लेन करूंगा. ये एक्सियल सेक्शन होता है. दिस इज द एक्सियल सेक्शन. नवनीत एक पेपर देना, A4 शीट कुछ भी दे देना. हम देखते कैसे हैं एक्सियल सेक्शंस को. दैट इज वेरी इंपॉर्टेंट. दैट इज हाउ यू सी. Suppose this is the body of the patient. You have taken multiple sections, right? Now what you are doing is, imagine you have taken a section here, and then you have rotated the body like this. You have taken the section here and you have rotated the body like this. That is why vertebra is posterior, because the patient is lying like that. Vertebra is posterior. This part is anterior abdominal wall, it is anterior, right? And see, for you, this is left, this is right, but you are seeing the patient from in front. That is why the patient's right is your left. We all know where is liver. Liver is on the right side. This is the liver. This is spleen. These are two kidneys. This is the vertebra. And this is aorta, as I said, and this is IVC. You cannot see any enhancement here. Can you? Can you see any whitish thing here? No. So this is a non-contrast phase, right? Coming on to the arterial phase, as I said, 20 to 30 seconds post IV contrast, we acquire it, during the peak enhancement. The timing is crucial, obviously, for various arterial structures and detecting the hypervascular lesions. So how does it help? It helps in vascular clarity. We can know whether the patient is having normal arterial anatomy or not, or whether the patient is having any arterial dissection or anything like that. We can diagnose few lesions like HCC, which are hypervascular tumor, NET, neuroendocrine tumors, which are also hypervascular. So these which are hypervascular tumors obviously will have more blood supply, so they will enhance more than the liver, normal liver parenchyma. Then anomalies, as I said, dissection, aneurysms, and organ enhancement. For example, in pancreatic parenchymal phase, I said pancreas will be enhanced. If you see here, it's already labeled. This is the IVC, this is the aorta. Aorta is white, aorta is white, IVC is not. This is the arterial phase. Now, in venous phases, so you don't always get the exact timings. There might be a possibility that the person has taken a scan between an arterial and venous phase, so you'll be confused, okay, which phase is this? So how to differentiate that? One thing, keep in mind, arterial phase, aorta enhancement would be like the vertebra. Can you see? Aorta will be as white as vertebra, it is arterial phase. Just one word. And the other dots that you see here, these are also the arteries. This is probably the hepatic artery. This is the SMA. SMA here. We'll be coming to it. Then the venous phase, around 60 to 70 seconds later, post IV contrast, optimal for solid organ enhancement. For example, I told the liver. Liver is well enhanced in it. And leisure characterization, obviously, because now imagine, we have talked about HCC. HCC is hypervascular tumor. So if I give a contrast and it is getting more blood supply, it will enhance on arterial phase. But the other liver tumors, for example, as Navneet said, colorectal mets, these are hypovascular, right? So once you do a portal venous phase, you will not see any enhancement in that. However, the liver will enhance normally because most of the 80% of the liver's blood supply is via portal vein. So liver will enhance normally, but this lesion will not enhance. So that's how you can characterize the metastasis. Metastasis from anywhere in the body to liver except neuroendocrine tumor would be hypovascular. But neuroendocrine tumor, since it is itself is a hypervascular tumor, its metastases are also hypervascular. The peritoneal thickening you can see, you can differentiate it with collection, lymph nodal masses you can see. This is aorta, this is IVC, both are equally white. Can you differentiate it from the arterial phase now? Yes? We'll move ahead. Anybody can tell me what this structure is and what is this white thing inside it? This I'm telling you, this is air. This is air fluid level. Yes, it is stomach. And we have given enteral contrast, oral contrast we have given. Right? This is a CT scan acquired post-oral contrast. Then the last phase, which is sort of less important, is equilibrium phase. It is taken 3 to 10 minutes post-IV contrast, allow for, so in this, the contrast diffuses extracellularly, extravascular spaces. So you will not see that much enhancement in artery or vein. However, the tissues will be enhanced. I'll just show. Can you see this liver? Now compare this is non-contrast. Compare this liver with this liver. Can you see this is more white, right? And these both artery and vein are equal in color. The important thing here is that once you give IV contrast, it gets excreted by a kidney. Agreed? So once the contrast goes into kidney, it will be excreted into the ureters. If you are seeing any contrast in the ureters or renal pelvis, it is equilibrium phase. This is the renal pelvis. Yes or no? Can you see? This is whiter. See the other ones? Isn't it dark? Isn't it white here? Isn't it white here? So it is the equilibrium phase. Right? These are the 4 phases of CT. So we should always follow a systemic approach so that we should not miss anything, though it is more of a radiological job. So I'll just skip it. I have few images to be show. Yeah, sorry. So we are coming from above to below, right? The blackish thing here you see are the lungs, bilateral lungs are there. This orange thing is liver. This red thing is spleen. And this thing, pinkish thing, between the liver and spleen is stomach. And then the vessels are there, IVC, as I told, the hepatic vein centers, the IVC. So you can see right hepatic, you can see middle hepatic, you can see the rectus muscles here, right? These behind is the vertebra and then the quadratus muscles. You can see this another pinkish structure is esophagus. This is aorta. So we are going below and we'll be walking through the abdomen. Everything is marked here. So you can see as we are going below, we are seeing more and more things of that organ. For example, stomach is increasing in size, liver is increasing in size, the spleen is increasing in size. Now we can see the left kidneys is starting to get visualized. As you all know that left kidney is above the right, above than the right kidney, contemporary right kidney, because right kidney is being pushed by the liver downwards. You can see very well the aorta and the IVC. These things that you see, can you see these two things here? These are the cruras of the diaphragm. I think it will be too much in details, so just skip it. So we are going, you can see the portal vein here, right portal vein is being formed with the left portal vein. Bilateral kidneys are being seen, stomach. So this is the stomach here. This is the spleen. This purplish thing is pancreas, right? This purplish thing is pancreas. Just behind the pancreas lies the splenic vein. You can see here. I have a lot of images. We'll be seeing it. So now you've started seeing the small bowel also now. You can see the psoas muscles, small bowel, and then we enter the pelvis. I think that will be more than enough. So this video is a CT scan video of a non-contrast phase. You can very well see that there's no contrast in the aorta. This is the heart you're seeing here. Liver started appearing. This is the aorta. This is the IVC. No color in any of these. These are all the bowels in here. Bilateral kidneys are there. Small bowels. Non-contrast. Are we okay with it? This is the arterial phase image. You can see the aorta is white. These vessels are of heart. So heart is also white because arteries arise from heart. This is as white as the vertebra here. You cannot see any whitest thing in the IVC. These things that you see, you just run it again. Yeah. I need to stop it. Can you see this part, this whitish thing? Can you see it? This is the hepatic artery here. This thing, aorta, giving rise to celiac axis. As we all know, celiac gives rise to common hepatic artery and splenic artery and left gastric artery.
Your voice is not audible.
Okay. So we see the arterial relations. We can see the renal arteries as well. This aorta now dividing into bilateral iliac vessels, then further dividing into external and internal iliac vessels. So this is an arterial phase for you. It is as white as vertebra. कुछ issue हो रहा है क्या? हाँ? उधर ये केस. नहीं मेरे को इसकी वीडियो नहीं चाहिए, इसकी ऑडियो नहीं चाहिए, इसकी ऑडियो नहीं चाहिए मेरे को. So this is a venous phase. Both artery and vein will look white together. You can see this is the aorta. Aorta, IVC here, portal vein can also be seen. Bilateral kidneys. Right? This is the portal venous phase. And then we come to the delayed or equilibrium phases. So this is a PET scan, so that is why you are seeing it from well above, from the neck. You can see bilateral lungs are here, trachea, esophagus, you can see. Do you want me to show it again? No? Yes? Okay. Trachea has air. That's why you're seeing this structure with air inside it. This is a trachea. Just behind is esophagus. And on the right side of esophagus you can see is aorta. Very good. Is it abdominal aorta? Thoracic aorta. So you just saw that the trachea divided into two. This is the right bronchus here. This is the left bronchus here. Right? And then we enter the abdomen. The bilateral lung veins looks clear. You can see stomach, esophagus, stomach, liver. This structure you see here is the splenic vein. It's going towards the spleen. So only two structures are horizontal. Only two veins are horizontal in body. First is splenic vein. The other is renal vein. It's also horizontal. Only two veins are horizontal in the body. In abdomen I'm talking about. So this is the splenic vein, and just in front of splenic vein lies your pancreas. We'll move forward. These are the two other sections. We have learned about the axial section. So now one is sagittal section. You divide the body like this, and you are seeing, you divide the body like this, and you are seeing from this angle. And the coronal is, you divide it like this, and then you're seeing from the front. I'll quickly play a video. You see, you go from right to left or left to right, from one side of the body to the other side. You go in sagittal section. Can you understand it? This is a coronal section. From forward to backwards or backwards to forwards, you do a CT scan. So you see ribs. Now you start seeing liver, and the heart is also above it. You can see stomach very well. So you have to see all these things in multiplanar reconstruction in all the sections to better characterize the lesion and its vascular relations to the arteries and vein that it supplies. So that is why it is important to see all the things in the 3 dimensions. So this is a picture of arterial anatomy of liver. We are more interested into the arterial anatomy of liver actually, as a GI surgeon and HPB surgeon. So you see, this is aorta. It has just exited from the hiatus, aortic hiatus. I showed you bilateral this crust things, no? These are the 2 crusses. This is the celiac axis. It gives rise to left gastric artery, splenic artery, and the common hepatic artery. You better see it in the CT image. This is celiac trunk. It is giving rise to CHA and splenic artery. The left gastric artery arises just perpendicular to it. So you cannot see it in a still section. You have to see multiple sections in that. So in this video, I am demonstrating the origin of celiac, and I'll be talking about it now. So it goes. You see, this part, chotu sa, is a left gastric artery. I'll be coming back again. This is the celiac. You'll trace it to this is the common hepatic artery here. And here you saw splenic artery. I'll just quickly run again. Yeah, just behind the pancreas, you see this dot? You see this dot? Just follow it. See, it is going towards the spleen, right? And it is originating from celiac axis. I think that will be too much for you guys. That's fine. We'll come to the portal venous anatomy. So we all know that supramesenteric vein, splenic vein joins to form the portal vein. You can see in the okay, which section is this? Axial, sagittal, coronal. Coronal, very good. This is not a part of quiz though. So this is the portal vein, splenic vein, and SMV. Again, I have a video of portal venous anatomy. So you can see this is the right portal vein, left portal vein. This is the right portal, right anterior, right posterior, and this left portal joins to form the portal vein. It's going down and down and down. It will join the splenic vein. So here it joined the splenic vein, and this is the supramesenteric vein now. Understood? It's another picture showing right anterior. RA is right anterior, RP is right posterior. This is the right portal vein, this is left portal vein. Together joins to form the main portal vein. A few things about as Navneet talked about sections, sectors, segments of the liver. So you can actually see which segment is involved in a CT scan. So this is how you differentiate, this is how you divide the liver. Segment 6, segment 5, segment 4B, 3, 1. So you can see that very well in the CT scan. So now we'll talk about how do we diagnose a lesion in CT scan. So you see there are 3 images here. This is a which phase? This is a which phase? Which phase? Non-contrast. This is? And this is? Venous. Very good. So we have 3 phases now, and these are the 3 phases that we do normally in a CT scan. If somebody really wants to pull your leg, he'll ask you delayed phase. Otherwise, they won't ask. So, can you see any lesion here? It is. You can see a lesion which is slightly hypotense to the liver. Though it is not enhancing, the liver is not enhancing, still you can see a lesion. Something is there. We don't know what is it. Now, we gave the contrast. We see some whitish dots at the corner and the periphery of the lesion. Right? What is this? This is known as peripheral nodular puddling, which is characteristic of hemangioma. And if you further go into the portal venous phase, it has centripetal filling. It is filling inside. Here it is less, here it is more. It is becoming more and more here. Right? So that's how we diagnose hemangioma. Another lesion, another picture of a CT picture. You see a lesion here. This is arterial phase, obviously. You see this is enhancing, arterial phase hyperenhancement. In the venous phase, you see that it is hypoenhancing. This is more white than this, but it has a capsular enhancement. And in the delayed phase, there is no enhancement at all. All the washout has been done. This is radiologically diagnostic of HCC. So let's see this image. Suppose we have only done a non-contrast image, and we say that liver is normal. Do you think this is normal? Everybody would say it is normal. Only if we give a arterial contrast. We see the lesion is arterial, it is hyperenhancing in arterial phase. It's known as APHE, arterial phase hyperenhancement, characteristic of HCC, and portal venous washout. In the portal venous phase, you cannot see any enhancement. And once you do a delayed phase, you will see that the contrast has totally washed out. So that is the importance of doing all the phases in liver. This is known as TPCT, triple phase CT scan of liver, of abdomen, liver protocol. If we had not done it, we would have missed. There's a still scan of a patient with pancreatic mass. You can see a hypodense mass here, and a characteristic sign that you see in this is CBD and this is PD, pancreatic duct. Both are dilated. Double duct sign is seen in periampullary carcinoma and CHOPs. So that's this thing. So let's test what we have learned till now. Are we ready? Yes. I am not ready. Okay, so tell me. Identify the phase of CT. Quick. Raise your hands. Raise your hands. No. Yes, Rekha. Arterial phase. Very good. This is the arterial phase. One chocolate to her, please. Identify the marked organ. Raise hands. Yes. You. Spleen. Give her one chocolate, please. हाथ उठा के रखना, पता लगे किसी और को दे दे. So coming on to the next phase, next image. पता है. Identify the phase of CT. Hand raise. Yes. Give her one chocolate, please. This lady in green suit. Identify the section. Axial section. Who answered it actually?
Somewhere from here, I guess.
Okay, let's skip it then. The next image. Phase of CT, hand raise please. Yes, Shelly again. I think you are Shelly, na? This lady. Venous phase, yes. Venous phase. Ek aur de do yaar. So now we have a 3 marked structure in this. Raise hands again. Identify the marked structure. IVC. Good. Deepak brother ko do. This one? Stomach. Give to Rupali. This one? रेखा, रेखा, एओर्टा. आपको हाथ उठाना है, मैं तभी देखूंगा. मेरे को जब से पहले जिसका हाथ दिखेगा मैं उसको दूंगा. आप तो उठा के रखो. आप नहीं, नीचे करके ऊपर करना है, तब दिखेगा. नेक्स्ट इमेज पे चलते हैं. This is a tricky one. Identify the phase of CT. बताओ. Delayed phase. Good. Deepak brother. Identify the marked structure now. ये शायद मैंने दिखाया नहीं, इसलिए किसी को पता नहीं होगा. हाथ उठाओ, हाथ उठाओ. डबल डक नहीं. गॉल ब्लैडर. दे दो ना. अरे मैं 24 मंगवाया था. कोई बात नहीं. Next question. Identify the phase of CT. Quick, quick. Hand raise, hand raise. Arterial phase. Give to one ma'am, one to ma'am, please. Now the mark structure. It's a tricky one. बताओ. बताओ सुनैना सिस्टर. सुनैना सिस्टर. दीपक ब्रदर. ऐसा में भी नहीं है. आप बताइए. Celiac. Rupali. Sorry, who answered it? मैम यू डिड नॉट पिक अप योर हैंड. किया था तो दोनों को दे दो यार, कोई बात नहीं, बहुत है हमारे पास, बहुत है. फेज अभी तो सबको पता है, मैं इसके लिए चॉकलेट नहीं दूंगा. क्लासिकल साइन बताना है, मैं वीडियो रन कर रहा हूं, जो आंसर देगा उसको 2 देंगे. इसके एरो को मत देखना, वो ट्रिक तुम्हें गुमराह करने के लिए है. I'll keep my pointer though. See this part? See this part first, and then see this. Double duck sign. Again to Rupali. So, why it was important? इनको भी दे दो यार. कितनी चॉकलेट्स बची हैं? दे दो, उनको भी दे दो. कितनी बची हैं? अब ये बताओ कितनी बची हैं? जो सुबह के सेशंस हुए हैं उसके सवाल पूछूंगा ना. 4-5 है ना. तो ये बताओ, लैब कोली में रेखा ने बताया था प्रेशर कितना रखते हैं. रेखा विल नॉट आंसर. ऐसे तो नहीं. दीपक ब्रदर ने हाथ उठाया पहले. हाथ उठाना है, हाथ उठाना है, हाथ उठाना था ना. ब्रदर आपको बहुत मिल गया, कि वैष्णवी को देने दो यार. ठीक है. In one of the slides, I think it was yours only, she has mentioned about Vicryl plus. What is Vicryl plus? If anybody can answer. Which antibiotic? High hand raise. Which antibiotic? उसमें आपने जो पोर्ट वाइकल बताया था, उस वाइकल प्लस का पिक्चर था उसमें कौन सा एंटीबायोटिक होता है? एंटीबैक्टीरियल होता है. कौन सा? द नेम स्टार्ट्स विद टी. ओके, तो मैं बता देता हूं, चॉकलेट भी मैं ही ले लूंगा. ट्राइक्लोजान होता है. ट्राइक्लोजान. कभी जाके वापस पढ़ना दोबारा ओटी में. ठीक है. एक बहुत बार बीच में वैस्कुलर जब 6 करते हैं तो नीडल होल्डर का बात हो रहा था. नेम स्टार्ट्स विद सी. आई डोंट गेट कैस्ट्रो. नहीं, पहले क्यों बोलना, वही तो पूछना था. पूरा नाम बताओ. दे दो चॉकलेट सिस्टर को. ठीक है. तो आई थिंक आई डोंट हैव एनी फर्दर क्वेश्चंस नाउ. आई फॉरगॉट ऑल द अदर सेशंस प्रॉब्ली. है और चॉकलेट्स हैं. पीजे का एंटीरियर लेयर में कौन सा सूचर यूज होता है? पीजे पैंक्रियाटिक जेजुनोस्टमी का एंटीरियर लेयर में कौन सा सूचर यूज होता है? यस, यू मैडम. यू. हाँ तुम ही. आई मॉडरेटेड योर सेशन मैडम. आई फॉरगॉट. सोनिका. नॉन एब्जॉर्बेबल. नो. यस कोमल. फाइबोपीडियस डबल नीडल. परफेक्ट आंसर. गिव हर 1 चॉकलेट. खत्म है? और है? और बची है? खत्म है? चलो, anyways, ending this session, empowering your role, continuous learning for enhanced patient care. Thank you so much. It was fun teaching you guys. Thank you. Thank you, Shishir.
आप कर दोगे? थैंक यू. इनका सर का ठीक है. हमारे बीच में बहुत बहुत धन्यवाद डॉक्टर कार्तिक. नाउ वी हैव डॉक्टर दास विद अस. सर, आपसे रिक्वेस्ट है, आप एक बार कृपया कर आगे की तरफ आ जाइए. देखिए, बहुत लंबी कॉन्फ्रेंस थी, बहुत महीनों से तैयारी चल रही थी, और कोई भी इवेंट करते हैं उसके पीछे एक पर्सन जरूर होता है. अगर वो नहीं हो तो वो चीज़ नहीं हो. तो इस कॉन्फ्रेंस के पीछे डॉक्टर दास है. अगर ये नहीं है तो ये कॉन्फ्रेंस भी नहीं होती और हमें मौका नहीं मिलता. तो सर, थैंक यू सो मच, आपने हम सबको मौका दिया.
मैं थोड़ा सा आधा घंटा लूंगा आप लोगों का. थैंक यू वेरी मच. My fundamental thinking is very clear. We are all in a team. Without development of each section of the team, it's like a chain. If you break one chain, one kadi, the chain is out of order. So if you have to look for development of everybody. Normally what I observe is in any of the conferences, everybody focuses on the doctors, surgeons. But whenever you are in the OT, where you are operating, you realize that without the nursing staff, without the allied professionals, without the technicians, without even the cleaning persons, nothing can succeed. We do a 10-hour surgery and if the person doesn't know how to handle the water and gets infected, वहीं से instrument निकाला डाला फिर उसी instrument में wash करने के लिए दे दिया, your entire thing is gone. And in a society everything is divided. All cannot do everything. So it has to be divided, every part has to develop. So that's why we in Ihpba, in the International Hepatopancreaticobiliary Conference, many societies, and in IASG last year. So they also do, we also do, we decided that all of us have to develop. So this time we thought, we prepared 3 months back, but time flew like anything. And then here we are ending after 3 months of preparation. So what we decided, then developing each section separately doesn't help. Because while we operate it, it's not that the sister works there, then finishes, goes home, the doctor goes home, the cleaning man goes on. It is an integrated thing. So the teaching, the discussion has to be integrated. This was the first attempt where we thought that we will present something, the surgeon will present the surgery, the supporting staff, the OT manager, he says about the OT preparation and use of instruments. Then there will be discussions. Like what you did in CT scan. When I was in Global Hospital, Hyderabad, I know we were operating on a case of liver tumor. We removed the liver tumor. We are coming out, and the sister in charge was there in Coimbatore, not in Hyderabad. And she said, sir, it seems that there was another lesion. She had seen the CT scan. All of us had seen, but we are so engrossed in that big tumor, we forgot that there was a small one. If you had left that one, within 6 months, the patient will come back. And the sister said that, yes, possibly you have another one. Do a ultrasound. It seems like there is another one. We did an ultrasound. There was actually a tumor, and you carefully look at the CT, then yes, you can appreciate there was a small one. So educating everyone in the society, in a team, is essential. So I hope our attempt to do that has some success or borne some fruit for you people. If you have learned something, you have enjoyed, we are very happy. What I saw today is you saw the basics. You saw how things actually work out. And if you are really interested, my suggestion is you should be watching the real surgeries beginning to end. Not the procedure is important, but see what instrument is using and where, and what the assistant is using, what the sealants or the medicines they are being using during that surgery, what is ICG, all those things. If you want, you are most welcome to be present. You are already delegates of the conference. That we have not made any difference between the delegates of the faculties, the entire conference. So you can be there, watch, enjoy up to maybe to the lunch session and then go back. So, but since we have to arrange for that, all of you who are really interested, please tell Sister Ji we need a number to prepare for tomorrow. And I invite all of you, if you are free, then you can come to the mega mess. There are parikrama taxis, they will take you there. if you are interested and you are interested in cocktail, then you can come there. It is already raining outside. So thank you very much. But give a big hand for your organizers who have taken a lot of pain. Now I tell you a great difference. We planned that we'll have 200 our delegates, our people, our means the IHPBA people, the doctors, and 100 of you. But now your number is 125, our number is 120. So it is your conference, and it is a side conference for us. The biggest part is the director and the medical superintendent. They appreciated this one very much, and I think they suggested that next time any conference on surgical side, medical side should include the nursing staffs to that side. So that's a good thing, and if it occurs, I'll be most happy. And big hand to these three people who are standing there. Thank you. Please enjoy, and please do take your gifts. I have invited for morning, tomorrow morning. I said tomorrow you can come, sit down, enjoy the ambience, and then have your lunch. And you feel like you continue, otherwise you can go back home if you are free. It is a Sunday. I know it will be difficult for you to come. If you come, it will be definitely educating. What you have read, you will be seeing there being applied. Okay? Is that, you want to say anything? No. कौन सा मूवमेंट हो? कौन सा बच्चे? हाँ, क्या दूं? लाओ जल्दी।
एक बार सभी खड़े होके सर के सम्मान में एक बार जोरदार तालियां। आपके सम्मान में। आइए सर, आपके सम्मान में।
मेरे?
आपके
सम्मान में ताली बज रही है, एक बार से आपको समझ ही नहीं आया। अच्छा ठीक है।
सर ने एक बहुत ही बड़ी बात बोली कि मुझे बहुत प्राउड फील होगा कि अगर ये चीज़ें एम्स में इम्प्लीमेंट होती हैं, नर्सेज इसमें पार्टिसिपेट करती है, तो मुझे एक संस्कृत के कुछ एक श्लोक की लाइनें याद आती हैं कि यद्यता चरति शिष्यस्त तत्त्वदित्र जने सयत्त प्रमाणम कुरुते लोकस्त दनु वर्तते। तो अर्थात कि जो रियल लीडर होते हैं वो जो करते हैं उनको बाकी सोसाइटी फॉलो करती है। सर ने जो किया वो एक अपने आप में बड़ा काम है और आने वाली जनरेशन उसको जरूर याद करेंगी। मैं बुलाना चाहूँगा डॉक्टर कार्तिक को सबसे पहले कि डॉक्टर कार्तिक आप आए।
और ना इनके लिए कोई ताली वाली नहीं मारना, मैंने देखा पूरा दिन भर आप मारा।
डॉक्टर कैलाश भी हमारे साथ आ गए, तो डॉक्टर कैलाश आप भी कृपया कर ज्वाइन कीजिए।
डॉक्टर कैलाश प्लीज। अच्छा, उनका आज सुबह से फोन ही आ रहा है।
आप बैठ सकते हैं, सभी आप बैठ सकते हैं। थैंक यू सो मच। डॉक्टर कार्तिक सबसे पहले एक बार जोरदार तालियां डॉक्टर कार्तिक के लिए। डॉक्टर कार्तिक के लिए एक बार जोरदार तालियां। डॉक्टर यशवंत हमारे साथ हैं सुबह से, वो भी अगर मेरी आवाज़ आपको आ रही है तो डॉक्टर यशवंत अगर आप हॉल में हैं तो प्लीज़। थैंक यू। मैडम जोली अगर है मेरी आवाज़ अगर आपको सुनाई दे रही है, आप हॉल में हैं तो कृपया कर एक बार आगे आए। मैम जोली संतोष। हमारे बीच में मैम आप प्लीज़ आप भी आइए। जोली मैम प्लीज़, आप अभी जीआई सर्जरी में इंचार्ज हैं और आपके सानिध्य में जितने भी जीआई सर्जरी के स्टाफ हैं वो काफ़ी उन्होंने एक्टिव पार्टिसिपेशन इसमें किया है। इसके बाद मैं बुलाना चाहूँगा प्रज्ञा मैम, जो आपने काफ़ी समय मेन ओटी में दिया है और आपका सानिध्य हमें इस कॉन्फ्रेंस में भी प्राप्त हुआ। आप इसके लिए बहुत बहुत धन्यवाद। और आप भी, मैं देख रहा हूँ कि आप सुबह से कंटिन्यू हमें वॉच कर रहे हैं। अब मैं बुलाना चाहूँगा दयानंद जी को, जो सुबह से उन्होंने जो रजिस्ट्रेशन की कमान संभाले रखी और साइलेंटली सारी चीज़ों को प्रॉपर मैनेज करके रखा। और इसी के अलावा मैं साथ में दीपक जी को भी बुलाना चाहूँगा, और जिन्होंने सबसे ज़्यादा चॉकलेट भी अभी देखा आपने कि इस एज में भी मतलब आप परफॉर्म कर रहे हो मतलब कि भाई 20 साल के बाद आदमी छोड़ देता है ना, आज फिर भी पकड़ के रखी हुई सारी चीज़ें इतनी जल्दी से ग्रैप्स करके और फिर उसको बताया।
चॉकलेट आया कहाँ से?
कार्तिक लाए। हाँ जी, मैं मैडम सुनैना को बुलाना चाहूँगा। आप भी इसमें की ऑर्गेनाइजर की भूमिका में रही और आपका सानिध्य हमें बहुत ही मदन जो हम आपको सभी को 8 क्रेडिट आवर्स मिल रहे हैं तो उसके पीछे मदन का काफ़ी सारा एफर्ट्स है और सारा कोऑर्डिनेशन। जो आपके पास मैसेज जो आ रहे थे वो सारे मदन के हैं, शब्द मेरे थे। ठीक है, इसके अलावा रश्मि मैम अगर है तो यहाँ पे ठीक है। रश्मि मैम आइए, एक बार जोरदार तालियां रश्मि मैम के लिए भी। सो ऑर्गेनाइजिंग टीम की तरफ से मैं आप सभी का बहुत बहुत धन्यवाद करता हूँ। आपने पेशेंसली इतना सुना है और उसका फल आपको जरूर ईमेल के माध्यम से प्राप्त होगा। इन्हीं शुभकामनाओं के साथ आप सभी का बहुत बहुत धन्यवाद।
कनिष्ठ सर खुद भी जो बिहाइंड द सीन काम कर रहे थे, आप भी जाइए।
ओके ठीक है। मैं रिक्वेस्ट करूंगी जिसने अपने साइन नहीं किए, मेल आईडी नहीं लिखी, लिख दीजिएगा क्योंकि ई सर्टिफिकेट ऑनलाइन मिलेगा आपको। तो जिसने भी नहीं लिखा वो कर लीजिएगा। बाकी जैसे सर ने बोला है सभी लंच डिनर के लिए जा सकते हैं, 7:30 बजे से डिनर लग जाएगा। ऐसा कुछ नहीं है, सबके लिए डिनर रेडी है, आप सब जा सकते हैं। यहाँ से डिनर करके घर जाइए, 7:30 बजे शुरू हो जाएगा। इट्स इन मेगा मेस, हॉस्टल नंबर
मेगा मेस सभी जानते हैं और गैला डिनर है। ठीक है, बिल्कुल फील फ्री टू पार्टिसिपेट। मतलब जो भी है वहाँ अगर कोई सिंगल रहता है रूम में बनाने की कोई ज़रूरत नहीं है आज। ठीक है, वहाँ पे और एक बहुत अच्छा मौका है सबसे बातचीत करने का, कहने का मतलब है इन शॉर्ट, है ना।
और मैं एक बात और बोलूंगी, नीचे परिक्रमा खड़ी है, जो लोग डायरेक्ट वहां जाना चाहते हैं तो परिक्रमा सबके लिए फ्री है, वो आप लोग उस परिक्रमा का इस्तेमाल करके वहां मेगा मेस जा सकते हो। दैट इज स्पेशली मेंट फॉर द गाला डिनर स्टाफ। ठीक है, पैदल नहीं जाना, आप उसमें जाइए।
सभी को एक बार आगे की तरफ आना पड़ेगा क्योंकि सिटिंग में नहीं पॉसिबल नहीं है प्रैक्टिकली। आप आए पीछे। और इसको 2 पार्ट में कर लेंगे हम, ग्रुप फोटो को 2 पार्ट में कर लेंगे, 2 में कर लेंगे। नहीं आएंगे सर, सर ज्यादा है संख्या। इन केस किसी को किट नहीं मिली हो तो वो आप दयानंद जी से संपर्क कर सकते हैं। प्रोजेक्टर एक बार बंद कर दीजिए थोड़ा। हाँ, प्रोजेक्टर एक बार बंद कर दीजिए, थोड़ा उसकी रोशनी आ रही है। और हमारे प्रोजेक्टर एक बार बंद कर दीजिए।
अरे मैं भी रुक गया, मैं भी आ गया। जिस किसी को बैग नहीं मिला है कृपया करके बैग ले लें। आपको नहीं मिला है? ले लीजिए आप। चलो बैग लो।
चॉकलेट ढूंढ रहे सबके थैले में।
चॉकलेट दो सर को।
सर पेन ड्राइव भी ले लेना। हाँ जी।